for a nice academic feast in pediatric ophthalmology and strabismus. We begin with the first session here, which is chaired by Dr. Subhash Dadia, who is the professor at...
we are in live.
Okay, so shall I begin again?
Yeah, begin, no worries.
Okay, good morning everyone, the speakers and the delegates. I welcome everyone on the behalf of MOS and BOA for this academic feast on pediatric ophthalmology and strabismus on this bright Sunday morning. We are happy to have Dr. Subhash Dadia as the chairperson for this session, and he's a professor at Guru Nanak Eye Center and the president of DOS and a co-opted member of SPOCI. And Dr. Prasad Valimbe as the co-chairperson, who is a private practitioner in Pune. So now I ask Dr. Hemlata to take over.
Yeah, good morning, everyone. Welcome to the session on pediatric ophthalmology and strabismus. Our first speaker is Dr. Uday Naik, who is director of Navtesh Netralay, and he would be speaking to us on topical squint surgery. Dr. Uday Naik, please.
Hi, good morning all. Am I audible?
Yes, audible.
Yes, you are audible.
Loud and clear.
Oh, okay, thank you, sir. First of all, at the outset, I would like to thank Scientific Committee BOA for giving me this opportunity, and heartiest congratulations that you are so professional that we are starting on dot 9 a.m. So I am a opening batsman, and I would be talking on topical squint surgery. My slides are moving.
Take the arrow, click on the arrow.
Yeah, arrow only. Okay. So no financial interest. To begin with, a glass of wine and a good lunch, followed by a headlock and a quick surgeon were early day anesthesia. And this is how the squint surgery was started centuries before. So I am presenting nothing which is new. So this is a 21-year-old female who had history of squint surgery done her in left eye in her childhood. Hello. Her vision is 6/6 and 6 in both eyes, and she has 40 prisms of exotropia with minimum left hypertropia associated with left eye inferior oblique overaction. Her distant angles were more than near even after patch test. So I had planned both eyes squint surgeries in the form of both eyes lateral rectus recession of 8 mm and left eye inferior oblique weakening procedure. As the left eye was a resurgery eye, I had planned it under local anesthesia, and the right eye was planned under topical anesthesia. So for topical anesthesia is given with the help of 2% xylocaine jelly, which is inserted 15 minutes prior the starting of surgery. After that, the anesthesia is achieved with topical proparacaine 0.5% drops, which are put 2 to 3 times at 5 minutes of interval. To guard against the oculocardiac reflex, as you all know, we give injection atropine 0.4 milligram intramuscularly before the surgery, and throughout the procedure, pulse rate is monitored. So I am directly going to the video of this surgery. The patient is asked to look in extreme opposite direction of gaze in which the muscle which you are operated, like adduction in this case. Before touching conjunctiva, it is better to put a drop of paracaine and then touch the conjunctiva. The change here in incision is taken over the muscle. And to know that thing, topical brimonidine eye drops can be put just before starting the surgery, so that conjunctiva is blanched and we can see the brownish muscle mass clearly, so that we can plan our incision accordingly. Then next important thing is to hook. The hooking is always done very gently, as the muscles are having stretch receptors and any pulling would cause pain. So always it is better to hook muscles very gently. So there should not be any pulling while you do topical squint surgery. Then you can continue with your routine procedures like steps like half thickness muscle suture, then followed by full thickness one. That is, all those steps are very regular one. Even you can use Moody's forceps to fix the globe in this case. As soon as we cut or disinsert the muscle, the pain completely goes off, and patient is better as regards to pain after this step of cutting or disinserting. One important thing in topical anesthesia is like you have to give continuously vocal local anesthesia. That means you continuously keep on going talking with the patient, so that the patient's cooperation goes on increasing as the time passes by. We can give live commentary of the surgery as regards what stage of surgery you already are going are, how much time it will require to finish the job, how the patient is responding, he or she is feeling, whether she is having any pain. All such questionnaire you can go on doing, so that patient is more involved with you rather than in her pain, in her or his pain. So continuous vocal local is important, and this is the very important step. Like when we take scleral sutures, everything should be meticulous, as this is really a very ideal bite that throughout the pass the needle is visible. Here the new insertion site is exactly of the same size as the original insertion site. So here the muscle is reattached to the sclera exactly 8 millimeter from the original insertion, and muscle and the 6 vicryl suture knots are being taken. Surprisingly, we may think that maybe doing topical anesthesia, the surgical time will be more, but it is not. Actually, in this case, usually I take only 15 minutes for my one muscle, and in this case, also the time taken was just 17 minutes. So this is the new insertion, and after that we close with interrupted suture. I feel that is better in topical anesthesia squint surgery, uh, because we can put topical paracaine drops before touching the conjunctiva and take the sutures. So this is how it finishes the surgery. Now this is immediately after the surgery. As you can see the microscope behind, the patient is very comfortable moving her eyes, and the next picture is of 1 day post-op. So topical squint surgeries requirements, I would say that there should be motivated surgeon and equally motivated patient. Relatively fast surgeon would be more exercising this option of is hallmark, but there is no difference as such between cooperation from a male or a female. Anesthesiologist with a secured IV line is a must. And if you have your routine good seasoned assistant alongside you, it will be icing on the cake. But if it is not possible, don't lose your heart. Anesthesia at any point of time. So which muscles and which surgeries? Usually recti are preferred over the obliques. I personally have not operated any oblique under topical anesthesia. I know Dr.
1 minute.
Santhan Gopal sir. Okay, yeah. The simplest muscle to operate on is lateral rectus. Resection surgeries are more simpler than resections, although tenotomy's advancement and Fedden sutures have been done under topical. Topical surgery gives us opportunity to do on table adjustments, so we can achieve more perfect results, and there are no issues associated with injection and GA. But this is restricted or limited only to a special subgroup of patients, surgeries, and surgeons. Oculocardiac reflex is a constant risk, and sometimes we have to change the anesthesia. Literature is robust with proponents of topical anesthesia surgeries. So to take home, topical squint surgery is very much doable. Proper delicate handling and continuous vocal local is key to success. Standby anesthesiologist is must. On-table assessments and adjustments are possible, so we can achieve more perfect results and more smiles like this. Thank you very much.
Thank you, Dr. Uday, for that wonderful video demonstration of topical surgery. Now I invite Dr. Rishikesh Mai to speak about incisions in squint surgery.
Am I audible?
Yes.
Yes.
Okay, I'm just sharing my screen. At the outset, I would like to thank Bombay Ophthalmic Association and Maharashtra Ophthalmic Association for such a wonderful academic session and allowing me to be a part of this scientific deliberation. So the topic of my presentation is incisions in squint surgery. Like all surgeries in medical science, incision is vital even in squint surgery, and choosing the correct incision size and site gives a good surgical exposure. It simplifies the surgical maneuvers. It reduces the post-operative irritation and provides better post-operative cosmesis. One more point which we can add here is that if resurgery is contemplated later on, and if you have a good incision initially, perhaps we can use the same incision site for resurgery as and when required. So the aim of this presentation is to discuss the advantages and disadvantages of various incisions in squint surgery. There is nothing like one rule fits all. Different surgeons, they use different types of incision for similar surgical procedure based upon their experience, comfort, and also the patient profile. So basically there are three types of incisions we use for squint surgery. One is the limbal or Harm's incision. One is the paralimbal. Swan is basically a type of paralimbal incision, and fornacial incision or Park's incision. Coming to limbal incision or Harm's incision, here basically just a diagram to show how it is done. We give the first incision paralimbally, so that one blade of the scissor can pass in the subtenon space. The advantage of limbal incision is that at the limbus, the conjunctiva and the tenons are attached together. So we need a single incision, and tenons might not trouble us there, as it might in a paralimbal or a fornacial incision. After doing the limbal incision, we can give radial cuts so as inadvertent conjunctival tear will not happen. Some surgeons for two horizontal recti also use a single limbal incision like a 270 degrees peritomy.
Dr. Rishi, sorry, could you be a little more audible? Not able to hear.
Am I audible now?
Yeah.
Okay. So then I will just share a small video. This is actually an older video because I don't tend to use the limbal incision nowadays. Basically, we have to do the first incision paralimbally so that one blade of the scissor can pass underneath the subtenon space, and then you do a radial cuts to it, and then followed by hooking the muscle. The advantage of limbal incision is that we see most of the structures, any inadvertent cutting of any muscle tissue or ciliary vessel is usually not there. It is easier to learn and better. So in the initial phase of our practice, like when you are learning squint surgery, perhaps this will be the incision of choice. Also for older patients where chances of inadvertent cutting of the conjunctiva or handling of the conjunctiva leading to tearing of the conjunctiva is less. Also, for many of the surgeons for adjustable squint surgery, use limbal incision. The disadvantage is that we need to have a larger incision size, so chances of postoperative irritation, inflammation, corneal delen are more. Also, for limbal procedures like trabeculectomy, it may not be the incision of choice. So, where to use limbal incision is for beginners or trainees, resurgeries, pre-existing extensive conjunctival scarring for any reason, squint surgery or a buccal surgery, we might use this particular incision, and also for elderly age group. Coming to paralimbal incision, these are basically of two types. One is the swan incision like this, where you place the incision over the muscle and then you perform the surgery there. The advantage is that we might need a smaller dissection of the smaller incision size because you are directly approaching the muscle. But the disadvantage is if the surgeon is not well trained, then the chances of cutting the inadvertent cutting of the muscle fibers or the ciliary vessel is there. The other paralimbal incision is placed in between the limbus and the muscle insertion, and then the surgical procedure are performed. Here, the chances of inadvertent cutting of the muscle are lesser, but being closer to the limbus, the chances of post-operative irritation are definitely there. So just a small video about how the paralimbal incision is done. This is in between the limbus and the insertion of the muscle. First, you have to cut the conjunctiva, then go to the tenons, because especially in younger children, younger age group, the tenons might be thick. So we might have to dissect that. And then do a undermining of the tenons tissue, and then we approach the muscle or hook the muscle as per the requirement of the surgery. Another incision is the fornix or Parks incision, which is popular among the experienced surgeons. It is in the bulbar conjunctiva of the cul-de-sac in between the two recti muscles, two adjacent recti muscles. You place an incision here, and you can approach both the muscles with this. The advantage is that with a single incision, you can approach two muscles, and based upon the requirement of surgery, if you are approaching the recti muscles, you can extend the incision parallel to the fornix, or if you want to approach the obliques, which are more posteriorly placed, so we might have to use a parallel incision. Just a couple of videos to show. This is for the inferior oblique. We usually go in the inferotemporal quadrant, 8 millimeters posterior to the limbus, and then we place the incision here and conjunctiva followed by the tenons. And with a single incision, I can approach three muscles now: the lateral rectus, the inferior rectus, and the inferior oblique. Another video for the superior oblique. This was actually an incision which was placed perpendicular. This patient had already undergone a lateral rectus surgery somewhere else, and he was a case of a Brown syndrome. So we approached superotemporally. As you can see, the fornix-based incision provides hooking the superior rectus, but we have to go in the superior for the superior oblique, which is posterotemporal here. After stabilizing the superior rectus, we realized that the incision may not be adequate for performing the superior oblique. So we can extend the peritomy posteriorly, that is perpendicular to the fornix, and then apply a D-Mars retractor and get a proper exposure of the superior oblique muscle. And this helps in getting a proper exposure of the superior oblique here, and then hooking the muscle.
Rishi, we have a minute.
Yes, I'm just concluding. So advantage of this is that it provides less chances of inadvertent muscle injury because it is placed in between the two muscles, and two neighboring muscles can be approached with this single incision. And also the scar is not noticeable, postoperative irritation is less. However, the disadvantages cannot be, for the beginner, it may not be the incision of choice. And also for elderly age group, the posterior flap of the conjunctiva might not be retrievable later on. Just a word about minimally invasive strabismus surgery, or MIS. It's a newer technique which provides a small incision size. Usually, if you are beginning with this, the usual age group is 14 to 40 years. What is done is we perform multiple keyhole incisions close to the muscle of interest. And depending upon the tightness of the muscle or the thickness of the muscle, we can do more than one keyhole incision and then perform the surgery. Many of the surgeons, they don't close this, they leave it open because it is in the posterior part of the tenons. But it's better to close this with the Vicryl suture, which we usually use. So to conclude, this is the last slide. There are different type of incision of surgeon's choice, but there is no clear advantage of the incisions for squint surgery as regards complications, outcomes, and patient satisfaction. Thank you. Thanks a lot.
Thank you, Dr. Rishi, for the excellent presentation. Now I invite Dr. Chandresh Parekh, sir, for his talk. Sir would be talking to us on pearls and pitfalls in squint surgery. Dr. Chandresh Parekh, sir, please.
Am I audible?
Yes, sir.
Yeah. Good morning, everyone. I thank the organizers of BO and MOS for having invited me here today. I shall be speaking on pearls and pitfalls in the squint surgery. There is no financial disclosure. It has taken me 35 years to collect these pearls, which I'll be dividing in the pre-operative and the operative part. The pre-operative. The most important is that without doing the prism bar cover test of PBCT, one should not do a squint surgery. It is like doing a IOL surgery without doing the biometry. So it is very essential to do PBCT first. One should also tackle the vertical squint and obliques at the same time, because our goal is to straighten the eyes in all 9 cardinal position of gaze, and it also helps in correcting the slight over corrections in the horizontal squints. First, one should do the squint surgery and then ptosis. However, squint surgery should be second in case one is planning to do any refractive surgery or a cataract surgery, and one should first treat the amblyopia and then do the squint surgery. because angular squint may change after the cataract or the refractive surgery, but it should be done as soon as possible. A lot of time their patients are advised to do the surgery at the time of marriage, which I don't agree with. For a general ophthalmologist, when they should not operate, that is very important. What if the patient is less than 5 years of age because the surgical planes are not well defined? One should not operate vertical or oblique squints. Onyx approach, as Dr. Rishik has rightly pointed out, is a difficult approach. So one needs adequate experience with other approaches, and one should avoid resurgery and restrictive surgery till one has got sufficient experience. We have to counsel the parents about their apprehension about the GA and the surgery. Informed consent is very important because the court wants an informed consent and not a consent. And in this, one has to mention all the possible modalities of squint treatment and the common side effects and a serious side effect. I even mentioned that in my informed consent. The surgery charges are equivalent in Mumbai, at least people are, it would be equivalent to about 1.5 lakh rupees per muscle if the surgery lasts for half an hour to 45 minutes. Now let's go to the operative part. The atropine intramuscular is very important because there is more efficacious to prevent an oculocardiac reflex rather than intravenous atropine. Asepsis is very important because in Mumbai, one of the charitable clinic, for a cosmetic squint surgery, the patient developed end-op and required evisceration for a cosmetic squint surgery in an adult. One should have a surgical plan readily available like the IOL power right in front of you and revise the surgical anatomy. The only operating under in the ketamine without intubation not advisable because airway should be secured because ketamine causes the tongue fall and the respiratory depression. Peribulbar should be repeated if there is any pain because otherwise the patient will become uncooperative. The eye drops are very important because if you are going to operate 3 muscles in one eye, then the stickiness of the eye trap should not come out. It should be big so that one can see the sutures. The strip should be applied so that the stickiness is maintained, the eyelids are retracted, and it avoids the eyelashes coming in the field of view. The eye speculum should be with the solid plate so it keeps the eyelashes away and adjustable eye speculum. FDT should be done repeatedly for every muscle surgery to rule out any adhesions. Please remember, eyeball is suspended in the orbits. So one has to use one hand is occupied to stabilize the eyeball. So one has to use a marking ink, for example, to mark a point of insertion. And that it also helps us in reaching to the muscle because the muscle insertion or the recession goes very close to the medial and the lateral canthus. Fixation sutures should be used because the eyeball is suspended. However, the minus point is when you use the fixation sutures, the eyeball may get rotated, so your plane would get distorted. And while taking conjunctival suture, it will add to the difficulty. As Dr. Rishikesh advised, my suggestion is to do limbal approach because the scar comes on at limbus, which is the junction of two dissimilar tissues. When you hook horizontal recti, please remember to hook it from the superior side. Otherwise, especially for the lateral rectus, you'll be inadvertently hooking the inferior oblique along with it. The conjunctival separation, the muscle is very firmly attached to the conjunctiva. So when you recess a recti muscle, the conjunctiva also gets recessed. So for example, for a recession of 8 millimeter lateral rectus, one should recess the conjunctiva by about 15 millimeters from the limbus. I suggest to do sharp dissection to prevent the adhesions and not blunt dissection with the birds. One should have the tissue respect and avoid repetition of the surgery. Then only the eye will respect you as a surgeon. I use a single arm needle and I do a single pass, full thickness pass through the muscle. In a recession, one should not cut flush with the sclera because we need to hold the muscle stump to rotate the eyeball. So it should be about 1.5 millimeter from the insertion and mark with a blue dye so that your one hand is free to pass the needle. The scleral pass, one should be able to see the passage of the needle through the sclera, and I prefer a radial or a pass right angle to the limbus. And when you are tying the knot, you should rotate the eyeball back towards the muscle so then the muscle is in a proper position. And at the end of recession and resection, one should see where the center of the muscle is lying. Otherwise, you'll end up with under or overcorrection. In resection, I prefer muscle clamp because you have to pull the muscle toward the limbus, which is much easier with the muscle clamp. Remember, please get the muscle insertion is the thinnest portion of the sclera. So again, you leave the muscle stump so they can pass just superficial to the sclera, so the superficial fibers of the sclera. And again, please take central sutures. Otherwise, the lagging will cause undercorrection. And whenever you are starting the conjunctiva closure in a GA, switch off the AC so that patient comes out of the GA fast. Conjunctiva closure is very important because otherwise it will lead to a poor cosmesis and parents will be unhappy with it. I don't put a patch on the eye unless there is a corneal epithelial erosion. And antiemetic is must because a lot of patients have the vomiting post squint surgery. So remember that the pulse which over 35 years I've divided into intra and operative, but I'll again repeat, if you don't have a prism bar, if you're not on the prism bars examination, there should be a bar on the surgery and one should not operate. Thank you again for a patient listening.
Thank you, Dr. Thank you, Dr. Parekh, for sharing those words of wisdom. They're very helpful, I'm sure, to all of us with for so many years' experience. Now, invite Dr. Vaishali Une to give her talk on spectrums of monocular elevation deficiency. Dr. Vaishali, I think you're muted. Dr. Vaishali?
Yes, yes. Just no, yeah. Yeah. Am I audible?
Yes.
Yes.
Good morning, all. And at the outset, I would like to thank BOA, MOS, Lani sir, Rangini ma'am, and Hemalini ma'am, and Prachi, Dr. Prachi, for inviting me. And I'm really honored to be on this share screen with so many stalwarts. So very good morning. And the topic is quite close to my heart. And I thank the organizers for giving me this topic. Monoocular elevation deficiencies spectrum. So it is characterized by the unilateral limitation in elevation. The causes may be either paretic, restrictive, or it is a combination of both. We all know that earlier, when we were PGs, we were taught that as the name was coined by Dr. Dunlap as double elevator palsy. But now we know very well that it was a misnomer because it is not just caused by inferior oblique and superior rectus muscle palsy, but then because of the restriction element also. MED can also be associated with the Marcus-Gunn jaw winking phenomena. It is not a hereditary condition, rare, can be congenital or acquired. And the clinical features are here. I've got the pictures. Primarily, there is a large hypertropia in primary position. There is limitation in elevation in adduction as well as in abduction. If there is a ptosis, the child may have chin up, that is abnormal head posture. There is also concurrent strabismus, usually exotropia, presenting in 30 to 50% of patients. Then there can be a combination of ptosis and pseudotosis. For the postgraduate students, I would like to explain that pseudotosis is that ptosis which gets corrected after we do the cover test. So it is not a true ptosis and it doesn't need surgery. Only the cause, when you take care of the cause, then the pseudotosis gets corrected. Bell's phenomena is usually very poor in such patients, and we may have to think about while surgery, this is important to look upon. And when the eye is fixating with the normal eye, there is pseudotosis and hypertrophy of the ptotic eye, whereas when the paretic eye is taking up fixation, the normal eye takes up the hypertropia. A small video to show about the Marcus-Gunn phenomena in this MED patient with hypertropia. The child has hypertropia with ptosis, and on the jaw winking phenomena, there is. So what are the types? First is the type 1 is the restrictive, where there is primarily inferior rectus fibrosis. The patient may be orthotropic on primary gaze. The force duction test, which is very important in MED cases, has to be done, and subsequently I'll tell you the importance. So force reduction test in this cases is positive because of the restriction of the inferior rectus, and Bell's phenomena is poor. Then the second part is paretic, where it is secondary to the superior rectus palsy. Here the force reduction test is negative, and hence why we have to know this, because the management totally depends on which type we are dealing with. And the third type usually has the supranuclear involvement, and it is a combination of both. So the management differs. Most important, like already told by the previous speakers, and as Parekh sir had also told, the cover test is in this case, especially in MED cases, is very important, because especially I would like to tell my oculoplasty friends that if in a case of ptosis, we have to do the cover test and see whether the ptosis improves on the cover test. So this is primarily for the postgraduates that don't go the labeling, diagnosing it as just a case of ptosis. It may be a case of MED. And then the next, another important is the force reduction test. So force reduction test is done. I'm afraid the video is not so the force reduction test is by holding at the limbus and moving towards the action of the muscles. And if there is limitation or you get restricted movements, you get label it as force reduction test positive and or negative. Again, there is another important test, that is the force generation test, where we ask the patient to the eyes is held, but the patient is asked to move in the direction of the muscle, and a tug if it is present or if it is absent. That way, accordingly, we know the power, again, to differentiate between the paretic and the restrictive pharmacopoeias. Coming to the differential diagnosis, Brown syndrome is very close because it is elevation, defective elevation in adduction. But here in MED, there is elevation in adduction and limited elevation in adduction as well as in abduction. Inferior oblique palsy is also one of the differential diagnoses. The hypotropia would increase on the ipsilateral head tail. Blowout fractures commonly seen in casualty areas when there is tissue entrapment. So in those cases, force reduction test is positive. And superior oblique overaction, we get typically A pattern exotropia. In congenital fibrosis syndrome, we have it is bilateral, congenital, and all the muscles are involved. Hence, along with the elevation deficiency, we have limited abduction and adduction also. But there is ptosis also. So it also comes very near to MAD, to get confused, and the adherence syndromes. So management, like I have just told initially, that it is primarily surgery. The type of surgery depends on the cause of elevation deficit, and if the child is having amblyopia, also we need to repair the ptosis also and correct the squint surgery. Like the previous speaker said, there is no hurry, squint just to do the, in this case, I would say that there's no hurry to do the ptosis surgery. Find out whether the underlying squint is there. If the squint corrects your ptosis, then we need not go further. So
we have a minute.
Okay, okay. So it's just about if FDT is positive. Usually in the inferior rectus recession helps the pseudotosis also. If not, then when it is FDT is negative, we need to have that NAPS procedure. I'll just go on to the NAPS procedure, where the medial and lateral recti are sutured at the superior rectus border. Then there is an augmented NAP procedure, that is conventional NAP with the posterior fixation sutures. There is a modified also, where only the superior half of the medial and lateral recti are given sutured near the superior rectus. So after doing a primary surgery, we may have to deal with the element of ptosis. So if LPS action is absent, a sling surgery is done. If it is associated with Marcus guntosis, a crutch spectacle can be used for or disinsertion of LPS and followed by sling surgery. So the take home message is, in all cases of ptosis, examine the eye for evidence of hypotropia. do cover test. I keep on saying this to my residents that always do cover test and look for improvement in ptosis. Next is that see for in detail for the extraocular muscle movements. That will give you a lot hint about what kind of squint you are going to look at, and force duction test is important in planning the surgical options. So I'm very sorry I couldn't have the videos of my surgical. I just could put the photographs. So thank you for patiently listening, and thank you again for giving me this opportunity. Thank you.
Thank you, ma'am, for the excellent talk, especially highlighting the importance to rule out pseudotosis and to look for the differential diagnosis. Now I invite Dr. Sandra Ganesh, who is the senior consultant at Arvind Eye Hospital, Coimbatore, for her talk on interesting cases in superior oblique palsy. Dr. Sandra, please.
Good morning, everybody. Thank you for being there. Thank you so much. Good morning.
Good morning. Are you able to hear me?
Yeah,
Yes,
we can hear you.
Yes. So many thanks to the Bombay Ophthalmic Association and the Maharashtra Ophthalmic Association for this kind invite, and especially Dr. Prachi for her very personal invitation. So today I'll be talking about interesting case scenarios in superior oblique palsy. So superior oblique palsy is the most common form of vertical strabismus, though the management is challenging due to the wide range of operative and intraoperative considerations. The choice of procedure depends on various factors like the amount of hypertropia in primary gaze, bilaterality, torsion, occupational and functional needs of the patient. And so I'll be illustrating this with the help of a few case examples. The first is that of a 24-year-old male with a sudden onset of binocular diplopia. There is no trauma. The best corrected vision is 6/6 with the anterior segment and fundus evaluation being normal. And as you can see in this picture, he has around 25 PD of R/L in the primary gaze, and that increases in the left gaze and the right tilt. So the diagnosis is quite straightforward, being that of a right superior oblique palsy. He did not have binocular single vision. This is a case of a congenital right superior oblique palsy because, and why does he present later? It's mainly because they lose the vertical fusion amplitudes later on, and hence they present later with the diplopia. So the intraoperative force duction, there is no tension or laxity. Hence we did only a recession of the right inferior oblique muscle. So postoperatively, he was able to fuse the residual 10 PD of R/L that he had in the primary gaze, and the near deviation was only 2. So it was good that we did not go ahead with the 2 muscle surgery in this patient, because then we can expect a reversal of the diplopia. The second patient is that of a 34-year-old male, complained of squinting of the right eye since childhood, and history of road traffic accidents in 2008, where he had undergone a surgery for facial bone fracture. He did not have an anomalous head posture. There is a right hyper again. And this is his motility, showing the huge right inferior oblique overaction and the right superior oblique underaction. And you can see here again the huge 50 PD of right R/L increasing in the left gaze and the right tilt, as you can see in the 9 gaze photographs also. So here it is. And this again, the trauma was misleading. He did not have an acquired esopalsy component at all. It is a congenital esopalsy presenting late again. And so we did an intraoperative force duction test for the superior oblique. It was extremely lax. And I usually prefer a nasal approach for the superior oblique tendon. You can see how long and lax it is. So the diagnosis of the congenital esopalsy here is confirmed. So I'm doing a tuck here, and usually prefer to do an adjustable tuck where you put in the slip knot and then you titrate the amount of tightness that you want. As you can see here, is much tighter before than like after doing the tuck than it was before. You can compare the amount of cornea that goes into the nasal supranasal aspect, and so the tuck is done here. We also combined it with the inferior oblique antero positioning due to the huge hyper, and at the end of 2 muscles you can see that the R/L is 16 PD here, increasing in the left gaze again and the right tilt, but the patient was quite happy. We did tell him that if he wanted further correction, then we will be operating on the other eye inferior rectus here, so that will be the 3rd muscle of choice. Currently, he is quite happy with the result right now and said he'll come back if needed for the 2nd procedure. So the 3rd patient, again, he complained of upward deviation in his right eye since early childhood. He had a need to use the chin up posture in both eyes to fuse, and he could fuse only in his down gaze. The unaided visual acuity was 6/6 with the anterior segment and fundus evaluation being normal. You can see here with his right eye fixing, the left eye goes completely up with an upshoot, whereas with the left eye fixing, the right eye is down and it has a ptosis also. And he has a BSV with the chin up posture, could fuse very well in the down gaze. You can see here the extraocular motility, a huge upshoot and on both primary and elevation, normal superior oblique function, and could fuse in down gaze. So here, this is his 9 gaze photographs. Again, you can see the same picture with the upshoot in both the primary and the up gazes. All gazes having an exotropia. Exotropia increasing towards the left side, and also exotropia only present in down gaze with no vertical. And this is the fundus picture with the extorsion in both eyes. So this was quite of a like a diagnostic dilemma. We were thinking between right eye MED, left eye SO palsy, or misinnervation. So the plan was to go ahead and explore intraoperatively to get some clues intraoperatively also. And you can see the superior rectus being hooked and the superior oblique by the nasal approach, again extremely long and lax. So that was in favor of a congenital SO palsy. The superior rectus was also, there was a mild tightness. So maybe a long-standing SO palsy with an SR, a mild contracture. So here I'm doing a tuck of 6 millimeter using the non-absorbable suture. And the superior rectus was also recessed here because we were not sure whether there is a misinnervation going on, and extreme upshoot in the up gaze. And this is the lateral rectus and the inferior here. So because the upshoot was so much, I decided on doing an anterior nasal transposition of the inferior oblique, where the inferior oblique goes under the inferior rectus and being attached. So I did that because I wanted a stronger depressing force, and the lateral rectus is also being recessed by 8 millimeters. So you can see the post-operative, we were very happy to see the good outcome here. You can see the absence, total absence of upshoot in the up cases. Primary alignment is very good, and in the gaze position also there is no upshoot, and down gaze he continues to maintain the alignment. He no longer needed the chin up posture, and he could fuse in most of his gazes. So again, this is a case of SO palsy, though with a very different presentation. The last, another case is that of a road traffic accident, head injury, underwent conservative neurological management, but noticed double vision in down gaze for the past 4 months. He was working in a textile industry and could not resume work because of diplopia. And here you can see that it is like a bilateral superior oblique palsy with a mild esotropia in primary, but on the down gaze, he had a huge ET and also a vertical deviation. So this patient could not use his down gaze at all, and he couldn't join work. This is the fundus examination with 20-degree extorsion seen in both eyes, though the extorsion subjective was more in the left eye. So the main concerns were chin depression, torsion, and diplopia in down gaze. So it's a case of acquired SO palsy. The surgery done was inferior recession of 4 millimeter with a mild temporal transposition for the esotropia and left eye superior oblique anadoidal. So this is the photographs of the surgery with the temporal transposition of the inferior oblique after recession, as you can see here. And this is the superior oblique anterior transposition with the anadoidal. So post-operatively, he did not have ET in primary. Down gaze esotropia collapsed from 20 to 6. So he had a much bigger binocular field of vision right now, and he could resume joining his work. And this is the fundus picture. As you can see, there is a mild overcorrection with a slight intorsion of his left eye, where we did the anadoidal. Right eye also reverts to normal. So sometimes even one surgery can give, one eye anadoidal gives a good result. And the last case is a 38-year-old lady.
Dr.
Yeah,
Sandra,
Yes, just finishing. The head injury, 1.5 years earlier, noticed double vision in down gaze on climbing the stairs, and she had to tilt her head. And she had a huge vertical with 12 prisms L over R in the left gaze and increasing in the down gaze and towards the right side and the left tilt. So again, it's acquired left SO palsy, but the good thing is she did not have much, she did not have torsion. So because it was more in the down gaze, so I decided on doing the other eye inferior rectus with a recess procedure or a Scott's procedure. And so with that, her primary was okay. okay. Down gaze, the L by R reduced to 6 prism from 12 prism. So her binocular field increased and she did not have diplopia except for extreme down gaze. So to conclude, single muscle surgery may be the standard for smaller amount of hypertropia. Ipsilateral inferior oblique weakening is one of the choices. Contralateral inferior rectus and SO tucking if FTT shows SO laxity. Harada Ito for torsion. And if the angle is more than 15, 2 muscles. And usually if there is SO tendon laxity, I prefer to combine the inferior oblique along with the ipsilateral superior oblique. And that avoids GA in adults if the surgery is performed only on one eye. And you can avoid intra-operative like iatrogenic browns if you do an adjustable tuck and judge the tightness based on the amount of tightness that you want. Thank you.
Thank you, Dr. Sandra, for such a lovely illustrative demonstration of the spectrum of cases of superior oblique palsy. Now I invite Dr. Sanathan Gopal to speak on the looking beyond occlusion. He is an innovator, and let us see how he is sharing his new knowledge with us. Thank you.
I would also take this opportunity to invite Dr. Prabhakar Patil sir, who has joined us. Welcome, sir. Welcome to the session.
Santhan sir, you're muted, sir. So we're not able to hear you.
Yeah. Can you hear me now?
Yes, sir.
Yes, sir.
Yes.
Good morning. I thank the Bombay Ophthalmic Association for this opportunity to present my instrument, which is called as the orthoptic, and which is called as orthoptic. This talk is divided into 3 parts. The first part is about just the presentation of the instrument, and also how to use the instrument, which is very easy. Even the illiterate patients can use it. The second part of it is to show you the results using this machine on over 142 patients. And the third part, which is the most difficult part to understand and not needed for an average general ophthalmologist or even for that matter, a strabismologist to know. So let us start with the first part. This is called as a magnocellular stimulator, which is used for not only treatment of amblyopia, but a number of other conditions. And after using this instrument, I've seen improvement in stereopsis, binocular vision, monocular vision, and in a large percentage of the patients with exotropia, intermittent divergent squint, and also in consecutive exotropias, they never needed further surgery. And this improvement in all these conditions is sustained even after we stop the treatment for about 6 months after the last session. The stereopsis improved much faster than the monocular vision, and binocular single vision in all these patients for distance improved rapidly. So the instrument, to show you, has got three, in the instrument has three rows of light, 9 rows of light, or 3 rows of 3 lights. The center one is red in color, and the patient sit about 1 meter in front of the machine, and the eye level is adjusted for the red light. And the patient with a laser pointer keeps pointing at the light which comes on, which stays for 300 milliseconds, and the next light comes on. Like that, the process goes on for about 25 minutes or 20 minutes with the amblyopic eye, and the other eye is passed during the time, and then it is done with both the eyes for about 5 to 10 minutes, and then it's done with normal eye for about 5 minutes. And this constitutes a session of about 30 to 40 minutes, depending on the degree of amblyopia. And you can repeat the same within 1 day, 2 or 3 times, but patients usually lose attention because our machine is based essentially on attention mechanism, which you will know later. We cannot do more than 3 sessions in 1 day. That's about how to use the machine. Now, during the time when you are not using doing any exercise, there is no need to patch the eye. So our results I will present binocular single vision at presentation. You can see that none of the amblyopics had any binocular vision for distance with red and green glasses. But you can see here, after treatment, nearly 95% had binocular single vision within the first 3 or 4 days of the treatment, and all the suppression disappeared. The initial visual acuity in these patients, you can see 0.493 and 0.210, and after treatment, you can see 0.08 and 0.07 in amblyopia patients. The initial stereopsis in all these patients present at all. To give a number in considering the statistical part of it, so we gave the number 3000 seconds of arc, which is the lowest possible stereopsis. And this is after treatment. You can see about 10 days of treatment, 45.4 in the anisometropic amblyopia, and 216 stereopsis in strabismus. Some of them need some. Now, in order to explain why this machine works and why it works so rapidly, you need to know a lot about these things, the whole visual pathway. But I don't have enough time to discuss all these things. Just to say one few points here, that the first place where the photochemical energy, photonic energy is converted into neural energy is at the ganglion cell layer, which are of various types. The parvocellular types, the coniocellular and the magnocellular, and they all go to LGN first, and then they go to the V1, which is the lowest visual cortex. At the V1, the ganglion cells go to different layers in V1, depending on what type they are, 4A, 4B, and 4C. In the 4C, 4C alpha, and 4C beta. Let's not go into the details. The sensory cortex in turn is closely connected to the motor cortex in a very orderly fashion, which is called as fovea cortical fidelity, which means that the point above the fovea or point below the fovea or nasal or temporal is exactly represented in the cortex, which the retinal topography is exactly represented in the cortex. And during a saccadic movement, you must remember that the retina between the fovea and the stimulated peripheral retinal point is suppressed by the brain during a saccade. There are various types of saccades, but what we are interested in is called as the reflexive saccade or prosaccades. So at the beginning, before the prosaccade starts, the fovea is already alerted, and after the saccade stops, the fovea is still active. So therefore, this is possible because there is a connection between the M and P cells throughout in the brain at various levels. This is the principle we exploit in this machine. We can see that the retina magnocellular cells are catered to the peripheral retina, and they go to only ventral 1 and 2 of LGN, whereas parvocellular cells catered to the central retina have a larger representation in the sensory cortex and also in LGN, 3, 4, 5, 6, the dorsal part of the LGN. Now, LGN is not a simple relay station. It's only 30% of the impulses that come to LGN are passed on to the cortex after modification. And this modification at LGN happens because of this corticogeniculate modulating fibers which come down from V1 to LGN, and perhaps they go down to retinal level also. So you can see that the parvocellular cells go to layer 4C beta in V1, whereas the magnocellular cells go to 4C alpha in V1. From there, they again diverge. The parvocellular cells mainly go to the inferotemporal cortex or what of vision, whereas the magnocellular cells go to the where of vision, which is the superoparietal cortex. Now, this division of labor is very, very essential in central nervous system for uniformly sending the impulses and managing the impulses very correctly. So there is a lot of interconnection between the M and P cells. Ultimately, both an M and P cells end up in the primary posterior parietal cortex, which is called as the global sensory motor integration center. So you can see that the primary parietal cortex is the global integration center, which receives both the parvocellular and magnocellular cells discharge. In the parietal cortex, there are two centers which are called the attention center and the saccadic generation center, and they are in connection with each other. And when the attention center is strongly stimulated, the saccadic generation center is strongly inhibited. And when the saccadic generation center is strongly stimulated, the attention area is slightly depressed. So as I told you, it's called as PPC is called as Global Sensory Motor Integration Center, which receives all the afferent impulses from all the part of the body and decides what motor action should be taken after taking into consideration all the afferent stimuli. Now, in the PPC, as I told you, there are attention area and saccadic generation area. The attention area sends down the impulses not only to different parts of the cortex, but also to V1. And these impulses which come from attention area are called as the top-down impulses. They can be recognized on EEG as alpha and beta oscillations. They go to layer V1 at layer 4C beta, and the top-down impulses from the saccadic generation area go to the attention area, and then they come down to layer 4C beta. Also, the forward connection with saccadic generation center is to the frontal eye field area, which is very closely situated to the hand area in the brain. And therefore, I give a laser pointer to improve the hand-eye coordination in many of these patients, which is abnormal in amblyopia. So the point is, peripheral retinal point, when it is stimulated, M cells get stimulated by the sudden appearance of the light, and the eyes make a saccadic movement. When the eyes make a saccadic movement, the direction and the amount of which is dependent on the distance of the peripherally stimulated point from the fovea. Due to the foveo-cortical fidelity, the eye moves. When the eye moves to such extent so that
You have a minute, sir, please.
So that the fovea is brought to focus. Farther away from the fovea, the point is, the greater is the movement, and closer to the fovea, the less is the movement, and at the fovea, there is no movement of the eye because of strong inhibition of the saccadic generation center. So the principle is sudden appearance of light in the peripheral retina, then followed by stimulation of saccadic eye movement, is then associated with the stimulation of the fovea in V1 at 4C beta via the top-down impulses which come from attention center in the parietal area to the occipital area, and separation of the retinal area happens in between these two as alluded to earlier. So repeated stimulation of the magnocellular cells leads to repeated stimulation of the attention area in the parietal cortex, which in turn stimulates the fovea, which in turn improves the vision. The prosaccade is associated with maximum stimulation of the V1. Now, all this can be understood because the top-down impulses which come down from the parietal cells go to 4C beta, where the separation is maximum. However, it's important to note that the top-down impulses on 4C beta go to not only the synapses, before synapse and after the synapse also, so that it obviates the separation which is situated at the 4C beta synapse level. So when you say amblyopia, there is separation, you should ask, where is the separation? A general answer is in the cortex. Where in cortex? In the occipital cortex. Where in occipital cortex? You see, when you go and analyze, you realize that the maximum separation happens at level 4C beta synapses. The afferent impulses from the parvocellular cells go to 4C beta. So if the separation is in the synapse, no information is passed on to the extrastriate cortex for further analysis by the occipital cortex, and therefore there is no analysis of the image. The occipital cortex is called as image forwarding center. It does not do anything. It does not really analyze the images, but it passes off the image quality. It passes off the information about the color, texture, shape, and size of the image to the extrastriate areas, which are principal in analyzing this information. Whereas our magnocellular cells pass on the information.
Dr. Santhan sir, please summarize.
Finished?
Yes.
Finished?
No, I didn't understand.
Sir, please summarize. Conclude.
Summarize.
So we have 1 minute.
Okay. Anyway, I'm almost finished. The top-down impulses which come from the parietal cells go beyond the synapse where the suppression is in amblyopia, and therefore the vision in amblyopia improves. No matter how much you send impulses from the retina to the cortex, it is not going to go beyond suppression point at 4C beta, which is the synapse at 4C beta. However, the top-down impulses have not only discharge before the synapse, but in the synapse and also after the synapse. And therefore, this instrument is very useful in many cases of attention deficit disorders, cerebral palsy, amblyopia, nystagmus, and in most cases of exotropias, which you don't need any further surgery. Thank you very much. I think I had 10 minutes. Subhash didn't note that. So,
So you have taken 11 minutes, sir.
oh, sorry. Finished. Thank you.
Thank you,
sir. Now I invite Dr. Shashikant Shetty, who is Chief of Pediatric Ophthalmology at Arvind Eye Hospital, Madurai, to give his talk, please, on surgical management of nystagmus. Dr. Shashikant Shetty, please.
Yeah, I can't share my screen.
Now you'll be able to.
Yes, sir,
Yes,
we
my
can
screen-
see your screen now.
Okay. Yeah. Good morning, BOA, MOA. Thank you for inviting me for this very excellent webinar. I would like to thank Dr. Hema Malini Sawant and Dr. Prachi for personally inviting me for this webinar. I'll be talking on basic aspects, surgical aspects of patients with nystagmus. So there is no financial disclosures. So this is the slide given by Dr. Del Hosso. It just illustrates how a patient with nystagmus sees. So basically they have a very small zone of visual acuity with a null point, that is called as a null point. So when he has a null point, he sees at a point where he sees clearly. And when the null point shifts, the other zones are blurred. And so you can see in this slide how there's a small zone of narrow visual acuity. So when we do the surgery for these patients, we expect the null to be here from the periphery, but actually what happens, there is a widening of the null zone. So patient actually sees better. So which group we need to operate? If the any age group, specific age group, yeah, actually we wait for the head posture to stabilize, because sometimes patient can have alternating head postures. Patient can have periodic alternating nystagmus, and they might have a silent null. So suppose one null gets corrected, the second patient may start using the second null. Or if the patient has got significant head postures, we should have a periodic assessment of the head postures to rule out pan, A-pan, and a silent null. And then if you have access to eye movement recordings, we should do recordings to look for again pan, look for NAFX, and finally look for reversal to rule out aperiodic alternating nystagmus. And if you not have access to eye movement recordings, then we can do vision in 9 gazes. This 9 gazes vision recording helps a lot. It tells you if there is associated 2 nulls or there is a single null. So what we see here, this is a chrome. This is a cervical range of ocular motion, what we use in our clinic to assess the head posture. It can assess head posture in all the 3 gazes. The horizontal, this is for the chin elevation, for the head tilt, and this is for the chin elevation or the chin depression. So it assesses the head posture in all the 3 gazes. The horizontal, this is for the chin elevation, and this is for the head tilt. So all the 3 gazes can be seen. And we do eye movement recordings for everyone. We use the iLink 1000 Plus, which is a very great machine, which can evaluate even in this child who is 1.5 years old and it's got a upbeating nystagmus. We use the eye tracker, which is nothing but an infrared lace light, which analyzes the eye movement, and it tracks the pupil as well as the cornea. And then you can see the movements of the eye, and you can look for A-pan, pan. You can look for subtle seesaw nystagmus. And then you can see this, we can analyze both the vertical component as well as the horizontal component. So these are the waveforms which we can use to see the type of nystagmus, like a pendular, asymmetric pendular with foveating saccade, jerk right with extended foveation, pseudo-cycloid, pseudo-jerk left, pure pendular, foveating saccade, triangular, bidirectional jerk, and directional jerk. These are the different waveforms we can look at. These bidirectional jerk forms are seen in the neutral zone. Neutral zone is nothing but away from the null zone, where there is a direction of the nystagmus will change. Okay. So if you're analyzing more than 30 degrees, you go to 45 degrees, 60 degrees, then you can look for bidirectional jerk waveforms. before you assess the head posture, you have to assess the head posture. You have to look for PAN, A-PAN. Periodic alternating nystagmus is basically seen in adults, and they are switch at regular intervals. While in pediatric patients, you will usually see a aperiodic alternating nystagmus. So you have to observe for a long period of time, because patient might have a right face turn, and then over a 10 minutes of time, he might switch over to left face turn in patients with aperiodic alternating nystagmus. But in patients with periodic alternating nystagmus, you might have a change of reversal every 90 minutes. 10 minutes, there may be a null phase, and then it will go reverse to and from right beat to left beat. And when we are assessing head posture, you can use the yoke prisms. You can keep the prisms and then see whether the head posture reverses. So when you correct one head posture, patient may go to another head posture. Then you are sure that patient might be having a periodic alternating nystagmus. And second thing is, if the patient has got a multiplanar nystagmus, if the patient has got a multiplanar nystagmus, where patient can have associated head tilt, chin elevation, face turn. So then if you correct only one posture, you keep the prisms, correct the dominant head posture and see what happens to the other head postures. If they get corrected, that suggests that if you do surgery only for the dominant head posture, it will increase the null zone. It could cause widening of the null zone, and the other head postures will get corrected by itself. This is a study which we did for Kestenbaum-Anderson's procedure. Kestenbaum-Anderson's procedure usually correct up to 10 to 15 degree. If it is more than that, then you need to augment. This was an immediate post of surprise what we got after doing a augmented Anderson's Kestenbaum procedure for a 25 degree face turn. Patient developed large angle esotropia in the primary position and developed double vision. And then over a period of time, the movements got better. You can still see the limitation of movements where there was a maximum recession was done. In conclusion, we had residual face turns of 5 degree in patients where patients underwent augmented Kestenbaum's head posture. There was limitation of gazes was not very significant, and we got a 1.5 degree millimeter improvement in all these patients. This is a small video where we had a patient who had a right face turn, and patient had a left eye esotropia, and he had a small esotropia with alternating suppression, and he was dominant actually with the right eye. So we decided to do right eye medial rectus resection and lateral rectus resection. And then on the first post-op day, immediately developed a reversal of the face turn, started fixing with his left eye. And 2 weeks later, we saw him again, and then he has gone back to his original head posture of a right face turn. So you might see a reversal of face turn if the patient has got a periodic alternating nystagmus or aperiodic alternating nystagmus, or if there's a silent null, or if they have a fusion maldevelopment nystagmus. So in our experience, we feel that rectus muscle recession with oblique surgeries, if the patient has got a head posture of vertical head posture of 20 degree, it helps. If it is more than 20 to 30, we do a recessed resect posture of the vertical recti. If it is more than 40 degree, then we do a 8 mm recessed resect. This is a patient who had a chin elevation of 30 degree, and we use the prisms to neutralize his head posture. Very small amplitude nystagmus. And we proceeded with 5 mm recession, and because the patient had a chin up, so we recessed his inferior rectus and we resected his superior rectus, and there was a good improvement in his chin posture.
Sir, we have 1 minute.
And if you have a chin down, you can proceed with the superior rectus recession with infraoblique myectomy, which takes care of the pattern with the recession of the superior rectus, and also it can because when you do the superior rectus recess, it can induce exudation in the primary position, and by doing combining with the inferior oblique, which might induce a small ESO, so that takes care of the horizontal deviation also. And with the head tilt, this child had a head tilt to the right side, so basically we need to take care of the intorsion in the right eye, extort the right eye, and intort the left eye. And he had a very small amplitude nystagmus. We did an MRI to rule out the contracture of the sternocleidomastoid muscle. So what we did is we weakened the extorsion in the left eye. We weakened this inferior oblique anterior fibers by 8 millimeters, and we did a Harada-Ito procedure in the left eye. And in the right eye, what we did is we did the anterior superior oblique tenectomy, and we did a anterior advancement of the anterior fibers of the inferior oblique. And we created a required extorsion in the right eye, and we created a required intorsion in the left eye. But in spite of which, the patient still maintained the right eye head posture. So in spite of doing such a large procedure, the head posture was still, you can see the small amplitude nystagmus on the right head tilt. And as soon as he tilted his head to the left side, the nystagmus actually increased.
Sir, would request you to please summarize.
Yeah, so this is a patient, when we do the eye movement recordings, we have to look for pan. This is a left beating nystagmus, and this is a right beating nystagmus. Okay, so when you do eye movement recordings, which is very important, you can rule out periodic alternating nystagmus. And this is a patient who had the periodic alternating nystagmus, but he didn't have face turn, but he had a chin elevation. And after the chin elevation, we are seeing only the right beat nystagmus. And we have to be very careful when you see a patient nystagmus. You have to rule out saccadic oscillations and saccadic intrusions. So this is a patient who had square wave jerks. It looked like a nystagmus, but on eye movement recordings, we could rule out saccadic intrusion. So to be very, very careful, because saccadic intrusions can be in supranuclear gaze palsies. It can be seen in patients with myasthenia. So you have to rule out saccadic. You should not operate those patients. They are basically saccadic intrusion. They don't have slow phase. They only have saccades. So this is a patient, you can see the saccadic intrusions. So there are multiple saccadic intrusions, saccadic wave oscillations, which can be ruled out with eye movement recordings. So when we do the surgery for this patient, what exactly you're doing?
Dr. Sasikant, please conclude.
Expanded null gaze. So you're improving the null gaze. You're not improving the vision. Subjective vision will remain the same. You're improving the time to see. You're improving the time to see, so you improve his contrast. You improve his gaze-dependent visual acuity and other parameters of visual acuity. So the vision might remain the same when you check his vision, but his other parameters.
Dr. Shetty.
Thank you.
Thank you, sir.
Thank you so much, everyone. I request Dr. Dedia, sir, to kindly share his inputs, please.
Basically, if there are any questions, we are left with only 2 minutes. So if there are any questions in the chat box, they can be put to the speakers.
Raj, sir, would you please like to add your comments?
Yeah, it was a wonderful. Am I audible?
Yes,
Yes,
yes.
sir.
Dr. Shanbag, please mute yourself. Dr. Shanbag, please mute yourself.
Yeah. Am I audible?
Yes.
Yes, sir.
Yeah, it was a wonderful session. First of all, let me thank BOA, MOS, and the panel for the invite. It was a really wonderful session. Each one of the speaker gave some take-home messages for the general ophthalmologists, and I think overall we could gather some good points to practice in. So thank you for the invite.
Dr. Praveena, ma'am, please.
Yes, I have a question for topical anesthesia. That subject was anytime he just changed the type of anesthesia at the time of surgery. Did they need to change the sort of anesthesia topical to different anesthesia during the surgery?
Actually, ma'am, I'm doing this since last 10 years, and not great number of cases I had done under topical anesthesia, but whatsoever I had done, like 25 around, I never needed to change the type of anesthesia. The actually case selection is here is very important. Preoperatively itself, you should see whether the patient in case would be able to cooperate well, and vocal local is very important. So if you go on doing this vocal local and assuring patient, usually you don't need to change, because I usually do it for recessions and lateral and medial recti. So touch wood, I haven't needed to change my anesthesia anytime.
And there is one more question. What are the fasting instructions? I mean, you give any fasting instructions in case you need to change it in between?
Routine, like 2 hours pre-op, I tell them to keep NBM.
Okay.
Dr. Prabhakar
Can I
Patil,
add?
please.
One question again regarding the incision in squint surgery. That basically the limbal incisions are better for the starters or the beginners, because conjunctiva and the tenons, they are together over there. So dissection becomes a little bit easier process for them. So directly switching on to the paralimbal or a fornicial, it is always better to go for a limbal incision for beginners, I believe so.
Yes, madam. Actually, we started with limbal incision only during our fellowship. So
Right.
later on, we switched over to formation.
Right. True.
There's a question for Dr. Chandresh Parekh, sir. Like, what special precautions to be taken in the eyes which have undergone buckling? Sometimes after buckling, we see the squints. If we are operating in those eyes, what special precautions we need to take?
First of all, one is to ask the retinal surgeon whether the buckle can be removed or not. Most of the time, they don't allow the buckle to be removed. But if they permit the buckle removal, then buckle removal should be done. The other thing is that while isolating the muscle, one has to be very careful. There will be a lot of adhesions over there. So one should avoid damaging the muscle or the conjunctiva. And one should, very important, is do post-reduction tests before opening the conjunctiva, after reattaching the muscle, and before closing the conjunctiva, because there are also a lot of adhesions over there. And one may have to do a semi-hangback recession, because the buckle may come in the way of passing the needle. So these are the few precautions which I take in a post-buccal squint surgery.
Thank you, sir. I welcome Dr. Lahane, sir, who has just joined us. I would request Dr. Prabhakar Patil, sir, if he would like to give some comments.
Can I have a comment, ma'am?
Yes, sir, please.
Yeah. So first of all, I think it's a good take-home message and one practical tip by Dr. Chandresh, that especially towards the end of the surgery, the AC in the room should be off, because many of the times we have observed, most of the time the temperature is between say 18 or 16, and when the child is out, he's in hypothermia. So it's a very good point that the AC should be off. Second comment is about the anesthesia. Yes, Dr. Uday Naik, I think has very well covered that. But I think the patient selection is of utmost importance. You come to know the psyche of the patient beforehand only, and only those patients who you feel that will be cooperated should be posted for topical. And on table, you should keep a local anesthesia with say subtenon anesthesia ready. And for general, the squint surgery under general anesthesia, I prefer to have a blended anesthesia, because oculocardiac reflex is quite ubiquitous and quite common as than what we think. So even if the patient is under general anesthesia, it's always a good habit to give a peribulbar or a subtenon anesthesia to the child, even if he's under general anesthesia, because it has got multiple advantages. It decreases the PONV or postoperative nausea and vomiting. The amount of anesthetic gases required is also very less. The recovery is faster, and as well as there is post-op analgesia also. So it's always a good idea to have blended anesthesia, especially the squint surgery under general anesthesia. So these were a few comments.
Thank you, sir.
We have a question regarding to Dr. Sondra, that did she apply NAPS classification while operating over the superior oblique muscle?
Yeah, mostly it is according to that. Basically, I choose the procedure depending upon the amount of hypertropia in primary position and which case the hypertropia is maximum. So those are the two. And again, whether there is torsion or not. So mostly it is according to those guidelines, but also it differs a little bit based on case-to-case basis also.
Thank you.
Okay. Thank you, everyone. We have overshot our time by a few minutes. I would like to thank all the panelists, the chairperson, co-chairperson, and the speakers for contributing today for this wonderful session on strabismus. Thank you again. Now I hand over the hall to the chairperson of the next session, moderator
Dr.
of the next
Snehal,
session.
Dr. TPL wants to say something.
Oh, okay.
Sorry, you want to say something?
Hema, I was listening everybody's talk because as Hema has joined, I have stopped doing squint surgery. But I think everybody, and I want to give this one that Hemalata is an excellent teacher. She said ki 1 minute reh gaya hai, 1 minute reh gaya hai. So I think because of Hemalata,
Thank you,
we have
sir.
finished our session very early. And the Setti what told about the nystagmus. I think Hema, we must do some surgery of nystagmus also. What he is doing there. I think everybody,
Yes, sir.
Dixit and everybody. Santan, as usual, was an excellent. So I was hearing this because I am always interested in this. And Subhas, thank you very much.
Thank you,
Subhas,
sir. Thank you.
Thank you. Chandresh, I think you have 30 years of experience. I am very happy to know that after 30 years, you can now tell people, Vaishali,
But
thank
he
you.
has 35 years. He has told 35 years.
35, sorry. Thank you, Subhas. Thank you, everybody.
Thank you so much,
You
sir.
can go for
I
the
thank
next session.
everyone
Thank
for the
you.
excellent session. Thank you so
Thank you.
much.
Thank
We
you.
would just take a
Thank you,
screenshot.
everybody.
Yeah, I have
Thank you.
taken.
Thank you, madam.
Okay,
Thank you.
Thank you.
Thank you, everyone.
Thank you, everyone, and we close this session. And
Thank you very much.
you can
Thanks
hand
a
over
lot.
to the next.
Yes.
Thanks a lot.
ये मैंने अनम्यूट तो कर दिया.
Has he, sir?
कौन?
डॉक्टर शुक्ला सर, गुड
अरे
मॉर्निंग.
सुभाष कैसे हो?
बस सर खत्म कर दिया टाइम पे सर.
अरे वेरी वेरी गुड. तुमने तो बिफोर टाइम खत्म कर दिया.
Shashikant sir, if you want to hang on to this session, no problem, huh?
Hello, Prakshit. How are you?
All well, sir.
All the faculty can continue in this session if for the next session also if they're interested.
Okay, thank you.
Yeah.
Good morning,
hello, everyone.
Santan.
Have a
Good morning, everyone.
Hello, Dr. Himalini.
Good morning.
Good morning.
So I can see Dr. Shubhangi Bhave ma'am, Dr. Vivek, Dr. Parikshit, Dr. Yogesh Shukla.
But I am not coming on the screen.
Sir, you probably need to on your video, your video camera.
I think my screen is, I can't, that something has gone wrong with screen sharing about that background, virtual background.
Madam, there is too much.
That's okay, ma'am. If you cannot do it, it's okay. It's fine.
I can't do anything to put off that thing.
You can remove the virtual background.
Yeah, you can remove the virtual background, ma'am, because there's too much light. It's not syncing properly.
Okay. So how can I remove that?
You will have to go to the settings on a computer.
Oh.
No, madam, you go to the video. You go to the video. There is one, this one arrow. Click that. You will see there is a virtual background. Remove that virtual background in the video.
Okay, okay.
Anand Kumar, are we ready?
Yes, sir, we are ready. I can see Dr. Pradeep Sharma as well. I can see Dr. Jitendra Jethani. I think we are waiting for Dr. Milind Kiledar, sir, and Dr. Ankur Sinha. Dr. Manjushri Bhate and Dr. Sanjay Tekavade as well.
Okay. प्रदीप जी गुड मॉर्निंग. आपकी आप अनम्यूट करिए, आवाज नहीं आ रही है आपकी.
Good morning, Yogesh and
yeah, now we can.
Nice to see you all. बहुत अच्छा लगा.
Yeah, seeing each everybody virtually हैं.
हाँ. तो है ना दर्शनी दीदारी है ना नदीरे.
क्या करें साहब, आपके दिल्ली और बंबई ये दोनों ने मिलके तो
बैंड बजा दिया.
And बजा दिया बिल्कुल. Santan, how are you? Santan, how are you?
I'm great, no problem.
You are always great, huh?
Sir, and you shouldn't forget Bangalore also, sir, in line with Delhi and Mumbai. That is also a great city.
Bangalore तो परीक्षित अभी आ रहा है. So anyway, let's talk about good things, not the bad things. Let's
welcome Yogesh Shukla sir, welcome, and Pradeep Sharma sir, welcome.
Thank you, Dr. Lane. Thank you, Dr. Lane.
Welcome.
Good morning, sir.
Good morning. Good morning.
Good morning, sir. Lahane sir, good morning. All the best for the elections.
Thank you. Thank you very much, sir. Thank you. Thank you.
You are hitting the jackpot right in the beginning, Santan.
Morning, Lahane sir.
Good morning.
Anand,
good morning, Vivek. Good morning.
You give me the red signal so that the green signal. I'm sorry, so that we can start.
Green signal.
Right,
Go
sir.
ahead.
We still have 5 minutes for the
Okay.
start, and I think a couple of people have still not joined.
Till that time, we will have a little chit chat with Hemalini is here. Good morning, Hemalini. Nice to see you after a long time.
Thank you, sir. Good morning to you.
I hope in future we meet in better circumstances.
Definitely, sir. Hi, Manju.
Hello, Manju. Yes.
तू एकदा हे कर, लिव्ह कर आणि पुन्हा जॉईन कर. शुभांगी, तू एकदा लिव्ह कर आणि पुन्हा जॉईन कर.
Shubhangi, I'll tell you what, I had
Morning, Lahane sir. Morning, everyone.
Hi, Prasad. Good morning. Good morning. Good morning.
Hi, Prasad.
Hi.
Hi, Manju.
Hi, Manju. How are you?
I'm good.
Good.
आमचं पुणे.
Good. Good. Recovering now.
Good, nice.
Good morning, Sharma sir. Good morning.
Good morning.
Very nice to see every one of you, sir. Although
sir,
virtual, but it's
to see all
always a
of
treat
you.
to watch and hear everyone.
Hi, Parikshit. One more आमचं पुणे.
Yep.
Where
Pune
are you
is
based
recovering.
now?
Everyone is recovering now, hopefully.
Hyderabad.
Oh, okay.
Come over.
Sure.
Actually, I'm not able to do. I think
Shubhangi, you know what? I face the same problem. My laptop, it says it's not compatible for virtual background. So I used to get this. So probably you may face the same problem because
Manju, she doesn't know how to remove the background. Tell her how to remove the background.
Yes, you go to that virtual background, how you got it, and click on none.
Actually, my husband did it for me and he has left somewhere. So I think I'll have to just...
At this time, your husband should not have left you.
They are known to leave us for
these are corona times, and the family should be together. Shubhangi, this is not the time. You know?
Dr. Shukla, आप सब husbands को एक lecture दे दीजिए.
मैं करने वाला हूँ इसके बाद.
With their wives and
Webinar-itis दोनों को होना है.
Shubhangi, you can and go to choose virtual background. You get that choose virtual background option. You click on that.
Okay.
And once you click on
stop video, then
you get the choose virtual background option. Click on that.
Okay.
The option आला का तिकडे?
नाही येत आहे hide.
ते stop video च्या शेजारी एक असं छोटंसं हे आहे ना, त्याच्यावर क्लिक कर.
स्टार्ट वीडियो आ रहा है. स्टॉप वीडियो के बाद नहीं आ रहा है कुछ.
नहीं, स्टॉप वीडियो के बाद एक छोटा सा सिंबल है ना, उसके ऊपर इफ यू क्लिक,
ओके,
यू सी चूज वर्चुअल बैकग्राउंड.
Okay. I think I'll do without the video only. Shall I start my presentation?
No, wait. Let everybody come on this thing.
Yes.
So,
good morning everyone.
Good morning, sir. I just talk to you. आ गया वो ठीक है वो. हाँ sir. So I think this we can start. We can start the session. Good morning, everybody, to you. And we have on the chair with me Dr. Pradeep Sharma. Then we have the convener, Dr. Manjushri, co-convener Dr. Sanjay, moderator Dr. Parikshit, and co-moderator Dr. Anand. The moderator, please, your job is to monitor the time, so be careful. And at the outset, I welcome you all the on the chair as well as the speakers. And I'm very happy to see that, in these trying and testing times, the Ophthalmic Society of Bombay and Maharashtra have done this program. And the best thing which I like is they have done it, on every Sunday, so that you don't jam the whole sessions. Each day is dedicated to a particular topic, and that is very nice, something. But I hope it doesn't become a routine, because we all miss the physical sessions what we have. This is just for the emergency, that we're having this virtual conference. But anyway, whatever is there, we should make the best of it. And now, after welcoming, we can start the program now. The first speaker is Dr. Shubhangi. And you have 8 minutes, Dr. Shubhangi, and she would be speaking on acute concomitant esotropia. You can start your talk, Dr. Shubhangi.
Good morning. Good morning, everyone. I thank BOA for asking me to be a part of this momentous conference, and thank Lane sir, Ragini madam, Himalini for asking me to be a part of this. I'll be speaking on acute acquired concomitant strabismus. Is my
Yes, ma'am. Your screen is visible now, and you're clearly audible.
Yes. So, acute concomitant strabismus is characterized by a concomitant acute onset non-accommodative esotropia, and each of this terminology is important. It has to be concomitant, acute onset, and there has to be no accommodative element. It's associated with diplopia and visual confusion. There is a good potential for binocular vision with highly favorable surgical results. Age of presentation is generally more than 5 years, and there is no tendency for spontaneous resolution. 3 types have been described. Type 1 is following artificial interruption of fusion, that is also known as the Swan type. And this is generally seen after fusion of one eye for any reason. And this strabismus becomes manifest. Then type 2, we have an concomitant esotropia of Franke-Shetty type. This is accompanied with diplopia and good potential for binocular cooperation. And the third is the comitant esotropia of Bilchowski's type. And these patients have myopia up to 5 diopters and have cross diplopia for distance and fusion for near. Basically, they say that type 2 and type 3 may not be very different. And because even in the type 2 one, they do not have much of hyperopia. 80% of those patients also have myopia. And in the type 3, it is not as if we see it only in patients who do not wear myopic glasses. So according to some researchers, it is better to classify it as a small angle concomitant esotropia and a large angle concomitant esotropia. Now, in examination, one has to be careful in taking in history. Examination for uncorrected hyperopia and isometropia, AC over A ratio to rule out the accommodative component, myopia has to be assessed. Detailed orthoptic checkup, Hess charting to see for the evidence of comitance. Late age of onset and diplopia indicate absence of suppression. And even though it is concomitant, neuroimaging is done to rule out intracranial lesions. The differential diagnosis is bilateral 6-nerve palsy, where obviously there would be an abduction deficit. Divergence palsy, though it may not have an abduction deficit, but the deviation would be more for distance, divergence, insufficiency. The treatment, basically one has to do in full correction of refractive error, treatment of amblyopia, if any, treatment by Botox, I'll come to it a bit later on, and surgery. Early realignment carries a good prognosis for re-establishing fusion. Now, Botox versus surgery. There have been good reports in this condition by using botulinum injection. Though I have not used Botox, but the research says that botulinum gives good result, especially in younger children. Those in younger than 12 to 14 years may have very good results with Botox and also require lesser injections. Surgery gives good result, but one has to be careful against guarding undercorrection. Adjustable sutures should be used preferably whenever we are doing the surgery. I'll be just describing one case related to this. A 16-year-old female came with double vision and headache since 4 months prior to seeing us. There was no significant history of double vision in the recent past. She was a myope using specs since 5 years. Her BCVA was 6/6 in both the eyes. Right eye she had -3.25 and left eye she was -3. Pupils and fundus was normal. She had a right esotropia. The prism bar cover test was not very large angle. It was 25 to 30 prism diopter esotropia, both for distance, near, and all the lateral gazes. So it was totally concomitant. Ocular movements had no abduction deficit, and synaptophore showed an angle of 11 degrees with simultaneous macular perception at the angle. The Hess chart showed near symmetrical inward displacement suggestive of concomitant esotropia. Force junction test was negative. MRI brain done was normal. So we clinically, it was a case of acute concomitant esotropia. Query the type 2 or the Frank-Shetty type. Here we did a R&R in the right eye, right medial rectus resection of 4.5 millimeters on adjustable with lateral rectus resection of 5 millimeters. And this was the Hess chart showing an almost equal displacement inward. And this was the pre-op images showing a right esotropia. And this was the post-op showing the straight eyes. I'd just like to present a post-operatively, the eyes were straight and the stereopsis was plus with limited fusion. I'll just like to show a short video of adjustable suture.
Preetham.
So we take a continuous suture on the muscle, the chain stitch type. And after passing this suture through the sclera, tie a square knot at the muscle and then put a sliding knot on the suture. Slide it nicely 3 or 4 times. So it makes it easy post-operatively for adjustment if you require it.
1 minute remaining, ma'am.
This last few seconds. And when I take out the suture, I don't take it out from the near the cornea. I take it through the gap between the two sutures at the inferior edge, so that we don't have to again open the conjunctiva, and can be adjustment if needed can be done from there. So this is about the topic, and thanks for a patient listening, and stay safe.
Thank you, Dr. Shobhangi. As already mentioned, we are going to have discussions at the end of the session. So please keep your questions ready at the end of the session. Then next we have the talk on management of Brown syndrome by Dr. Ankur Sinha from Jaipur. Ankur, you can start here.
Is my screen visible, sir?
Yes, yes.
Okay. Good morning,
Yes,
everyone. And thank you, BOA, thank you, Dr. Himalini and Dr. Prachi for inviting me. And we have my mentors and friends in the panel and maybe in the audience. So I'll be talking in brief about the management of Brown's syndrome. So the clinical features of Brown's syndrome are the absence of elevation in adduction, normal elevation in abduction. A forced duction test would show a severe mechanical restriction when you try to attempt to elevate the eye in adducted position. There are some variable features like downshoot or hypotropia in adduction, hypotropia in the primary position, widening of the palpable fissure in adduction, compensatory head posture, divergence in the up gaze, that is because of the tight superior oblique, presence of trochlear tenderness or audible or a palpable click when the muscle is passing through the trochlea, more so in the inflammatory cases. Now they can be congenital or acquired. The congenital variety has a problem in tendon or the tendon trochlear complex. This could be a sheath anomaly or a short or inelastic tendon. There could be an improper slippage of tendon through the trochlea, or there could be bands which do not allow movement of tendon through the trochlea. The acquired variety could be a post-surgical, post-inflammatory, or traumatic. So for the management point of view, we would like to grade them into mild, moderate, and severe ones. The mild ones would have restricted elevation only in the adduction. So there would not be a downshoot or a hypertropia in the primary position. As we can see here, this patient has exotropia, but there's no problem in the elevation. But as soon as we elevate the eye in adduction, there is a little bit of mechanical restriction there. Now, in the moderate cases, there would be a little bit of problem in the elevation in adduction, definitely, and then there could be a slight problem in elevation also. So here again, in the primary position, the eyes are perfectly well aligned. In the severe cases, there would be a significant hypotropia in the primary gaze, a deficient elevation, and a significantly deficient elevation in adduction. And also there can be a little bit of downshoot, as we can see here. So clinical evaluation starts with evaluation of visual functions, which are usually normal in a case of Brown's. Look for the old photographs to look at the head posture. Take the other history as in the cases of acquired Brown's or especially inflammatory cases. 9 cases to be seen very carefully as we have just described. Do an FDT, and exaggerated FDT is important here to find out how tight the muscle is. Now, exaggerated FDT should be added as a part of surgical management before and after the surgery so that we know that the mechanical restriction is done away with. Now, what are the indications of surgery? A severe constant congenital Brown's, a primary position hypotropia, a significant head posture, unacceptable downshoot in adduction, and sometimes in long-standing acquired cases which are not resolving on their own. Management could be non-surgical, like in cases of acquired, we can give steroids, oral or topical, oral or local injectable steroids, and also try and treat the underlying disease which has caused this Brown syndrome in these patients. Surgical options for Browns are Z tenotomy, split lengthening, silicone or chicken expanders, and sometimes a free tenectomy can also be done. PTSOs, tendon recessions in chichotomy actually do not work in case of Browns. Now, goals of treatment here would be to correct the hypotropia in the primary case, the correction of head posture, reduction of downshoot, try and increase the up gaze, and overall what we do is we try to expand the binocular diplopia field. So the best statement regarding management of Browns is no surgery can eliminate or cure Browns, as stated by Rosenbaum. Counseling and discussion is a very important part, more so in the private practice. Proper explanation to the patients and parents and caregivers is very important as to what we are doing and why we are doing. We should also explain them possible adverse effects, because there can be sometimes a residual Browns, which is more common, and then sometimes there can be superior oblique palsy. This is more so in mild cases because adverse effects can sometimes be counterproductive, and mild cases may still be managed without surgeries. Try and address all the queries and expectations of the patients before surgery, especially in the private practice. Now, dyes can be used to identify the fibers. We can use methylene blue, trypan blue, or indocyanine green, but this is usually done for the beginners because sometimes they're not able to find out the white glistening fibers of superior oblique. I have tried and avoid the videos because sometimes the streaming is a problem. So this is stills from the videos where we are doing a chicken expander suture. So this is a case where we have taken out, exposed the superior oblique from the underneath the superior rectus, and we mark the superior oblique 2 points like this here, and we pass the sutures, the non-absorbable sutures, from these 2 marks. Now in this case, they are approximately 3 to 4 millimeters apart. So what we do is if we are planning 8 millimeter lengthening of the tendon, then this 3 to 4 millimeters is to be added to the overall length of the suture which we are putting in between the two parts of tendon. So here it would be 8 plus 4, so 12 millimeters of the loop of this suture here. So we tie the sutures at both the marked areas and we snip off the tendon in between. And this is how the tendon is lengthened with a chicken suture. A similar thing can be done with a silicone expander here. So here where the silicone expander is placed between the two cut ends of muscle as we have placed the chicken suture. But the problems here could be, there could be sometimes fibrosis around the band, which can cause limitation of movements. Now, this is a case of severe Brown's syndrome of the left eye. We can see there is significant hypertropia, absence elevation, and there's significant downshoot with significant restriction of elevation in adduction. The patient undergoes a suture expander here, and this is the photographs 3 days and 3 months post-op. We can see that there's good alignment in the primary gaze, increase in the elevation in the primary elevation. However, there is certain amount of residual Brown still left. Another case where we have a moderate Brown syndrome in the right eye, post-surgery, which he undergoes a suture expander, we can see there is a significant improvement in the up gaze, and also this Brown's is very minimally left. Now, this is a case of 14-year-old girl. On examination, she had a history of progressive onset of double vision. Examination was absolutely fine, but the 9 gazes, we can see there is slight hypertropia, deficient elevation in the primary gaze, a downshoot, and significant restriction of elevation in adduction. So all these show a typical ocular motility of Brown syndrome. Since it was a progressive onset, the patient undergoes a sonography where we can see a cystic lesion in the superior oblique. This is very clearly seen in the CT orbit where we can see a ring enhancement here. So this was a case of acquired Brown syndrome, which is cysticercosis. So she was given albendazole along with steroids. Eventually, the strabismus status did not change after the long-standing treatment. So the patient undergoes silicone expander, and we can see again, this is the improvement in the primary gaze, the improvement in the up gaze. However, certain amount of Brown still is left behind in this patient.
1 minute
Now, this is another case where we have a case of left superior oblique palsy. We can see this is a left hypertropia with significant underaction of superior oblique here and a significant overaction of inferior oblique here. The patient undergoes superior oblique tuck for superior oblique palsy, and immediate post-op, we have this Brown syndrome, which is coming up. So this is a case of iatrogenic Brown syndrome. We wait for a long time. The Brown syndrome does resolve to a certain extent, but still a residual Browns is left behind. So in the end, I would just like to say Brown syndrome is a rare, difficult form of strabismus with multiple types of etiologies. It can be dealt with proper workup with fair to good results. Thank you.
Thank you, Ankur. In very short time, you have elaborated it very nicely. Anyway, if there's any questions, we'll do it at the end of the session. Now, the next topic we have by Dr. Vivek Varkad on muscle transplantations. Dr. Vivek, yeah.
Yeah, can you see my presentation?
Yes, Dr. Vivek, we can see your screen.
Yeah, so good morning, everyone. So basically, I am going to talk about the muscle transplantation case-based discussion. I do not have any financial disclosure for the slides which I am going to show. So as we know that the muscle transplantation surgery has recently become popular as a surgical procedure in strabismus. Although this has been very well described by Dr. Hayat almost 5 decades ago, and in his landmark paper, he has summarized for the fact that this procedure can be used in humans, and the tissue transplanted remains viable, and this procedure has an advantages over the artificial synthetic material like the Gore-Tex or silicone band or the non-absorbable suture. And this procedure can also be used as the intervention for those patients who are left with residual strabismus, either consecutive or the residual exotropias or isotropias. So basically, what is this muscle transplantation, or for that matter, true muscle transposition? So as you can appreciate in this video for muscle transplantation in isotropia and exotropia, so the R&R procedure is more or less the way we do conventionally. However, the harvesting of the muscle segment, which we are planning to transplant to the, the muscle to be recessed, is very, very important. So as you can appreciate in both the videos running, so marking of the outer surface of the muscle is very, very important. again, the measurement. So usually, you know, when you're planning it for esotropia, taking the graft is pretty easy compared to for exotropia, because we have a short length of resected MR compared to, you know, the larger extent of the available tissue from the resected LR. So it is very, very important to take a secure bites at the either end after the cut end of the muscle is being, you know, secured with the transpose muscle. And then the middle bite is equally important to make sure that, you know, the entire horizontal length is being opposed or aligned with the muscle to be recessed, as you can appreciate in the first video. So I think other than this, there are other factors which we need to consider is, you know, the proper cauterization of the tissue. Once you disinsert the muscle and cut the segment, there could be, you know, the contraction of the muscle fiber and then ultimate recession of the muscle position. So let's move on to the clinical case scenario. So this is a 19-year-old male child who presented with, you know, the inward deviation of the eye since birth.
We have a video.
Okay.
Anand.
Yeah, I think there's some network issue. Dr. Vivek, we've lost Dr. Vivek. We'll wait for a few seconds for him to rejoin, or else I think we can take a few questions in the meanwhile, sir.
No, we can go to the next speaker then. We can go to the next speaker because then
Sure. That's a good idea, sir.
Are you able to connect, Anand?
I'm trying, sir. I'll just try.
Never mind, he can continue, you know, later on at the end. We can again, the remaining part of it, we can do it at the end of when all the speakers are finished. So
Sure. Sure,
okay.
yeah, we'll move on to the next speaker,
Yeah.
sir.
So the next speaker now we have Dr. Jitendra Jethani from Baroda. He would be speaking on small things in big strabismus.
Morning, sir.
Good morning.
I will be sharing my screen. So is my screen visible? I am audible?
Yes.
So I'll be talking about small points or small things which are very small issues, maybe not very frequently seen, but they have their own importance in strabismus. These are a few things which over a period of time in last few years which I have learned and practiced. These are few things which we feel are small things, but they do hold a lot of importance when it comes to understanding and when it comes to taking surgical decisions. Corneal reflection test, we all know that it is a simple test. Most of us do it to estimate the amount of deviation, and the amount of deviation estimated is depending on the degree of eccentricity of the light reflex that we see. So this is a normal discussion that each millimeter of eccentricity is around 7 degrees, and we know that these things are useful when we are not really able to do a prism cover test. But there are a few questions. This was a paper, part of the paper which we presented in 2011. Dr. Santhan Gopal sir was the judge, and we got Best Paper Award in this particular paper, where we could show that it is the original article by Dr. Hirschberg, which was published way back in 1885, had a basic presumption that when the light is at nimbus, it is 45 degrees. And at that point of time, he was actually measuring it with a candle and not even a light. So this is how it is, and the presumption was very close. And so by these calculations, we in our work found that 1 millimeter of displacement is approximately equal to 19 prisms. See, there are two important things here. One is that this is a curved surface, and when we are measuring it, see, the difference is shown in these two diagrams. If you keep the candle at an angle of 45 degrees, it is different from the eye being rotated at 45 degrees, because when the candle is at 45 degrees, it is the corneal curvature which is being measured, and when the eyeball rotates, it is the center of the rotation of the eyeball. So it is the axial length which determines how much is the eccentricity and not exactly the corneal curvature. So the value is totally dependent on corneal curvature and axial length of the globe. These are the 2 points which we should, which are important when when you are not really measuring it with prisms. If it is not possible to measure it with prisms, we should keep these things in mind. Another thing which we started using a few years back was this particular to measure. I'm sorry for the audio. So this is a goniometer which we are using, and it is a wonderful useful device to measure face turns, but it becomes a difficult proposition when we want to measure chin depression or a head tilt towards right or left, and this becomes important especially when we are excellent talk by Dr. Shetty sir, but it becomes difficult when we are measuring the head tilt and chin depression. So what we started doing a few years back was that we started using this simple device, which is cervical range of ocular motility, very easily available, usually an orthopedic device, but it is a simple device. It has got 3 dials, and the 2 dials would straight away give you the head tilt and chin depression or chin elevation. I think a similar device by the name of oculocephalodiviometer. I saw it with Dr. Sharma sir at AIMS. So that is another device where a mirror is used, but this is a more simpler device because it gives you in degrees, and it is much easier. It's not complicated. This is a top compass which is there, where you can, once the face turn is there, you can easily measure the amount of face turn directly from this particular compass. So that was another simple device which we a lot of times we have patients where we measure ocular motility in terms of -1, -2, -3, -4, and it becomes very difficult to say what exactly we are talking about, what was our -2, and some of the orthoptists and some of the surgeons I have seen, at least in US, they use -2.5 and -2.25. It is very difficult, to make it repeatable. So this was a handy instrument which we made way back in 2010. We have modified this into a computerized based program, but that is not functional at this point of time. But this is quite functional. This we are using it. Dr. Shetty is also using at Arvind Eye Hospital. So basically, this is a simple device where we have incorporated a millimeter scale so that we can measure the ocular excursions in terms of millimeters, much better than whatever is available. And this was part of a poster which we presented in 2010 Kolkata conference, where we could give the normative data in Indian population of mean value of abduction, adduction, and elevation and depression. Okay, so another, I'm just concluding with a couple of slides. This I think is very common, but and not really all the strabismus surgeons who are practicing already know this. This is more of a thing which is for postgraduates who have started working, or fellows who have just started working up patients, that we should not stack the prisms, and we should try to separate the prisms over 2 eyes. But important point here is that even if you split the prisms over each eye, the actual deviation will not be as bad as stacking, but it will still not be a pure addition. So it will be slightly higher than that. And the tables for these are available in Dr. Rosenbaum's book. and it is a wonderful. This was work of Dr. Guyton, but the tables of how much would be the actual deviation are available in Rosenbaum's book. And this was another device which we made last year. Whenever there was large angle, as we heard Dr. Vivek speaking on true muscle transplantation, we normally would be splitting the prisms in between two eyes like we have done here. And the problem is that, a person has to hold the two prisms and another person has to either show a target or do a cover test, because when both the hands are busy, it's not possible for you to do a cover test. And so this was another small thing which we could devise, but we could not really make it commercially because of COVID. So this is a small prism holding device, and there is a spring system attached here, and there are small rubber fittings here, so to make sure that prisms don't get scratches, because they are normally plastic prisms, and for the fact that they snugly fit into the socket which we have into this particular socket. The good thing is that you can move it, so ESO, EXO, you can use it for both. Prism orientation can be base in, base out. Even vertical is also same, because this is a spring system which will hold the prisms. The problem is that it is slightly bulky at this point of time, and we are now switching over to acrylic model. But you can pull it and put the prism here, so that makes it very easy for. And there's a stick here which the patient can hold. I hope I have that in a photograph. I don't have that in a photograph, but the patient can hold the whole device, and you have both the hands free, and you can do a prism cover test. And this is just to, in short, summarize what are the orientations mainly for postgraduates and fellows. The only point which I want to make is that if there is a vertical and horizontal prism, it can be stacked, but you can give a Fresnel prism if you want to give at 30 degrees. So you can use a theorem. There's a wonderful small booklet which was sent by Dr. Santhan Gopal sir years back, and it has a chart where you can make out that what would be the final prism that you have to give when
Thank you.
Okay, I just have a small video. If I'm not overshooting the time, I can just show a small video also. This is a small video just to show that how you can. This is a very old technique, unfortunately, because as ophthalmologists, we don't prescribe, or rather go into the grinding or optical part of glasses. This is a small, simple technique of decentering the prisms and giving it to patients who have some residual esotropia, exotropia, or have diplopia and have glasses. You can easily do it with a lensometer. That was my point, that you can do it very accurately on a lensometer, and you don't need to rely on opticians. And you can mark the frame, and you can easily mark it on the slab which you can get, and you can give it to the optician and he can fit it just by decentering it. I'm showing the point how much is to be decentered, and they can decenter and prescribe up to 4 to 8 prisms depending on the amount of power that the patient has. So this is the original formula, but it is very difficult to use it. So you can easily use it on the lensometer live directly, and you can see that this equals to around 3.25 prisms, and you can increase the decentration depending on how much angle you want. So that was regarding small things in strabismus. Thank you so much, and thank you Bombay Ophthalmic Association for giving the opportunity. Thank you, Dr. Himalaya.
Thank you, Jitendra. Thank you. Some of your things are very innovative, very nice to see. But there have been some queries I think people would ask you later on. Now we move to the next, managing Duane's retraction syndrome by no other than Dr. Pradeep Sharma. He needs no introduction. Pradeep ji, please. Dr. Anand, his time is 10 minutes.
Right, sir. Thank you, Dr. Shukla. Thanks to Bombay Ophthalmic Association for giving me this opportunity. In spite of the distances that we are meeting, and it's always a pleasure to see you all that we have. So we'll be talking about Duane's retraction syndrome, a simplified perspective in today's time. As you all know, that Duane's retraction syndrome was described way back in 1879, and it's been almost over a century. But how much have we learned? There have been some changes. One is that we have come to realize it's no more a musculofacial anomaly, but it's a congenital cranial disinnervation disorder. It's a CCDD. And with the imaging, with the high definition MRIs, we have seen that we can actually document the missing nerves or the missing nuclear hypoplasia we can document, and we have come to know that. The innervation is the basic problem, and we have come to know it's a paradoxic innervation of the sixth nerve, and we'll talk about this later on when we come to clinical management specifically. The genetics is another thing which has come up more recently, but mind you, the genetic types of DRS are only about 10% cases. The majority are the sporadic ones that we are dealing with, and we will have to think about it. And in this condition, I think we have certain genes which have been identified, like the CHN1, the MAFB, the SALL4, and the HOXA1. These are more commonly associated with the syndromes that are there. Another interesting article that I would like all of you to read, and that is by Parsa and Robert in JAMA Ophthalmology 2013. Recently I had a chance to read about it, and it's something which is all of us should know, because this is one condition. If we know, then we can prevent future Duane's retraction syndrome happening. He has mentioned that it's, we all know that it's 4 to 8 weeks of embryogenesis, which is the problem. Marilyn Miller had mentioned about the thalidomide and misoprostol causing it. But Parsa has highlighted the importance of the estrogen levels and the inflammatory problem which is happening in causing the venous thromboembolic events. And that is also the reason he has explained why there is a preponderance of females having it, more commonly a DRS, which is almost like 70%, and also more commonly the left side is involved, which is again about 70% cases. And this is very nicely given in this article. All of you should read this. He has talked about this, and I think the point to be taken home is that if we can prevent thrombogenic influences, which may be because of malnutrition, dehydration, alcohol intake, infections, trauma, ionizing radiations, antiphospholipid syndromes, in the 4 to 8 period of pregnancy, there may be a possibility of preventing Duane's retraction syndromes. Coming to the management clinically, that if we have, how do we deal with, and that is I would like to talk about now. Clinically, we all know that esotropia in the primary position is the hallmark in ESO-DRS, and there is a phase turn subsequently because of that. There is a marked upshoot and retraction in adduction. There is a limited adduction because of a co-contraction, and a limited abduction, which is because of an absent innervation. Similarly, we have exo-DRS. And the exotropic DRS, the only difference is, one, it's an exotropia in the primary position, but mind you, there is much more severe retraction and upshoots in the exo-DRS than in the ESO-DRS cases. The associated problems in the eye can be several, and one of them which I would like to highlight is the crocodile tears, which you can take a history of, that whenever the child is eating or swallowing, he has tearing in his eyes. This is common. It was made aware to me by Dr. Marilyn Miller, which I used to miss earlier. Marcus-Gunn jaw winking phenomenon is another association which may be there in several of these cases. The systemic associations are in the form of cervical spina bifida, the cleft palate, facial anomalies, perceptive deafness, malformations external ear, anomalies of hand and feet, and the cardiac anomalies. And these combinations in different forms gives rise to the syndromes which are associated: the golden heart, the Klippel-Feil, Wilder-Wang, Oki-Hiro, and IVIC. Coming to the clinical management, as I said, it's a paradoxic innervation which we need to settle. And I would like to summarize the problems that how we manage. One is, look at the case, is it ESO, exo, or ortho? Second point is, look at the co-contraction, whether it is significant. Mind you, co-contraction is always there by definition in a case of DRS. We need to see if it is a mild, moderate, or severe, and this you will be able to see from the retraction in adduction and the upshoots and downshoots. Third is, how much is the normal LR activity, that means the abduction which is there from primary position to the abduction. And fourth point which we need to see is intraoperatively the forced duction test, whether it is positive for MR, LR, or both. Now let us take some examples. Now this case in which you see an ESO-DRS, we have FDT of the MR is negative, and there is a minimal co-contraction, as you can see, that there is hardly any upshoot or downshoot. So in such a case, a simple LMR recession of 4 millimeters to correct the FDT is that all that we need to do. But cases in which there is a marked co-contraction, you have to be very, very careful in doing a recession of MR. A slight 1 mm more MR recession would result in an iatrogenic synergistic divergence. So the same 4.5 millimeter LMR recession in the left eye, in this case, which is shown here, gives rise to a synergistic divergence. And this has to be then corrected by a post-operative LLR recession or a Y-split LR recession. So you always need to plan it in the first stage itself. If there is a severe co-contraction, like in this case, you see, there is a marked retraction and upshoot and downshoot, always plan the MR recession. If it has to be done for FDT being tight, always plan an LR recession with Y-split in these cases. So in ESO-DRS, we will depend upon the FDT and the co-contraction to decide. Now to improve abduction, you may do an SRT, IRT or VRT, but this is only possible if it allows the third muscle to be operated to prevent intersegment ischemia. The role of LR resection has been talked about by some prominent strabismologists, but I have my reservations on this, and I have seen their own articles. You see them, the pictures indicate that it can be a trade-off only at best, and one should be very wary of handling the LR resection, and it can only be done very small amounts of 3 to 4 millimeters, as they have mentioned, and only if the severity of the MR tightness is not much. So there is an ESO-DRS. If there is an FDT and all, there is a very minimal involvement, then a simple SRT may be done because we haven't handled any other muscle. Coming to the EXO-DRS, management will depend upon how much is the exotropia in primary position, one. Second, how much is the co-contraction, which will again be determined by the upshoots and downshoots. And third is how much is the normal LR activity. Now this is a little difference from the ESO-DRS, in which the LR activity normally is not there. Here there may be a normal LR activity which is giving rise to an EXO-DRS. So if there is the LR activity still there, we do not want to sacrifice the lateral rectus. We need to do a lateral rectus recession of large amounts, maybe 12 to 15 or 18 mm, but with a Y split of about 21 millimeters from the two ends of the lateral rectus. So this is an important thing, and just a single lateral rectus which is being tackled in such cases may be enough to take care of the exotropia as well as the marked upshoot and downshoot. Mind you, do not recess the MR, and most of the cases the MR is not tight. So never recess an MR in cases of EXO-DRS. I think we may not have time for the videos, so I would move on to this point that if there is a significant EXO-DRS and the LR activity is not there, then in such cases we may do a lateral rectus periosteal fixation. So it takes away the abnormal paradoxic LR activity altogether, and then we can do a partial VRT or an SRT according to your choice, but I prefer always a partial VRT, which gives us a much more controlled improvement. Recently, we have started doing a modified Nishida for improving the abduction. Now, this is a case of EXO-DRS in which periosteal fixation and the LR recessions in both the eyes have been done, and you can see so EXO-DRS cases, if there is in such a case nowadays, the improvement of the abduction can also be done by a modified Nishidas, which may not be hampering the anterior segment. Coming to the ortho-DRS, which are the most common problem sometimes and not being handled by most of the strabismologists, you have to be very careful in handling them because their challenge is to correct the upshoots but maintain the orthotropia in primary position. So I would suggest doing an adjustable MR recession in these cases. So to conclude, the ESO-DRS cases, you do an MR recession alone or with LR recession if the severity of the co-contraction demands that. If the EXO-DRS is there, then a large LR recession or a Y split is done in cases in which LR abduction normal activity is there. But if there is no activity of the LR, then a periosteal fixation with the PVRT may be done. In ortho-DRS, adjustable MR and the LR recession with Y split is the preference that we will do. And you can improve the abduction, taking care if the LR activity has been countered fully by using SRT, IRT, or a partial BRT. So thank you all for this kind listening. Thanks.
Thank you very much, Dr. Pradeep. As usual, you have been very comprehensively and concisely expressed about DRS. And Then we go to the next. If you have any questions, we'll do it at the end of the session. Then next we have is newer surgical techniques, Dr. Milind. You have also 10 minutes.
Am I audible?
Yes, sir, you are audible,
Yes,
and
sir.
we can see your screen as well.
Just power.
So I'll start with my topic, and I thank the organizers for such a wonderful opportunity given to meet all my seniors and friends. So I'll be sharing few of the newer things which we do, not all. So the first thing I would like to share is the vessel sparing recession. Indications are when we are operating 3 recti muscles at one time in one eye, and resurgery is on the third muscle in the same eye. So here you can see that there is a third nerve pulse, you can see that there is a exotropia and hypotropia. So
You have to speak a little loudly, Dr. Milind.
MR and LR has been done, and I am doing an inferior rectus recession with vessel sparing. Now ligament of Lockwood has been separated because I'll be doing a 6 millimeters of recession. There is a prominent vessel which you can see. With a traumatic simple plain forceps in my left hand, I am trying to separate the vessel along with few fibers of the muscle. And once that separation is achieved, then sparing that vessel at its place, the rectus is recessed behind so that the blood supply is maintained to the anterior segment, at least through this one vessel. Because lateral and medial rectus, we are losing 3 vessels. Here also we are losing 1 vessel. Here 1 vessel. And we have superior rectus 2 vessels and rectus 1 vessel. So there will be no anterior segment ischemia. Now you can see that I am carefully cutting the muscle without. So you can see that the vessel is patent now, and this is recession is being done. Next, I would like to speak about surgeries for heavy eye syndrome, that is myopic strabismus fixus convergence. This has been recently described that because the eye is very large and there is a protrusion of the eye posteriorly between superior rectus and lateral rectus. So it is nasally slipped superior rectus and inferiorly slipped lateral rectus that causes extreme ESO and hypotropia. So in such cases, we have got 2 options. Besides doing a supramaximal medial rectus recession, we'll be doing a myopexy of superior rectus and lateral rectus. So we have 2 choices, either with suture, which is non-absorbable, or a silicon band myopexy. In the first video, I am showing that I have taken a fixation suture on the sclera, although it is not needed always, and I have sutured it 2 halves of the muscle. In the second muscle, what I am showing you is I have created a tunnel of on the sclera on superior temporal part about 5 millimeters, and I have used that 240 band which is passed through that scleral tunnel so that there is no migration of the band. And then the band is taken over the superior rectus and lateral rectus, and then it is tied with non-absorbable suture. You can also use that sleeve, Watzke sleeve, but that becomes a bulkier thing. In one of the cases, it all got extruded. So I don't use the sleeve anymore. I just use non-absorbable suture. So now you can see that I am passing it through the lateral rectus, and after tightening it, see that the both muscles are coming together. So this is how you can approximate the 2 muscles and pass a suture through it, and a non-absorbable suture, and hold the muscles together. So I'll be sharing a case which I saw almost 120-degree prism diopters, both eyes ESO. You can see that hardly the eyeballs are seen, especially right eye, and medial rectus was detached and lateral rectus resected, and a cut end of the lateral rectus. And in this case particularly, a lateral rectus part was transposed to the medial rectus to elongate the medial rectus. So we get an enhancement effect of about 20 prisms by this. Now a little review about muscle transposition procedures which have been described by earlier speakers through their talks. So I'll just show you this Hamilsham procedure originally described, where lateral ends of the superior rectus and inferior rectus are sutured near the lateral rectus. There's a small video. The case of lateral rectus palsy, long standing almost more than 2 years. Similarly, I am splitting the vertical recti, inferior rectus and lateral rectus, and taking sutures on the lateral half of the muscles, and those sutures are being tied to the upper and lower end of the insertion of the lateral rectus. So you can see that I am doing the same thing for the inferior rectus now. And the muscles are being sutured near the lateral rectus. So this also improves abduction to a certain extent, besides giving you a orthotropic eye. There are other modifications like plication of the lateral rectus can be done in O'Connor's modification, Peters procedure for the third nerve palsy, where the superior oblique is transposed to the medial rectus upper end. Jensen's procedure, which is done for double elevator palsy, or a medial rectus palsy, or a double depressor palsy. Knapp's procedure, which is commonly done for a double elevator palsy, wherein we transpose the lateral rectus and medial rectus to the superior rectus. Nishida's procedure, which was commented by Dr. Pradeep Sharma sir, wherein we do the so part of the superior rectus and inferior rectus is taken nearer the lateral rectus in order to improve the abduction. So this is in short revision of all the new procedures that we use, although it is not a comprehensive talk, but I have tried to cover from my part of it. Thank you very much.
Thank you, Dr. Milind. Yes, in very short time we have been able to concise it. Very good. Anyway, then we have the last speaker now by Dr. Parikshit Bugate on strabismus resurgery. Dr. Parikshit,
Yes, sir. I'll just share my
you have
screen.
also 10 minutes for your talk, so you have time.
Good morning, sirs. Good morning, ma'am. It's indeed a pleasure to speak, an honor to speak in this session of such stalwarts. And that also has my teacher, Dr. Milind Killedar, Professor Pradeep Sharma, sir. I'll be having a short talk on strabismus resurgeries. Just give me a minute, please. Now, strabismus resurgery is that way a niche topic, and I tried looking up on the publications of it, and I found that there were so few of them. Can you see my screen, sirs?
Yes, yes.
Yes, we can see you.
Yeah, one is why resurgery? Well, as Dr. Killedar was showing, when it's a planned two-step procedure, when one step is done and now the second one is planned. For example, a 3 horizontal muscle procedure in which 2 of an eye have been done, and now we are doing the second one. Or second, if it is a slipped or a lost muscle, and we know the medial rectus is the commonest one. Or third, if the surgery has been abandoned earlier. Or fourth, it's a wrong diagnosis, an accommodative component of esotropia has been missed. So it's a wrong diagnosis or a wrong surgery or a wrong operative technique. The surgery started wrong or stayed midway during surgery. Or an intermittent exotropia that was operated and has later become a secondary esotropia. Or in cases of sensory strabismus. Or we all know in restrictive strabismus, when it is difficult to accurately get a dose-response relationship, like in dysthyroid ophthalmopathy, where resurgeries are common. Or what we more commonly see nowadays is secondary to trauma, especially polytraumas, road traffic accidents, or even in paralytic strabismus, where resurgeries may be needed. But I think the number one reason is a long-term follow-up. almost 60% of strabismus surgeries have a post-operative deviation of more than 10 prism diopters a decade after surgery, both in esotropia and exotropia. So if we have had surgeries that have been done very early in life, say in the age of say 2 years to 5 years, there is a very high chance that we are going to get these children again in their teens because now they again have strabismus. So the need for repeat strabismus surgery is not uncommon if we look at the long-term view of this problem. Well, what are the indications? Generally, an undercorrection of up to 10 prism diopters is acceptable as peripheral fusion is still possible. In young children less than 4 years, a larger undercorrection negates the indication for surgery and therefore, well, we'll have to do one soon. Or an overcorrection of up to 8 prism diopters also may be accepted. Now, the most important thing is, of course, refraction must be rechecked, amblyopia treatment properly attempted before planning the resurgery. We have to do a complete orthoptic evaluation once more. We cannot rely on all the old notes, even if we have done the surgery. It has to be treated like a fresh case. Force reduction test will have to be performed even if the original surgery was a concomitant strabismus, because now perhaps during or after surgery, newer restrictions may have developed. The surgical plan is drawn and patient is counseled because since it's a second surgery, obviously patient has more questions, is more apprehensive. In our small series in Pune of a few hundred surgeries, we have found that recess resect surgeries had lesser chances of undercorrection than bilateral medial rectus surgeries. And if initially bilateral MR recess were done, we could do a MR marginal myotomy with LR resections, or we could do a bilateral LR resection so that we are always operating on a virgin muscle. If there is an undercorrection of esotropia, if it's just 20 to 30 prism diopters of undercorrection, then one eye marginal MR myotomy with LR resect can be done. If it is a bigger one, then both eyes marginal myotomy can be done with LR resect. And for bigger, well, even more surgery. If we get an overcorrection of esotropia, which is very rare, then I think we follow the Cooper's dictum. That is to plan and execute the second surgery as if the patient has never had previous surgery. Again, for an overcorrection, do not reverse the original surgery. If esotropia has become exotropia, do not undo MR recess because we are not sure if we are undoing a MR recess, LR resect. Rather, we do an other eye LR recess. If the overcorrection is less than 10 prism diopters, then generally peripheral fusion takes care of it. In fact, a small overcorrection leads to faster reappearance of normal retinal correspondence. Again, when to operate? Ideally, we should wait. So cosmetically undesirable overcorrection after 12 to 15 prism diopters can be tackled 6 to 8 weeks after the original one, because sometimes as the muscle heals, as the conjunctival tissue heals, the alignment may change. The only exception to this is if in the immediate post-operative period, we think there is a lost or a slipped muscle is suspected by a sudden large, often consecutive strabismus, then yes, we should do a surgery as early as possible and find it. But one thing we have to understand is that now the usual equation changes. The dose-response relationship that we are used to while predicting is now no more there. And this is where adjustable sutures can be a great help. They need skill and patience on part of the surgeon and also faith and cooperation on part of the patient, because the patient also has to cooperate, has come for more post-operative visits so that the final deviation is good. We know that adjustable sutures improve the chances of good outcome, that is post-op deviation less than 10 prism diopters from 64% to 88% as in the John Hopkins series. But then we need short general anesthesia for children and even for uncooperative adults, because a lot of them, especially strabismus patients, can be very hyper and anxious. and the adjustment has to be done on the second post-op day. Again, from the Indian settings, in the last few years, I found 2 randomized control trials, one from Guru Nanak Eye Care Center, Delhi, which showed no significant difference whether we did an adjustable surgery or we did just a planned recess reset. Compared to this, another randomized control trial from KGMC Lucknow and Venue Delhi found that the modified adjustable surgery gave more predictable results. It's just that because there is more amount of effort, not just during, but after the surgery that is involved in adjustable procedures, many squint surgeons who are very sure of their results would just go on with the normal recess or a bilateral recession. But places like thyroid-related strabismus, where the final outcome is unpredictable, well, in Brazil, they have tried weak magnetic fields, or they have tried scleral implants in Scandinavia and in Brazil to put it so as to have a more predictable result. But again, this is theoretical as far as I'm concerned. In LV Prasad, they have also tried horizontal rectus muscle transposition, transplantation. But whatever it is, we have to understand the pitfalls in resurgery. One, normal anatomy is disturbed, and identifying the muscle needs experience, skill, and patience. So this is something that is best done by an experienced strabismologist. So be prepared for surprises, and this has to be counseled to the patient, is that because after the first surgery, if the outcome has not been perfect, well, the chances are after the second surgery, there may be something different. Also, if we are in doubt, it is better to grade the surgery to tackle 1 or 2 muscles at a time rather than attempting multiple muscle surgeries. So, well, thank you again. Thank you to the organizers, BOA, and of course, Dr. Himalini for giving me this opportunity. Thank you.
Thank you, Parikshit. Very nicely you have highlighted some of the problems. Well, we all know about that. Now we are going to take some questions.
So we still have Dr. Vivek's residual talk.
Yes. Sorry. Yeah. Please. Yes. That's why I think a lot of time. So I thought, what happened? Finished well in time.
Right.
Yes. Is he on the line?
Yeah, he's online. He's got his next slide ready.
Yeah, please.
So,
you
over to you, Dr. Vivek.
Yeah, can you see my slides, please?
Yes, Dr. Vivek. We can hear you and see your slides as well.
Yeah, so sorry for that glitch. So I hope, like I had, I was able to run the video for muscle transplantation in ET and XT. So moving forward, so this is the first case of, the 19-year-old male child who presented with inward deviation of the eyes since birth. So basically, he was a case of, the infantile esotropia who has presented at later age in life. So on cover test, he had 60 to 70 prism diopter esotropia and had undergone, R&R with muscle transplantation of 8 millimeter to MR. So you can appreciate that at 1 week, there was a remarkable alignment in primary gaze and a very minimal adduction limitation in left eye. So at 3 months, the palpebral fissure height is comparable and there was no cosmetic blemish. And on the primary gaze, on cover test, he was ortho for distance and near. At 12 months, so basically, at long term also, they would have a very good outcome with improvement of the stereopsis over a period of time. So you can appreciate the motility is full and free and there is no motility restriction with a very good alignment compared to baseline. The second case was a 23-year-old male who presented with the shaking of both eyes since childhood and loss of vision in both eyes. So he was a case of infantile ET with uveal coloboma with 70 to 75 prism diopter right esotropia. Again here the LR transplantation 6 millimeter was considered to MR, and at 2 weeks there is a very good alignment in primary gaze with a motility limitation, maybe because of the short duration of follow-up. However, these patients, they do achieve a good motility and long-term follow-up. The third case is a 15-year-old male child. This is a very interesting case I came across. This was a extra large infantile esotropia with almost normal motility. So I decided to go ahead with a bilateral R&R with to put him on, the muscle transplantation in a left eye for 7 millimeter. And you can see that at 3 months follow-up, he had a very good alignment with residual isotropy of 18 to 20 prism diopter. So basically, if you see, even considering, one of the eye with R&R and transplantation, the palpebral fissure changes are very minimal with, the almost full and free motility. So if you look at the evidence, Dr. Hayat and Dr. Diamond has already talked about, but if you look at our context, Dr. Amitava has very well published his first 3 cases of use of, muscle transplantation in large angle isotropia. And even Dr. Jethani has used this procedure in myopic strabismus fixus, combining this with the loop myopexy. And I think he has the largest series of 22 patients of the use of muscle transplantation in large angle isotropia, and he has shown that it is a safe alternative and viable option because of the long-term stability. So switching the gears, so the case 4 is basically a case of the congenital large exotropia due to the strabismic amblyopia. The exotropia was 60 to 70 prism diopter. Here again, the harvesting the muscle segment to be transplanted from the MR. So it was usually of a shorter size, 5.5, and then you can appreciate at day 1 and at 6 weeks there is a remarkable improvement. Although there was a residual exotropia and induced, the vertical deviations. So you can still see that there is no motility limitation, and palpebral narrowing changes are minimal or absolutely not at all. So this was another case, yet another case of the sensory exotropia in high myopia due to anisometropic amblyopia. You can appreciate the outcomes of the surgical procedures, which gives a very good primary alignment with motility improvement.
Is that all finished?
No, I think there's some network issue. I think anyways he was about to conclude, so I think we can take the questions, sir.
The time is already over, so that I call on board Dr. Pradeep Sharma also to answer some questions if there is from the audience also on all, and the speakers also if they have some queries, some questions. This is open session now.
Yeah, I think I would like to make a comment on the first talk, which was very nicely presented by Dr. Shubhangi on acute concomitant esotropia. I think it's become a more relevant topic nowadays with the lockdown and the children using more of the screens, and we are getting more of, I mean, there is a sort of epidemic of acute concomitant esotropia is also coming because of a little bit of convergence spasms which these children are having. So we need to distinguish some of these cases which may be having an accommodation spasm. So we should do a proper cycloplegia, preferably an atropine cycloplegia in such cases. Also see if the the NPA, near point of accommodation, has come closer in these cases. Then these are like the spasm cases. But otherwise, they may be the acute concomitant esotropias as described earlier by Burian and Wilczowski. So those cases I think we have to keep in mind. That was one thing which I was thinking. The other thing was the Botox. I mean, we are all understanding that these cases have diplopia. They are always having binocular vision and diplopia. So Botox is one thing which may have a problem because we do not get a quantifiable, predictable response. I would rather go with a surgery if I have to do, and with adjustable sutures, so that I can give a more predictable result to take care of the post-op diplopia.
Just a question, sir.
You are muted, Dr. Shubhangi, you are muted.
Yeah. I think, sir, they have said that in younger kids, injection Botox works well in such cases, though I have personally not tried. But of course, surgery with adjustable is the gold standard. But in some cases who are not willing for surgery, or then Botox can be tried because they have given good results with Botox in such cases.
Yeah, but there will be a post-exotropia in these cases. And what we are talking about, the younger children having a different response, is mostly limited to the infantile esotropias. This is
No,
probably
sir. In the acute concomitant only, in children less than 12 to 14 years, they have found good response, and they even recover with just one muscle of, just one injection of Botox.
yeah. So they may be, I mean, then we have to see what kind of, was it just an accommodation spasm which has relieved by a shock? I mean, we'll have to see what are the cause of that case.
Yes.
Maybe they might be having a good divergence fusional amplitudes. So maybe giving one dose of Botox if the divergence fusional amplitude is good. So maybe no, they might get better. If the divergent fusional amplitude is poor, then you may have to operate them.
I think a small comment what I like to give is I 100% agree with Dr. Pradeep that in these times the accommodative spasm, is very important. So before doing any treatment or thinking of any treatment, you must do a good cycloplegic refraction first. That is number one. Secondly, it could be a decompensated esophoria also, because now the recent times the people are working on the computers for a long time, and the esophorias can get decompensated. So you have to look when the esotropia which is occurring for near and for distance. I think a proper workup of the patient is very important before you embark on any of the further treatments. And botulinum, I have not seen anybody giving botulinum toxin, even abroad also on this sudden. What do you think, Dr. Pradeep?
No, people are giving Botox. I think people are giving Botox. I have seen that they are giving, even in acute concomitant esotropias, there are papers on Botox. And of course, in infantile esotropia, the work done by McNear, I had a chance to see myself being there as a fellow.
I know infantile, I agree. Infantile, I agree, because you have to buy time for surgery. And so that is congenitally, that is a different thing. But anyway,
it is given.
Yeah,
Sir, any role
I have
of
seen, Dr.
anticipation?
David Hunter using Botox in patients with AACs. So yeah, it's been given, and they do have a very good outcome.
And yeah,
Any
maybe
role of waiting in these patients?
any other question on the other topics, because we have just 10 minutes now.
I wanted to ask Ankur one question which I put up in the chat box, if that's all right, just about his preference for chicken suture or spacer in Browns, and if the long-term results favor one than the other as far as complications or restriction is concerned.
Dr. Manjushri, I prefer chicken suture over spacer, because one, it is easily available. I feel it is more titratable, and then there's less chances of having fibrosis as compared to the silicone expander. But in the private practice, we see Browns once in every 4 or 5 months. That also, when you explain them, the patient runs away. So I don't have significant number of cases which I have done in the private practice, and I can't say about the long-term results.
What suture non-absorbable, Ankur? What suture do you use? Non-absorbable, which suture?
Sir, I use Ethibond, sir. I've been using 50 Ethibond, which is usually available because of my retinaculi, and nylon is little difficult to tie because it slips off. Ethibond is braided, so it is easily you can manage easily. Nylon tends to be little stiff and difficult to tie knots, so you have risk of
nylon also give reactions. So,
yes, sir.
Ethibond is what you prefer.
So that's why we the polyester.
That's why I prefer Ethibond. Yeah, I prefer Ethibond to lengthen the tendon. That's in short, and they're good for short to moderate terms. I just can't talk about long terms. I think Sir can help us more. Dr. Pradeep Sharma, he's been.
Preference is a hangback loop tenotomy at the distal end of the on the temporal side, rather than doing a nasal procedure in superior oblique situations, because any infection in the nasal compartment, in the superior nasal compartment, is something which is not desirable from my point of view. So I would rather do a temporal hang loop tenotomy for the Browns, and I find very good results. These are titratable. You can do an adjustable on the table to take care of the FDT. So I find this a much more cleaner procedure.
Okay. So when you say hang loop, sir, it's like a adjustable knot that you tie, do an FDT, and then tie a final knot?
I'm doing the superior oblique, tying the 50 Ethibond sutures, and then you do a 8 to 10 mm of hang back recession, just like you would do for a recession. as the recti, and then adjust it on the table. You may even do it if there's an older person, you can adjust it as a 2-stage procedure also. Yeah.
Sir, is it similar to translational recession described by Pluto Dias?
No.
Translational recession.
Translational recession actually is restitching the superior oblique on the side. It's on 12 millimeters from the limbus and 6 millimeter nasal to the superior rectus. So it's, a procedure which I have done in some cases prior to doing this. I think that is a procedure reserved for very severe overacting superior obliques, maybe 4+ or 5+ when you have to go more nasal.
Does it cause limitation of depression in abduction?
That's what this is, that it's a controlled
cause. Yeah.
You not have a limitation of depression in deduction, which is something which will happen with other procedures. And the chicken neck suture, there is a possibility of cheese wiring, and especially if you don't use a ethibond with the proline suture, there will be a cutting through of the muscles more likely. So we should be careful.
So Ankur, did you have any case of superior oblique palsy following chicken suture for Brown syndrome, and how you managed?
So not exactly, sir. We did not come across superior oblique palsy. In fact, we tend to be a little more on the conservative side in the private practice. So we are better off with residual Browns than superior oblique palsy.
Which is correct, actually. One should always try to trade off.
Because in any case, if there is any...
In fact, it will be all the more difficult to deal with the superior oblique palsy once you have with the, in the Brown syndrome, if you land up with superior oblique palsy.
Not really, because most of the people in the West have been doing inferior oblique recession.
Along with the superior,
They have.
I have one question
doing
for
too many
Vivek.
surgeries, too many muscles in one go is again, leads to more unpredictable results than doing stage one by one.
Avoid them, you should.
This is regarding the muscle transplantation, Dr. Manju, and there are a lot of questions on like how the transplanted segment is being titrated. So I think for the esotropia and exotropia, I usually consider 4 prism diopter per 1 millimeter, and for resurgeries it is around 2.8 to 3 prism diopter per millimeter. Probably Dr. Jitendra also can opine on that.
I think I would like Jitendra to confirm this fact, like what you were doing was trimming of the middle rectus segment, the lateral rectus segment for an esotropia correction. You're reducing the amount of resected muscle, whereas I think what I remember from Jitendra that he was using the full cut segment for his.
I was using the full cut segment, sir.
Yeah.
So I've
Jitendra, just a minute. You tell me one thing. What about the vascularity? What about the vascularity persistence of this cut segment? Because that is a big question.
No, sir, that is already established. There is no vascularity. I mean, it is a fibrotic.
It becomes a fibrotic band.
Yeah,
it becomes a fibrotic band. Yeah, it doesn't act as a muscle.
No, it doesn't have. First of all, it is tendon. It doesn't have any sarcomeres. So it doesn't have any contractile property. It was not being used for the contractile property. The only advantage over a spacer is that it is the part of the patient's own body. And so the chances of rejection or extrusion are less. As Dr. Vivek showed in the original article just published by Hayat in 1974, he did it on chickens and tried to suggest that this can be done in humans also. And it is basically, so he could go back into those animals and see what was happening to that segment. So he could even publish the mic. So his was actually a big article of 25-30 pages.
Agreed. But the tendon of each horizontal muscle has a specified length. So you cannot do more than that length. So what he was talking of 4 millimeter per.
No, he was saying the dose response, sir. He was telling about dose response. Per millimeter, you will get a correction of 4 prism diopters. That is what he was trying to suggest.
So suppose there's the diopters of more diopters you have to correct. Then you can't use it a tendon more than a specified length.
Sir, we are already
you can't take out more than
diopters.
You can't take out more than 9 or 10 millimeters of LR.
Yes, that is important.
Plus, once you tie out, you will lose 1 millimeter on either side.
And we are working in front of the arc of contact. We're not.
That is the most important point.
So that is why we don't have any limitation of movement. But I've never tried this patient in a patient with 6/6 vision. I've just tried it in patients with sensory esotropia or exotropia. So that was
I have tried it in 6/6 patients. I have even tried it in nystagmus patients who are already operated for some strabismus surgery, and patient had face turn. And so we had to go back and do the surgery. We've done it in resurgeries also where, there's a good paper from LBP in strabismus, which was published in 2021. And we have done it in vertical strabismus in thyroid cases also where there have been, I had presented that in Baroda strabismus meeting. There was a patient with a huge hypo, and fortunately we had a couple of more patients in which we could try our hands on, and we got good results. I mean, in terms of motility, see, correction in primary position is can be done with supramaximal recession and resection. Also was just talking about motility, and it was restoring motility, so we stick to it.
So how do you explain the improved motility, Dr. Jitendra, in the gaze of direction of the recessed muscle as compared to a large recession of the same muscle?
So this we just have hypothesis on this, that since the part of the muscle still remains anterior to the arc of contact, the muscle is still anterior to the tangent, and so the arc of contact is still maintained, and that probably explains the good ocular motility that we get even after doing such a large recession.
Jitendra, do you check for suppression scotomas? Because in esotropia, you will have patchy suppressions. So in a patients who are esotropic with amblyopia with patchy suppression, and you are getting them out of those patchy suppression to an area where they are seeing. So we had 2 or 3 patients who had large angle ESO, and when you took them out from that suppression scotoma area, they started getting double vision. So how do you manage those patients? Or do you have to check any large angle esotropia? We need to check for suppression scotoma, like correct their angle and see whether it become diplopic at that area.
Would be very difficult to, sir, check at 80 prisms. You have to keep 40 prisms on in front of each
Synaptophore, can we check synaptophore?
Yes, sir, we can check, sir, but synaptophore again is not a very physiological device, measures mainly for distance. These are things, I mean, you can check it, there is no doubt about it. There's a wonderful article by Dr. Kushner where he has used prism offsets to predict post-op diplopia, but these are not short things. We can predict it, we can tell the patients, we can definitely go ahead and do it. Normally, we would do it in most of the patients when we are doing, when they have good vision in each eye. We try to, when you do a cover test and you are finishing your prism cover test, you just ask a simple question to the patient whether he's seeing double or not, and whether you want to reduce the prisms just to see that whether that particular amount of prism would lead to diplopia or not. I did not have this problem with such large angles.
I think we'll just take one last question. The chairpersons of the other session have already arrived. Just one last question and then we can conclude.
One of the patients of Vivek had nystagmus with large angle esotropia. Suppose the patient had a face turn, that eye was amblyopic right eye. Suppose the patient has a face turn to the left side with large angle esotropia in the right eye. So how you would have proceeded, Dr. Vivek? Because that had a coloboma in the right eye, you said. So his vision must be definitely poor in that eye. Suppose that patient has got a left face turn with a large angle right eye esotropia.
Yes, so basically, that patient had a bilateral uveal coloboma. That is one thing. Second thing is, fortunately, there was no AHP. Otherwise, I could have, planned him, the dominant eye doing R and R with, the muscle transplantation. So that would take care of both, the AHP as well as the amount of deviation.
Dr. Pradeep, just one question from Dr. Parikshit, you were saying that in your resurgeries that even after 10 years, you can get more than 10 diopters of ESO or post-op surgery. But normally what we practice is we wait for 3 months, and if the correction difference is more than 10 diopters, we again take it for surgery. So we can't wait for 10 years, and you have to explain to the patient that, because more than 10 diopters is obvious. The patient who is
No, sir. That was data from John Hopkins, who said that in a 10-year follow-up, almost 64% only were within 10 prism diopters. So when they did their audit, in the first 6 weeks, almost 90% of them are within 10 prism diopters. It is after 10 years, so many of them, their deviation changes because as they grow up, the deviation will change.
Dr. Pradeep Sharma, you have any comment on this?
No. I think this is a long-term data, and it's their data. We cannot comment on that. It's their finding. We may be luckier that we have less than 60%, maybe. But
yeah.
Dr. Parikshit, you know what I had experience regarding the resurgeries. I think we should be waiting a little longer, because as you wait longer, the muscle get lengthened, and then even if you do re-reset, then there is a less co-contraction. So I think it's better to wait for a couple of months. And
no,
then,
normally we
No,
would
couple
say
we
3
wait for
to
3
6
months.
months.
We definitely wait
6
for 3
months.
months, and you tell the patient at least 3 months we wait. And if because the patient becomes jittery, because if there's more than 10 diopters under overcorrection, whatever it is, the patient in the family also gets worried and keeps on asking questions. So you have to, after 3 months, you have to do something. We can't wait for 10-year long period. As Dr. Pradeep said, it is their data, and 10 years long, the patient may not come back to you also. So the story ends there. I think we will stop here because there's a signal.
Okay.
Thank you very much. Thank you
Thank
very
you,
much,
sir.
everybody. Nice seeing you and nice talking to you. And thanks to Dr. Lahane and also Dr. Himalini and Dr. Ragini to give us this opportunity here on this platform. Thank you very much, everybody. Take care and be safe. Thank you. Bye-bye.
Thanks to all the speakers and audience.
Thank you.
Thank you,
Thank
everyone.
you, everyone. Thank you.
Thank you.
Hello.
Morning,
Hello.
sir.
Morning,
sir.
Ashish, can you hear me?
Yes, we can hear you, sir.
I changed my headset, so I just wanted to confirm that you're getting me or
No,
not.
can you hear me?
All good. Yeah, perfectly clear.
All good. Yeah. Sujata ma'am. Good morning. Good morning, sir.
Morning, Sujata. How are you doing?
Good, sir. How are you?
Perfect. Absolutely fine. And Sunday morning, I think so rather than having brunch, we're having chat here. I think it's worth it. How are you doing? Otherwise, all good. Work must have reduced a lot, and
We are on
only
lockdown.
writing is going on. Okay, so only writing work. Yeah, same here. Same here. So I still do manage a emergency pediatric cataract in between from last week, because earlier they were not giving EPA because oxygen they didn't want to use for the routine cases. So now they started doing it. So let's hope by next week that's like double figure again. Let's hope for the best. Are we on time?
Yes, we'll be. We
Ashish?
do not have Vijayalakshmi madam still logged in, so I'm just contacting her. She's going to be the first speaker.
So you is the person who will get from everybody. That's why you are called Doshi. Huh? Any mistake goes wrong, you will be caught. Doshi aapki ho. I like the name. नहीं सोचा था he is Doshi. पहले से बोल दिया इसी का गलती है. All mistakes are his. Credit is ours, right?
Credit is ours, yeah.
Good. Doshi. When I saw the name, I said, oh, well, I should tell him that, it's sounding good. All right, so what's happening now? Let's get over with this also. So for a change, I don't have anything videos to be shown because it's a pre-op workup, so I'm relaxed. I don't have to check my videos, otherwise there's always a glitch that video might not work. But recently, I think in the Zoom platform, the videos are working very well, actually. So it's good. Sujata, what are you covering? Sorry, I didn't see the topics.
I'm speaking on IOL calculation in children.
Oh, perfect.
So
of course,
have much.
children. Yeah, that'd be good, interesting topic. I think that's the most important one, people to understand that how much and where and how much under correction. It'd be good. It'd be good. And Kavita, how are you doing? You have to unmute yourself, please.
Sorry, sir. I'm fine, sir. Thank you, sir. Nice to have all of you.
Perfect. Perfect. Looking forward to.
So just give me a couple, 1 minute, ma'am, sir. We just
You have to give us time, you know. We are at your disposal.
We are just
You're
waiting
the
for
coordinator,
Lakshmi,
right?
madam. Just contacted her, so we'll just wait for a minute more.
Sure. In case she has a problem, I can start with mine and she can come. I mean, if she wants,
Vijayalakshmi
I mean,
madam
it's
is
okay with
just
me.
logging in actually.
Perfect. So if it's up to you guys, whatever you want, I'm ready anyway. And Doctor, I think Jagat is not coming, and somebody else is
Yeah, so
putting
Dr.
his video
Simar Singh
across.
will be presenting on his behalf.
The video, yeah, it's a video basically with the audio also. I think. Right. Yeah, Simran is there. Hi, Simran.
Yes, sir.
Simran, sorry. Simran, तो वो picture में थी ना वो. Right. So how's PJ doing? Again, shut down like AIMS only?
Yeah, so ma'am is logged in.
Shut down, sir.
So we can kick off the session. So welcome to all of you. We have this session 3 on pediatric ophthalmology on pediatric cataract. I'm Ashish Doshi and I will be moderating this session. We have Dr. Vijayalakshmi as the chairman, Dr. Lahane sir as the co-chairman, and Dr. Nikhil Gokhale as the co-convener, and co-moderating with me will be Dr. Pankaj Shah. So we will be introducing the speakers as we come to them. So first we will have Dr. P. Vijayalakshmi. She is from Arvind, as we all know. She is the chief medical consultant in pediatric ophthalmology and also the chief of Vision Rehabilitation Center at Madurai. So we'll invite Dr. Vijayalakshmi to give us talk on. Cannot hear me? Can you hear me?
Yes, do you hear me now?
Yeah, we can hear you, ma'am.
Yes, we'll start.
So please go ahead, madam. Your topic is assessment and intervention for cortical visual impairment.
Yes. Right. Full screen put on. Yeah.
Please share your screen, ma'am.
Yes, we are doing.
Cannot hear you, ma'am.
Is it okay? Is the slides or seeing?
Not yet, ma'am.
Not yet. What do I do now? So it's a scene here. I focused it.
You need to share the screen, ma'am. The green button down.
Where is the which one to click on?
The green one, ma'am.
Green one, the share screen, ma'am.
Make it full screen first, ma'am. Then the button will be visible.
Button was not visible with the full screen. I don't know why.
You can ask I think you ask a young kid next to you. He'll be much smarter at the gizmos.
He was only helping me, my grandson.
I know.
So
True.
the green light, where is it? Where is it? PowerPoint before there was one which was wait.
Madam, you need to open your presentation first and then share the screen.
Yeah, I have opened it. It is there. Open full screen.
I'm on the Zoom platform, no? The Zoom screen. If you can see all of our names there, then on that screen below there is in a green thing written share screen with a small arrow. So if you just click on that button, you will get the windows on the computer and you click on the presentation.
Yeah, I see the green one. I see the share screen. And then my PowerPoint. You have to click the power. Now.
Yeah. When you see the PowerPoint slide of yours, you can minimize this now, and the PowerPoint must be in the background, and you click the PowerPoint.
Minimize it now.
And
then the
PowerPoint.
PowerPoint.
Yeah, just click it.
Yes.
Yeah, that's the way we used to do.
Yeah, just a minute.
Yeah, sure. Please
coming,
take it. No hurry, ma'am.
Good afternoon, Dr. Khokar sir. Good afternoon, Dr. Vijaya Lakshmi madam. Good afternoon, everybody. Nikhil bhai.
नमस्कार, कैसे हैं आप? ठीक हैं?
बस
You're safe
बहुत
and
अच्छे हैं sir.
sound?
बस everybody please be safe and please take care.
Yes, that's the motto.
Few seconds.
Dr. Lahani sir is in a meeting with the CM. I think he should be here. Good afternoon, Dr. Guha madam. Good afternoon, Dr. Ashish.
Good afternoon, ma'am.
Dr. Jagatram sir, I think he also is busy, but Dr. Simar is here. That's why Jagatram sir will be here. Dr. Kavita madam, Dr. Zai, Dr. Pankaj Shah. Everybody, good afternoon. Hi, Dr. Prachi.
Hello, ma'am.
Good afternoon, madam.
Should we start with the next talk?
Okay, if you want to.
So as we wait for ma'am to log in with her presentation, we will have Dr. Sujashan Khokar. He's from the RP Center. He's the professor and head of the unit, cataract and refractive surgery, and he will be speaking on pediatric cataracts, the preoperative evaluation.
Right there, my screen is there. See?
Ma'am, ma'am, we are starting with the next one first. You are still not on. Okay, we'll just wait for you to sort out.
Okay, thank you, doctor. Thank you.
Okay, okay. Sorry, ma'am, I'm butting in, but I think because of the lack of time, I think we should start.
No problem, no problem.
Welcome, ma'am. Okay. So, are my slides visible? First thing?
Yes, yes,
and am I
yes,
audible? Okay,
yes.
perfect. Okay, so I would like to thank Dr. Lahane who has given me the opportunity to speak on this topic, and this topic is very close to my heart. Anything to do with the pediatric cataract, I'm the first one to jump in. And well, we've been doing it for the last 25 to 30 years, and we realize there's certain things which everybody does the things a little different. So there are a few things which helps other people to learn and understand. And I don't know how much sense is going to make what I'm going to tell you, but please try them, because we've been trying these for the last 15, 30 years, and we have realized that they do help in the long term. Okay, so this topic is called pre-operative evaluation. Now, the issue is, this question is, why are we talking about this? Is because it's a big issue. It's not small. If you see the number of patients, 1 to 15 in 10,000 live births will have a pediatric cataract, and a pediatric cataract is totally curable thing. If you can pick it up early, operate this patient, put an implant, glasses, whatever. But if you leave them alone, they're going to be blind. That is for sure. So that's because of this in mind, the WHO says that if you operate a blind child, it's better than treating an adult, because you helping around 10 adults is equal to 1 child. Okay, we did a study about this, was about I think 8-9 years back, in which we got the data from the lens clinic, the abnormal lenticular changes which the children came out with, and we saw about 1,047 patients we saw. And what we noticed was the developmental cataract was in about 45% of these patients. Traumatic was about 30. So traumatic cataract is the one which is the most unfortunate, because these are totally preventable. Because if the kids are playing with crackers or the bow and arrow and somebody supervising, they can definitely save these eyes. But once they have a perfecting injury, the visual prognosis actually goes very bad. And the third one, which I'm trying to show you here, is the last one, which is a visual excess opacification. That means somebody has seen the cataract and done the surgery, but has not done it properly. So about 7% will still go blind if they don't follow this patient. So dictum is to do the surgery, evaluate well, and keep following these kids up for at least for 10 years. I think the dictum should be at least for 10 years. Okay, so the story starts basically with the parent counseling and the eye examination of the parents. Now, why is it important? Because the parent walks in and says, "Doc, why is my kid having a cataract? And isn't the cataract a problem of an adult, for a senile or a grown-up person?" So we have to tell them, no, there is a certain subset in which the pediatric cataract happens, and those are actually increasing in number. 20 years back, we used to get about 4 to 5 in a week. Now we get about a 15 in a lens clinic every week. So that means it's really going up. What is the reason? Maybe this is being referred to us, or maybe people are picking up early. But at my center, we're getting more patients, 3 times more than what we used to get about 10, 15, maybe 20 years back. Eye examination of the child. Since I'm sitting in the hospital where we don't charge anything to the patient, the only thing I charge the patient is that both the parents will come, and I'll dilate the pupil, and I'll do a distant direct for both the parents. Then only I'll start seeing this patient, and I'm very rigid about it. Even if the one parent has come, I'll call the other parent the next time, because I want to see what is the pattern. Where are we going? Is the mother father having cataract or not, because lots of patient transferons are being picked up now because of this. And proper systemic examination in these patients is important. And I'll just, I think, rush through the thing. So what you need to know in the pediatric age group first is whether it's a lenticular change or it's a leukocoria because of cornea or behind the lens. Then against the red glow, you see the size of the cataract, the site of the cataract. If it's off the center, you don't have to bother. If the size is less than 3 millimeter, maybe 2.5 millimeter, you still can do a refraction and get away, whether it's a unilateral, bilateral, and all the associated oculars and systemic findings, which I'll be telling you soon. Okay, so if you see anterior to the lens, the columnar repeaters and corneal opacity, and in case you're able to see, it's good. If the child is too small, you're not able to see, best is to put these children under anesthesia, examination, and be very sure before you actually put in the blade for the surgery. Because if it's a PHPV or a thing at the back or a toxocara, you have to put a retina guy on the lookout. So this plus all the investigation, ultrasound is a must in this patient. First, you see the pupillary reaction of the patient, then put an ultrasound for this patient and try to see all these patients. And how do you see? I'll be telling you in a little while. So let's start here now. Now, this is a patient in which you have to assess the vision. Visual assessment is very important. Now, you see this child was operated both eyes, had a pseudophracus with a glass on the top, and he's so happy to see the vanishing optotype. So this is the Cardiff chart, which will disappear at a distance and will come at a certain distance. The moment the child sees it, he gets excited. So we know that he can see. Okay. Now, this is a second example. All these cases of cataract, you try to cover one eye and cover the other eye. You see, he won't let you cover one of the eyes. Better vision eye, he will not let you cover. Ocular movements are very important in this patient. If you see this patient now, he's got a total white cataract. He's very comfortable in father's lap. It's facing in front. Now you notice the eye, they're rotating on the z-axis. It's going to x-axis, y-axis. So there's not a particular pattern in this one. So we expect that this patient, now you see it starts getting the pendular movements also when it's trying to fixate, and it takes the eye into the EZO. Look at that, now it's happening. So he's got all kind of patterns. So I've showed you this one because always record. And after the surgery of first eye, record again. And after the second eye surgery, record again. And then after 6 months, they come back, he's doing a face-off. You must have seen that movie in which John Travolta and this guy is there. So Nicolas Cage, they're doing the face-off. So that's it. So this is a very important thing because we realize that the amplitude of the nystagmus reduces after cataract. It never goes away. It always stays, but it reduces. Now that's another one now. If you see the eye, where is the eye? If you put a scale from the superior bone orbit to the inferior orbit, you can't touch even the lashes because it's gone deep in. So he's actually rubbing the eye. So this is a case of octodigital phenomena in which we didn't expect good vision. But on evaluation, you see he's following the light so well. So this patient actually got good vision after the surgery. So even if the eye is sunken with the oculodigital phenomena, please don't write them off. Always give them a chance. And that's what a Bruckner's reflex is. You can see a glow in one eye and a cataract in the other eye. Okay, I go to the next one now. Okay, all right. Okay, now this was the paper we published in which we said the best way to put the child is on the mother's shoulder, facing backwards, because the entire body of the child is in contact with the mother and the child is comfortable. We realize that they're crying when they're looking front. The moment you turn them around, it's as good as seeing as a slit lamp. So any kids who are less than 6 months, you do this one. 6 months to 1 year, you can see them anywhere. People who are less than 3 months, who are not holding the head, you can put them flat and do it. Okay, and bigger than that, you can put them slit lamp. Okay, right. Now see, this is a bilateral cataract, whitish and grayish, look fine. Now this guy also was referred to me as a bilateral cataract. But the moment he put an ultrasound, we saw there was RD in both eyes, so we had to refer to the retina people. The lenses were clear in this patient. Now notice this one. This is a patient in which there's a leukocoria, but it's a shifting leukocoria. It's not staying in one position. You can see the glow, and the other moment you see the glow going away. So that means whatever is there is mobile. So if it's mobile, it could be a subluxated lens. If you're not able to see properly, that's a guess. Second is something at the back, behind the lens. That's why the movements are going opposite. You see at certain areas, the eye is absolutely fine. So this patient was a patient of ROP bilateral. Now you see at this end video, both eyes having good glow. So don't be in a hurry to operate these patients. Okay, so ocular associations could be any. You can see this list. I think there could be many. So if you find a unilateral cataract, always look in the eye for the problem. The eye will tell you what is the problem. Whereas the bilateral, you have to look at the systemic problems. The systemic conditions will cause bilateral cataract by and large, maybe say 99%. And ocular will be seen only and only in unilateral, but yes, you can sometimes get in bilateral also. Okay. So systemic association could be a torch infection, the infection which is common. We know about rubella. Then you have galactosemia, and let's, I think, run through it. Now, this is the second thing which we added on, which we're not doing earlier, which started about 10 years back. We do a head circumference of these kids and measure it. Now, according to the pediatric people, Indian Academy of Pediatrics, the guideline is that if it's less than 1 standard deviation small, we call it small head circumference. But if it's less than 2 standard deviations smaller, then it becomes microcephaly. And we found about a large number of patients in our subset who had microcephaly, but they didn't have any rubella or anything. So we can have patients with smaller heads and have cataract, and there's so many condition combination. We still don't have any names to that, but yes, if you get a cataract, please always measure the head circumference. It makes a difference to the follow-up. And you can look at this picture now. This is a rubella, a typical small head. Now, this patient looks normal, but his head is big. So he was hydrocephalus, and he was actually put a shunt later on. Okay, coming to the familial syndromes. 1 minute to go. Okay, so, all right. So the commonest syndrome is Down syndrome. You can have all these funny syndromes coming down the thing. But this is one of the Nance Horan. You have to see the mother. Mother is a carrier. She can have a cataract, a sutural cataract, but the vision usually is normal. So the kids do have an inverted panna like a PK movie guy, and that's how the cataracted mother looked like. Now, this was a patient in the Huneman syndrome. One limb has gone small. I think I'll just jump through this. Downs, everybody knows galactosomia. If you have a jaundice and the failure to thrive at birth and a cataract, chances are it's a galactosemia. Please always overdiagnose it and ask the pediatrician to have a look and get the enzymes checked in these patients. Okay, then genetics is important. We found 2 new loci recently, and this is what the lenses look like. So the ones in which you can do a refraction, you can get away and you keep following this patient up. The ones in which, like this was a mother's eye in one of the patients. She has good vision, but there was a cataract which was in the periphery. And you can get all these funny cataracts. Yeah, you have to see the morphologies, and there are certain set of morphologies which tell you. Yeah, okay. So the most important thing for you people to do is to do a EUA. In EUA, what you're supposed to do is you're supposed to do a measurement of the white to white in these patients. If the white to white is corneal diameter is less than 9 millimeter, you're not putting a lens, and do an exit length. And everything has to be calculated on the table. So you have to have a good inventory of the IOLs. You should have a inventory of the IOLs, 3-piece lenses, single-piece lenses. Then only you should do these surgeries. Otherwise, I don't think you should be jumping into the fray, because you might be having a problem with that. So I'll just run up this one. And once you're done, you can actually do a UBM in these patients. And we have done a study on the UBM in which we found that there are lots of peculiar findings which find with the UBMs. And these are the few of those ones which I'm just rushing through. And at the end, I'd like to say that if you're putting IOL in an Indian setup, I think you should not put lens if the eye is less than 17 millimeter in exit length, white to white less than 9 millimeter. For the more than 5 years, they put no undercorrection, maybe 2%. And for the 2 years, do 5% undercorrection. And this is a normogram which we published, and this is what is more applicable for Asian eyes. And that's about it. So just to finalize, summarize, a comprehensive history of the parents and the eye checkup is very important. Ocular systemic examinations are very important. Basic examination biometry has to be done at EUA time, because you can't afford to have any error, because you're anyway going to do undercorrection. If there's an error and you add on more error to that, it's going to actually magnify the problems. And tailor-made investigation, not for all, investigation for all, and clean surgery, ambulatory treatment, and follow-up. Thank you very much. Sorry.
Thank you, Dr. Coker. We will have Dr. Vijayalakshmi logging on first. First speaker is still remaining. Sure. And meanwhile, we can have any questions for Dr. Coker.
Yeah, sure. If you have questions, I'm ready to answer, please.
I have a question, sir. So for an isolated non-familial cases, what's your practice for genetic analysis and genetic workup? Ma'am, please log on.
No, we're not doing it. We're not doing anything for those patients. See, we did a study which we wanted to send the genetic investigation for most of the patients. We started taking a bilateral with the one in which had a family history. So we sent about a 50 patient to the genetic lab, and those people sent us a sticker saying that we need more money to investigate. Ideally speaking, bilateral with one family member, parent, one of the parent involved, and you should do a genetic. But because of the cost factor, we're not doing it, and especially the isolated unilateral ones, no way.
Thank you so much, sir. We have Dr. Vijayalakshmi ready with her slides, so we can go to Madam.
Yeah. Sure.
Madam, unmute.
Yes.
Yeah, we can hear you now. Yeah,
Sorry
please
for the delay. Let us start. Thank you, Prachi and other organizers for this. and it has become a very passionate subject for me now, recently. And let us see in another few minutes, I'll try to stick on to the time, about the significance of this cerebral visual impairment and what are the areas involved in the brain and how that affects the visual perceptions, and also the methodology what we have adopted in the institute to examine these children and planning the interventions. So when to introduce, when there was a registry published by by Kansas City, USA, predicting that the cerebral visual impairment for them was 25% between the age group of 0 to 3 years. This prompted us to look into our data, which also confirmed that almost a little bit 1% more than what they have, almost equaling their data. So this is the significance I think all of us should remember, and this can be attributed to the increased pediatric eye care throughout the country. And I assume the same data should be valid for all the regions in the country. So the intricacy can be understood if you try to read the words here. An visual adult should be able to read the words correctly in spite of the messing up letters in between the first and the last alphabets. So the intricacy of the brain perception is so much. So how is it? This can be explained the way as follows. It is said that 70% of the sensory receptors are placed in the eye, and this in association with the 50% of the brain is able to perceive any visual scene by 1/10 of a second. And thus, the eye, along with the brain, acts as the most sensitive organ in the body, transmitting 90% of the visual seen and also helping in retaining 80% of what it has been learned by visual. So what is CVI? This is mostly an interpretation of the misinterpretation of the visual world, especially on what things are and where they are located. And though, as I said, the importance lies in the more change in the scenario of the visual causes in the visual causes in the causes of visual impairment in children, but it is not well understood among the professionals who deal these children, and hence this often goes undetected or unrecognized. To understand a little bit more what is happening in the brain, if you see here, once the image gets formed in the occipital lobe, the information is transmitted via two main pathways called ventral and dorsal. The ventral stream connects the occipital lobe to the temporal lobe, and this is responsible for our recognition of objects, faces, colors, and shapes, and also the location where we are. And the dorsal pathway connects it to the posterior parietal cortex, motor, and frontal cortexes. And this is responsible for our visual recognition and the search and the eye-hand coordination movements. And in short, we can say the ventral stream, ventral or what stream, it can be compared to the hard disk of our computer, and the dorsal stream to the software. So as you see here, you can see the real act of this child, where consciously she recognizes the object as what she holds in her hand as an apple, and she decides to color it. Once she has decided, she searches for a red pencil, and then she tries to locate it, and the whole body helps her in going and searching and picking up the pencil from the table. So this act is not a simple one, it's a complicated one, but it is made simple by the coordination of the eyes and the brain. So these different areas, I will know how these different areas of the brain, what I showed, causes different affections in the visual perceptions. So occipital lobe, which is the main thing, that receive the receptors from the central part of the retina, that is parvocellular region, and that is responsible for the clarity of the image, color perception, and identification of objects. So, if this gets affected, you see blurred vision and also causes a central field defect along with difficulty in perceiving colors. So, what about the next? The middle temporal bone, I mean, this is responsible for the motion perception. So it is slightly a little anterior, and this motion perception is important as it is even when the occipital lobe is involved. These children will have some sort of blind sight. That means they will be able to perceive things that are at least fast moving in spite of having difficulties in other functions. So it is possible that we can stimulate this area even when the occipital cortex is completely gone. We can stimulate and have them some kind of ambulatory vision. So what about this ventral pathway? As we said, this acts as a visual library helping in all these recognitions. So what happens when this is affected? You lose identifying, you lose the capacity of identifying the objects and faces, also the emotions, difficult recognizing it, and also you are lost in the crowd. Even sometimes children may not be able to identify even their own parents in the crowd. That is the importance of the ventral pathway. So the dorsal pathway, as I said, that is very important in visual recognition, searching, and then movements. When that is lost, you will lose the conscience of locating the object and then picking up exactly what you want, and you bump into places and you have also difficulty in copying in the board. So how do we examine these children? As a routine examination, anti-segment, posterior-segment should be done, but a special emphasis should be on checking their accommodation, diffraction, and the vision assessments. So this child, if you see her carefully, she was a 2-year-old with hypoxic ischemic encephalopathy sequelae, referred to us as suspicion of cortical blindness. If you have seen earlier, she was having difficulty not looking at the red color apple. But once we gave the glasses, she was able to see it. That is, even by simple dynamic retinoscopy, you can assess this accommodation, which invariably, most of the time, it's poor in this case. And by giving them this small cover, we can increase the correction in clarity in them. And what is this cognitive or functional vision? This is the ability of the brain to see the image, to perceive what is seen by the eyes. If the brain doesn't perceive what the eyes see, even having a good visual acuity is of no use to us. So we have developed a protocol in examination of these children, and then we follow the same schedule. So what we use is, usually we use either a fixation, a mirror, or a smiley to check the capacity of ability of holding the fixation for longer, or use a different sized rectangles to check the size, shape, and also the width of the rectangles. Or there is one is missing, that where you see use the Leah board for checking the shapes, and a simple mailbox, a homemade mailbox, and this gives us how the child is oriented to the directions. And also use a regular puzzle, whatever is available in the market, to check their sequencing, and then multiple emoticons, whatever is available, can be projected in the TV screen or a computer, and then different emotions like your anger, fear, sad, happy, this can be assessed. Usually the autism children, and they have difficulty in emotion perceptions. And the crowding phenomenon can be checked with the array of different objects. And the contrast sensitivity, we use Leah cards again to check their ability to see in the low contrast levels. And this video demonstrates it's a child with the autism, where she how difficult, sometimes it's easy, but most of the time she finds it difficult to do all the things. This is for saccades and pursuit movement. It's also very important to check in these children because most of them have very poor circuits and pursuits. And just by simply training their movements, we can improve them. See, she knows that there is something to be matched, but doesn't know which to be, where to be commenced. So, and with all these hardware difficulties, recently, 2-3 years ago, the Arvind team, along with the team from a software company from Mindtree, developed an app which can check very easily with the play mode that all the things what I explained earlier can be seen in a app. And this is what.
Ma'am, we cannot hear you.
The video is not available. Oh, it's the audio. I am sorry. This is mainly this apart from assessing, this is also can be used for training in the activities where we have found the difficulty, and that mode can be trained at home by WhatsApp or in Play Store in the anywhere. And what is this rehabilitation? This rehabilitation is a word that we should use as either we recovery of an ability, or you develop an ability which is not there. That should be our aim in talking about rehabilitation. So the simple things, usually earlier, we never used to give glasses because for many factors. But if you give glasses, a pair of glasses, even if there is a small refractive error, definitely that makes their life easier by having a good clarity. And on the whole, we have seen the social behavior is changed with the pair of glasses. And supposing simple, the inferior field defects, how do we detect it? By simply making them walk with the clutter background, then we'll see they will just tumble on and then they walk. So what can we do to improve their inferior field defects? So this can be done just by either giving a contrast threshold like shoes here, or you give a stroller with the supra threshold where you ask them to. The video is not.
Ma'am, you have a minute left.
It's not seen. Or you give a supra threshold illumination so that they can. Screen sharing is stopped. Why? Kilo. Resume share, yes. The shared window is closed. Why is coming like the shared window is closed?
You cannot see your screen now. You have to just reshare the screen again.
Yeah, I'm doing it. Share. I have some very good example of cases. We don't know your screen sharing.
Open your presentation, ma'am. We can see your screen.
Your things are there obstructing my opening. Your photos, videos are there. Prachi, can you take over your video so that I can find my PowerPoint? Can you take out your picture from the screen?
My picture I cannot take out. Tech team, can you just help?
Okay, I will minimize it.
Oh,
Okay, I will just coming.
Yes, ma'am.
Yes. Sorry.
We can see your screen.
Yes. Full screen you are seeing?
It's just coming, ma'am.
Not yet.
Yes.
Do you have only videos to show, or you have some?
I have some special cases to show you. It will be very interesting. So we thought maybe.
Can we start the next and then come back to you
I
to
think
finish
so.
those cases?
I think so.
Yeah.
I think so. You can start with because the times are.
So we will have Dr. Simar. He will be speaking on the best of the best video, cataract videos. So he's basically filling in for Dr. Jagat Ram, who cannot be with us today. So Dr. Simar, please go ahead.
Thank you, sir. On behalf of Professor Jagatram, I would like to thank Professor Lahane, Professor Ragini, and the executive BOA for this opportunity. I'll be presenting sir's video on management of cataract associated with persistent hyperplastic. This video won the Best of the Best award at the American Society of Cataract and Refractive Surgery Annual Conference 2016 in New Orleans. It has a voiceover, and so you can understand it there.
In this video, we describe the management of cataract associated with persistent hyperplastic primary vitreous. The producers have no financial interest in the subject matter of this film. Persistent hyperplastic primary vitreous is a congenital anomaly in which the hyaloid vasculature persists beyond fetal life. In cases of anterior PHPV with visual axis obscuration, surgical outcomes have been dismal. The presence of a dense vascularized membrane behind the lens can lead to potentially disastrous complications like intraoperative bleeding, sometimes even requiring abandoning the surgery. We describe a surgical technique for the management of such cases to obtain a favorable visual outcome. After making a continuous curvilinear capsulorhexis, the cortical material is aspirated out. The persistent fetal vessels are then cauterized in a circular fashion to obtain an avascular cleavage plane. The membrane is cut along this cleavage plane with vertical microscissors, creating a posterior capsulotomy. The stalk with the hyaloid vessels is cauterized and cut along with a limited anterior vitrectomy. The IOL can then be safely implanted in the capsular bag. With these surgical principles in mind, let's take a look at some real-life scenarios we face in children with PHPV. First is a 3-year-old child who presented with a limited anterior PHPV, obscuring the visual axis with a classical stalk. Indirect ophthalmoscopy revealed a normal retina with the stalk attached to the disc. The axial length was 18.3 millimeters. After making the side and main port incisions, a continuous curvilinear capsulorhexis is completed using a Utratas forceps. Then the soft cortical material is aspirated out by irrigation and aspiration. A primary posterior capsulotomy is performed around the attachment of the stalk. The hyaloid vessels in the stalk are cauterized, followed by limited anterior vitrectomy. In view of the large posterior capsulotomy, IOL is implanted in the ciliary sulcus with capture of the optic in the rhexis margins. The viscoelastic material is aspirated and the ports are sutured. The second scenario is a 6-month-old child with a diffuse white cataract. Ultrasonography revealed the presence of a stalk extending between the optic disc and the lens, suggesting the diagnosis of PHPV and an axial length of 17 millimeters. The interior capsule is stained with tryptophan blue dye and a continuous curvilinear capsulorhexis is made. The cortical lens material is aspirated out with the irrigation and aspiration cannula. This reveals the densely vascularized membrane, with the stalk being visualized here on retroillumination. The persistent fetal vessels on the membrane are cauterized with the help of an endocautery to create an avascular plane. Vertical microscissors are then used to cut through this membrane 360 degrees, thus creating a posterior capsulotomy. The same endocautery is used to cauterize the hyaloid vessels in the stalk, and the remnants of the membrane are taken out after an anterior vitrectomy to release vitreous traction. A corresponding interior and posterior capsulorhexis can be visualized here. The single-piece intraocular lens is then implanted into the capsular bag. As PHPV is mostly unilateral, an IOL placement is desirable because unilateral aphakia is as strong a stimulus for amblyopia as the primary pathology itself. The third scenario is that of a 2-year-old child presenting with a densely vascularized membrane with large prominent ciliary processes. The initial steps of surgery are carried out in a similar fashion. A continuous curvilinear capsulorhexis can be particularly difficult in such cases due to the thin and lax nature of the capsule. The persistent fetal vessels in the membrane are cauterized in a confluent pattern to create an avascular cleavage zone. A posterior capsulotomy is made by cutting through this newly created avascular zone with microscissors aided with the help of intraocular forceps. Care should be taken to not cut through this thin stalk of fetal vessels at this stage. After completing the posterior capsulotomy, the fetal vessels in the stalk are cauterized and the anterior vitrectomy is completed to obtain a clear visual axis. An IOL can then be implanted into the capsular bag. Post-operatively, these eyes should be managed on higher frequency of topical steroids along with antibiotics and cycloplegics. Residual refractive error, if any, should be corrected and intensive amblyopia therapy initiated. Children with PHPV require a long-term follow-up to monitor for visual axis opacification, glaucoma, and posterior segment complications. To conclude, cataract associated with PHPV is a challenging situation. However, by following the basic surgical principles as demonstrated here, a favorable outcome can be achieved in a majority of these children. Thank you.
Thank you very much.
Thank you, Dr. Simar. We will have Dhane sir now for his tips and tricks in pediatric cataract. Sir.
Thank you very much. Now I will
Thank you, Dr. Simar. Thank you.
Thank you for allowing to present on sir's behalf. It was a pleasure.
No, I understand sir is very busy and with COVID, and it is very, very understandable. But thank you so much for you being here. Thank you.
Thank you, ma'am.
Thank you, Vijay Lakshmi, madam.
I think someone's presentation is seen there.
Ma'am, you need to unshare your screen.
You will have to. Someone's presentation is seen, so I cannot.
Vijay Lakshmi, madam, you have to. Unshare your screen.
It is in the upper.
Your screen is visible. Your PPT is visible, ma'am. We will have Danish sir's presentation, then we'll follow up with yours.
Okay, okay.
Okay.
Need to unshare your screen, ma'am. Yeah, we can see you, sir.
Thank you, thank you. Okay. Now I will share my screen. I don't know.
So it's at the bottom of your screen. It's at the bottom of the screen, the share screen part.
It is there, but
need to open your PPT first.
I have opened my PPT, and now, but how to share it?
So at the bottom of the panel, there is a share screen green button with the arrow up pointing up.
One minute, let's see.
Can you just
Okay, share. Okay. Now this is coming. Yes. Can you see now?
Yeah. Yes, sir. We can see your slides.
Okay. Sorry. Okay. So thank you, Assis. Thank you, everybody. Thank you, Vijaya Lakshmi madam. Thank you, everybody. Thank you, Ragini. Now this is pediatrics tips and tricks. I'm going to speak to you. You see, there is no financial disclosure, but you can see the pediatric cataract article. What says it accounts for the 7 to 15% of the cataract blindness is pediatric blindness is because of the cataract. And if you see the refractive error caused, 33% of the visual impairment is caused by the pediatric cataract. So now there are so many, this one when to operate. So bilateral dense cataract, if it is there, early surgery at 8 weeks or is to prevent development of the stimulus deprivation amblyopia. The second eye is to be operated within 1 week. Unilateral dense cataract, urgent surgery is advised, and best if it's done 4 to 6 weeks because the patient will not go into the amblyopia. Now, what is difference between the adult and the pediatric eye? You see, it is a smaller anterior chamber depth, the steeper cornea, shorter axial length, lower corneal and scleral rigidity, well-formed vitreous, soft lens, very elastic anterior capsule. See the IOL power calculation. See, roughly I'm telling you that the children less than 2 years of age do biometry and undercorrect by 20%, and children between 2 to 8 years do biometry undercorrect by 10%. Now this is the intumescent cataract. I am just showing you the video. You can see this is I am operating, and this cataract here I am doing the rhexis, and you will see the cataract as a whole comes out, and then it is very difficult now see to do the rhexis. So I am trying, but because the now everything is lost, so what I am doing is now I use the AC maintainer always. So I will go into the AC maintainer, and then I will aspirate, and after the aspiration, then I am doing the rhexis. Because of the intumescence, the cataract was coming out, and then I did the rhexis. Now when I have done the rhexis, see in these cases, the rhexis sometimes, the anterior capsule is very elastic, so it is very difficult to do the rhexis. So you'll have to do very by the forceps and go slow so that you can do the proper rhexis. Now here I'm just aspirating the cortex from all over. I use the AC maintainer, and I do the PCCC up to the 6 years of age and do the vitrectomy. So here, after doing this PCCC, I do the proper vitrectomy, and then Here you will see the just showing the another patient. Here the PCCC is done, and the I'm using the forceps here, and here you will see the capsule is very elastic. Whenever you are pulling it, we always feel that all the capsule is coming, but here the elasticity, you'll have to go slow. As you have seen that I'm going slowly and making a rexis. This rexis, it should be equal to the pupillary size or slightly larger than the pupillary size that I'm making. And here the rexis is completed, posterior rexis. Then I will do the vitrectomy, and after vitrectomy, then the IOL is implanted. Now with this, see, this is the cataract. You can see the totally can see absorbed cataract here. It is not uh, in the pediatric cataract. Now you see I'm doing the rexis, and you see the all capsule is coming with me. Whenever I'm taking the needle, the capsule is coming in because of the absorption. This capsule is can say elastic more and loosened. So I'm trying to do the rexis. You will see the anterior capsule is also having the calcification and also the opacification in the anterior capsule. Now here on one side, if I'm coming, there is a fibrotic band on the anterior capsule, and I'm unable to remove that band. And this tag, which is fibrosed area in that anterior capsule, that you will get in the such type of cases. So you should be particular whenever you are removing such type of tag, so that you will not bring the zonules and there may be a PC tear. So what I do, I always use the cutter, vitreous cutter. Here you will have to protect the iris. Otherwise, sometimes we may uh, cut the iris. Now again, after that, I am doing the PCCC. Here in the PCCC also, whenever you can see the same thing, that you go gradually, and after the gradual PCCC, see here, and then I will go for the cutter, this vitrectomy. And once the vitrectomy is complete, so here it should be complete vitrectomy, and then only you can go for the even this one. The another case I am going to show is the pediatric cataract. Yes, traumatic cataract. This injury due to the ball, and I'm doing this rexis. Here you will see it is on the anterior capsule. You can see there is a fibrosis seen in the center. So carefully the rexis to be done. Otherwise, it goes in the periphery, and it is very difficult to complete the rexis. So I have completed the rexis, and then what I will do will be, can see the aspirate the cortex. So this cortex, as you see, it is in the center. As there was a trauma in the posterior capsule also, there is a fibrosis, and I was unable to do it by the forceps. So I am doing PCCC by the cutter only. So here I am doing, and area where it was a fibrosis, that I'm cutting with the retractor. You can see here, and the extension of the PCCC also I am doing with the retractor. So here you will see this is I'm cutting, and the rexis on whatever the fibrosis is there in the posterior capsule, that I am trying to remove. And once that is done, then I have implanted the lens, and the surgery is finished. So I think this is what I do. In the conclusion, what I want to say is pediatric cataract is a preventable blindness. We can prevent it. Only thing is that one should not operate. Each and every person should not operate that it is a cataract, and any cataract surgeon can operate this. No, pediatric cataract is totally different from the our senile cataract. The meticulous preoperative workup is very important. Anterior vitrectomy with the PCCC in all children is important, less than 5. IOL calculation by repeated measurements from the experimental ophthalmologist, this experience ophthalmologist, and I think this you should do personally instead of asking someone to do. You should do personally, and close follow-up and visual rehabilitation is very important, because you have operated the kid, you have not implanted the IOL, so that may cause the amblyopia in both eyes. So there should be a close follow-up. So thank you very much for the.
Thank you so much, sir. As usual, we had a lot to learn from you. Thanks a lot.
Thank you, sir.
Thank you. Thank you very much. Thank you.
Ma'am, if you're ready with your slides, with your presentation.
Ashish, you'll have
Yes,
to
sir.
excuse me and continue this because I have joined the Facebook live of Honorable CM sir. So I'll be going there. So Vijayalakshmi ma'am, I'm sorry. So I'll be joining there. Huh?
Thank you so much, sir.
Yes, sir. Thank you, sir.
Lakshmi ma'am, we can have your a minute for your slides if you have time. You are ready with it. If you're not ready, then we can go ahead and take up the next presentation. Ma'am, we cannot hear you, ma'am.
I'm ready with the slides.
Yeah, please go ahead, madam.
Yes. So only I just wanted to emphasize the younger generation that we have come so much forward in treating diseases, and it is a high time that we should concentrate on this part, these children, where if you could do much, we can do a lot, much to these children if we identify them early and then do a correct intervention to them. So that is why I just wanted to share this thing about rehabilitation. So when you have this field thing, you can either have a super threshold shoes or one with the scroll where you have to train them to look at it to attract the illuminated one. It is a very nice device. It's available in the markets that can be done there. And then this is a child, 7-year-old, came to us with the Vision 66, N6, but with all these complaints from the mother, saying unable to do the academic work and a problem in mobility, and also identifying dropped objects, all those things. So when we examined, we found a similar problem with her simultagnosia. This video, we have simulated the video simultagnosia. If you show her the solid, the star, she was able to identify it. But when it is shown with multiple rounds around, then she had difficulty in locating the star. This is simultagnosia, and this can be tackled very easily by intervened by making the visual array a little bit a simple one, using a single letter card instead of a crowded one, or using a reading guide with illuminating only a single letter, or make the child to move closer to an object where she is interested to look into. So that will magnify and then she will be able to see. All these things need only a proper counseling and little bit training. And another 11-year-old came to us with a poor eye contact, behavior problem, and also poor academic performance, poor attention in general. And then main thing was uncomfortable around moving stimuli and traffic. So when we examined the vision was okay, everything was okay, but was uncomfortable because this, when we checked the eye movements, the saccades and pursuits were not normal. Because of the difficulty in eye movement matching the environment, she had difficulty in motion perception. That is about moving objects, fast moving objects, or a ball. So she could not play with her mates, everything. So these children will do better with the stationary ones. And also if we teach them without moving or with the static materials, that will help a lot in this. A small modification, but help them to do well in the academics. And we all know that many children, especially the autism spectrum disorder, have difficulty in recognizing emotions. And this can be trained by using emoticons, as what you see. But in the school, what the complaint of academic performance, a simple use of a bold pencil or a marker pencil or a lined one, or ask the child to go closer to the board, that will help a lot. That why this becomes important. Even with the little ambulatory vision is much helpful in a child with a profound visual impairment. So for that, we need great assessment and early identification, because these children have a different perspective, they show different clinical signs depending upon the pathology. So we need to examine each child for their own capacities as an individual basis to plan the intervention. So what is it? We have come so much forward in treating the diseases, cataracts, we are very good in making the eyes aligned in difficult situations. But this side, as I said, importance is 26% of visual impairment are due to now. This is because more and more premies are surviving with the morbidities. So with the allied personnel, we identify these children with a simple questionnaire what I presented by to identify early. This is about walking problems or seeing moving things difficulty, or whenever whatever is pointed out, the child is not able to point out. These 5 questions, if we employ, we can screen these children, and once we screen it, we should be able to intervene them, at least to give a better quality of life. And I am sure this is going to be a great significant problem in future. I think all of us should be aware and then try to examine or give importance to these children to improve their quality of life. Thank you very much for giving me time.
Thank you so much, madam. Can we have Dr. Kavita Kalaivani for a presentation? She'll be speaking on challenges and tips to manage traumatic cataract. She is a consultant in pediatric ophthalmology at Shankar Nethralaya, Chennai.
Thank you, Dr. Ashish. And ma'am, you need to stop sharing, ma'am.
Oh, sorry.
You're still sharing your screen, ma'am. Go ahead, Dr. Kavita.
Yeah. So, as with all pediatric cataract situations, traumatic cataract imposes extra challenges. So, I'll try to summarize how we step by step how we approach and try to give some tips. So, any traumatic cataract, the first aim is to manage the trauma like this. First is to restore the globe integrity when we are the primary surgeons. So then the visual axis has to be cleared, then optical correction and amblyopia in children. So trauma typically is blunt trauma, can present in various scenarios, in various situations like this. So you can have intact cornea if this injury is not so severe, total cataract. Iris issues can be there like sphincter or dialysis. Stability of the lens might be doubtful. Posterior capsular status might be doubtful. Angle injuries has to be looked into. And posterior segment issues can also be associated. Whereas penetrating trauma is more of corneal trauma. Again, capsular integrity, iris injury, all this has to be looked into. So we have different scenarios based on when, how, and we see how to manage and along with what to manage. So the issues involved in cataract management and in trauma situation is, do we manage the cataract if there is cataract while we have faced the primary repair itself? And if we don't do it during the primary repair, is there a time with the time gap where between the trauma and the cataract surgery, ideal time gap? And if IOL is planned, implantation is planned, whether do we do it primarily or secondarily, and where do we implant the IOL, the position, depending on availability of the intactness of the structures, and additional procedures, whether an iris repair is required, glaucoma surgery is required, vitrectomy is required or not. So these are the issues we need to face, and of course, patient counseling. So different scenarios present like this in children, making the issues complicated because of their age and the time at which they present. So like I said, the issue one, cataract management. Do we ever do a cataract management during the primary repair? So ideally, no, but why not? So when there is an open globe, it is an emergency state. We may not have the best backup of instruments and arrangement. So availability of expertise may be doubtful, and availability of risk of infection, inflammation, all that is doubtful when we have an open globe. So ideally, we do not manage the cataract in the primary repair, but sometimes, yes, we do have to manage. So when is that? When there is a breached anterior capsule, obviously, and there is a lens matter in AC, large chunks of lens matter. And sometimes we do it to avoid multiple injuries in very small children, and early rehabilitation is possible, and we can assess the posterior segment better. So cataract surgery during primary repair is ideally best avoided and done only if there is a large breach in the anterior capsule and lens matter in the AC. So then IOL implantation during primary repair, do we ever do? So you see these two scenarios. So the second situation, there is a very small penetrating injury, but the capsule is ruptured nicely and lens matter is in the AC. So here the rupture in the small tear in the cornea is actually not in the visual axis, and it's a little older child. So maybe in this second situation, we can plan a primary, or at least we can have a backup if DBR and all is possible. And if there is no other necessary for a tight corneal wound and everything else is intact by posterior segment examination, maybe there is a small chance that we can implant the IOL in the primary situation. Otherwise, we usually never implant IOL in the primary cataract surgery, especially when the cornea is breached. So best avoided due to chance of infection, of course, biometry issues. So if cataract is not managed during the primary repair, then when do we manage? So ideal time between trauma and cataract management. Is there anything like that? So when do we do it is always a doubt when it is when the children present in different situations. So age, intraocular pressure, and inflammation determines the timing between the trauma and the cataract surgery. So here we see primary repair done 2 days prior elsewhere. But if you can see, the eye is highly inflamed and cortex is in the anterior chamber. So we can do the primary repair. Once the cornea is intact, we can do the cataract surgery by doing a lensectomy. So here the cornea is still having sutures, so only lensectomy to improve the inflammation and IOP issues later. So when we do like this situation, we leave a capsular rim intact, but clear the visual axis completely, examine the posterior segment later, and plan electively an IOL implantation as a secondary procedure after corneal sutures are removed. So different situations, different timing for cataract surgery and IOL implantation. So when we decide on IOL implantation, what type, when do we implant? If not in the primary situation, and the power calculation issues arise. So when there is a corneal injury and primary repair has been done, so you do the cataract surgery, do a lensectomy or a contact lens and secondary IOL till we manage till we decide about secondary IOL implantation. If there is a sutured cornea, you remove the sutures, wait for 2 to 3 weeks for the suture effect to heal, and then topography, and then IOL implantation as a secondary procedure. So primary versus secondary, what factors decide is the posterior capsular status, age of the child, corneal sutures, etc. So when if we place the IOL, where? So that again depends on the integrity of the bag, sulcus, and so very, very rarely or extremely rarely we sometimes adopt ACIOL, but ideally no in children. SFIOL, glued IOL are the other options. So these are two situations where IOL is implanted. Even if there is a traumatic cataract, the PC block is removed and intact.
Kavita, you have a minute.
And the second situation, parallelly, if you see, there is a traumatic cataract with a corneal opacity, but IOL can be implanted in the sulcus. So there are two options in the primary situation depending on the posterior capsular integrity. So non-cataractous route, sometimes, as I said, we can have cataract with other conditions like iridectomy. We might need to do optical iridodialysis repair. We may have to do glaucoma surgery. So all this, we need a hand-in-hand role and plan what to do along with cataract surgery itself. So this is one situation where a pupilloplasty is done along with the cataract surgery. And here an iridectomy is done because a corneal opacity is a little in the center. To improve the visual axis, we can do an optical iridectomy while we plan the cataract surgery. So iridodialysis, ideally we do it when it is, first you do the cataract surgery and after that you do the iridodialysis repair if we do it in the same sitting. So long term, it's a continuous challenge. Refractive challenges are always there. Amblyopia, glaucoma, retinal complications, strabismus, everything has to be managed. So finally, to take home, cataract management is best avoided at the time of primary repair, except in extremely rare situations. Ideal timing of cataract surgery following trauma is within 1 week to 1 month in adults and children. And amblyogenic age group, it's crucial to plan clearing the visual axis rather than implanting the IOL, and important to weigh the risks of amblyopia due to aphakia and uncorrected astigmatism rather than DVR-related issues. And primary implantation of IOL has proven to give best results whenever possible, and concurrent issues, whenever present, can be tried to manage at the simultaneously. And very important to be aware of long-term issues like glaucoma complications and sympathetic ophthalmia, even in children. And patient counseling goes hand in hand all along. Thank you.
Thank you, Dr. Kavita. If we have time, we will take questions later. We now invite Dr. Sujata Goa for her presentation on pediatric IOL calculations. She's a consultant and a medical director of Shankar Nethralaya, Kolkata. Dr. Sujata, please go ahead.
Can you see my screen?
Not yet.
Just a question for Dr. Kavita in the meanwhile. Are you there, Dr. Kavita?
I'm here.
Yeah, so in case you're planning to put an IOL in the same sitting, how do you go about calculating the IOL power?
That's what I see. In my experience, in a situation where there is a corneal injury, we hardly ever have a situation like that. But that particular child which I showed, had a very small corneal injury. Wonder how the capsule ruptured so much. So I just had a backup of DBR done on table. We did DBR on table, and after we just needed to take one bite for that corneal wound. So I implanted IOL in that child alone. Otherwise, in a corneal injury, I've never had a situation where I could implant IOL in the primary setting.
Thank you.
Sujata, are you ready with your presentation?
Yeah. Can you see my screen now?
We cannot see your presentation.
Okay. Then maybe
Meanwhile, can we have Dr. Love ready for his presentation? We are really running short of time, so we need to.
Yeah, I'm ready. Shall I?
So ma'am, Sujata madam, we will have just if you can arrange your PPT, then we will have next one for you.
Yeah, is my screen visible?
Yeah, yes. So we have Dr. Love from Kolkata. He's the director and senior consultant at Nethralaya. So Dr. Love, please go ahead.
Yeah, I'll just rush through a few of the surgical videos in pediatric cataract, and whenever I'm overshooting my time, just let me know. I'll stop it there.
Yeah, please go ahead.
So most important thing is we all should know what not to do, because pediatric cataract is such a surgical issue that everyone who is doing adult cataract gets tempted to do it, and this is what happens when you're not trained properly. This was a case which was done by an untrained surgeon, and a single piece IOL was placed in sulcus. The inferior iris is missing, and this has led to corneal decompensation partially. So what we did, we removed the IOL and just left the child aphakic. First, we tried to bend fold the IOL and cut it, bring it out, but it didn't come out through the main incision. So we cut it into 2 pieces and finally explanted it. And more importantly, because the iris is deficient on one side, we decided against implanting a secondary IOL. We left the child aphakic. And later on, when the eye became quiet, we put the child on a contact lens. So the purpose of showing this video is why everyone should not do it, because this child who has a life of maybe 70-80 years ahead of him, and one eye is greatly compromised because of untrained hand doing a pediatric cataract surgery. So second video is just for a demonstration. How do we do the biometry in children? And most of the cases, what we do, we keep a full series of IOL with us, and do a biometry on table. As you can see here, we have not put the speculum because that causes the cornea to get distorted and the reading may not be proper. So with just opening the eye, we took the keratometry reading and then do a scan. So this is how we do the biometry. I'll go to the next one. Now this video is a combination of a routine cataract surgery with a small pupil in a child. And as you can see, we have used Grishaver hook here because again, more we manipulate, the chances of post-op inflammation will be much higher. So, and after making the initial nick, it was a hypermature cataract. We did the milky fluid was removed and capsular access completed. Purpose of showing this video is that 2-3 situations are combined in one surgery, and as you can see, zonules were a bit weak, so the trypan blue has gone into the vitreous cavity. A 3-piece IOL is placed in the bag. And once it is in place, what we do now on routine basis is use a 23 gauge cutter and do a posterior capsular access along with this. This is a video in which the cut rate is less, but the newer machines, it is much more better than that. Now, this is another important thing, which is when we have a child with a unilateral cataract, then we should always suspect a posterior lenticonus because almost 10% of these children have a deficient posterior capsule, and we have to think, and this is a clear cut. As we can see, the oil droplet is being seen at the posterior capsule. That is a point where the posterior capsule is deficient. So by mistake, I started doing hydro dissection, but at the right time I stopped it. Ideally, we should not do any hydro procedures, start aspirating the cortex from the periphery, and then finally go to the center where the capsule is deficient so that there is no vitreous loss. And if there is vitreous loss, we should stop there itself, remove the irrigation aspiration and go in with a cutter. And as you can see, the PC is deficient at this point. So what we did, we again treat it as an adult posterior polar cataract. So don't release the handpiece immediately so that the AC gets decompressed, and then that leads to a vitreous loss.
Dr.
And
Love,
again,
this is
here,
last minute.
yeah. So I'll conclude with this video there, in which this is another procedure what we do for infants, and when we are not implanting a IOL. In this, we don't make a main port. With the 2 side ports, the anterior capsular access is done. Using the cutter itself, we aspirate the cortical matter using IA, and finally, the posterior capsule is cut and we leave a rim of anterior capsule for future IOL implantation. I think due to time constraint, I will stop at this. Thank you.
Thank you so much, Dr. Love. That was very instructive. Can we have Dr. Sujata ready for a presentation?
It is not allowing me to.
Yeah, it will come on, madam. Yeah, it will come. You can do it now, I think.
Yeah, I did it. See, I'm opening and I'm sharing it. It's not allowing me to do it. I don't know.
Team, can you take over? Can you help in any way?
See, it is giving a privacy policy, and I have said that and just give me 2 minutes. And sometimes you leave the meeting and join again, it helps.
And with your permission, can we go ahead with the next presentation?
Sure, go ahead.
Yeah. So we'll have Dr. Jai Kelkar from Pune. She will be speaking on capsulorhexis techniques. So Dr. Jai there?
Yes, I'm there. I'll start.
Yeah, please go ahead, Jai.
It's telling me that I cannot share while the other participant is sharing. So I think you'll have to stop sharing. Yeah.
Are you sharing the screen? Can you please stop your sharing? Try again, Dr. Jai.
I have stopped sharing.
Can you still do it?
Well, just a question for Dr. Love. So you were talking about doing an intraoperative biometry. So do you prefer doing the contact e-scan, or do you like going ahead with an immersion e-scan? So that is question number one. And question number two, are you comfortable operating in the same setting after doing a contact procedure?
See, ideally immersion should be done, but in our setup, it's not available in the new machine. This was an old machine, and ideally speaking, it should be avoided. But in pediatric cataracts, putting the child into double GA is again another issue. I've been doing it for years now. It doesn't make any. I've not seen any infection till now.
Should I try to share my screen again?
Yeah, please do that, madam.
Okay.
Yeah, please go ahead. We can see your screen, ma'am.
Okay. Yeah. So I will be speaking on an important topic, which may be more important than the surgical process itself, and that is the pediatric IOL power calculation. And why is it different than that of adults? Because of the rapid refractive and anatomic changes which occur in childhood, and the anatomy per se of a child's eye is different. It has got a much shorter axial length, much steeper corneas, and a smaller AC depth. So the challenges in doing a pediatric IOL power calculation will be biometry, the selection of IOL formulae, and the amount of undercorrection that we need to do. Let me tackle with the biometry first. Now, why is it that the biometry is so challenging? It is because we do it under general anesthesia, so we don't get the child to fixate. The cataracts are usually very dense, so the axial length readings may not freeze. Sometimes we have seen they don't freeze even in very high gain. The newer machines like the LensStar, like the IOL Masters, don't really work for children. And as a general rule, as all of you know, 1 millimeter axial length error can lead to a 2.5 diopter power change, and a 1 diopter keratometry error can lead to nearly a 1 diopter IOL power change. A few terms which I will be using in my talk subsequently is prediction error, which is the actual post-op refraction minus the predicted post-op refraction. So if you have a hyperopic prediction error, that means you have got a more hyperopic outcome than predicted. And an absolute prediction error is the absolute difference between the actual post-op refraction and the predicted post-op refraction. It does not have a plus or a minus sign. So in the axial length measurements, we have several areas where we can have an error. The contact can have an error by increasing the indentation of the cornea. The immersion ultrasound technique, if you don't keep the probe perpendicular to the retina, you can have an error. And in partial coherence interferometry, which is there in the newer machines, you need a good patient cooperation And it really does not work in very dense cataract with corneal scars, with retinal dystrophies, so which is usually found in pediatric cataract. So partial coherence interferometry is not really very applicable in small children. Let us see what the literature says. This is a paper by Dr. Rupal Trivedi and Dr. Wilson, and they compared the immersion technique with the contact technique, and they found that the contact technique showed significant shorter axial length than that of the immersion technique. And then they said that the immersion technique is more accurate in children. Now, what about partial coherence interferometry? There also, on an average, it measured axial lengths 0.1 millimeter less than the immersion ultrasound values, which is taken as the gold standard in children. Now, what about keratometry? Since we can't use the usual keratometer, we use the handheld ones. And this paper discusses the accuracy of the handheld keratometer. And they did say that it provides reliable readings when used intraoperatively on anesthetized non-fixing children. Now, coming to the IOL calculation formulas that we have in our armamentarium. Why is it a challenge? Because most of these formulae are actually based on adult eyes, and they are based on assumed anterior chamber depth from the manufacturer's A constant. And we know that the effective lens position and the axial displacement of the intraocular lens is more pronounced in children because of the dynamics of the PC contraction, the effects of PPC and anterior vitrectomy, and the effect of reproliferation of the lens material. All of them cause a little different expected lens position than that of adults. So what are the formulas that we have? We have many, but we usually use SRK-T, 2, Holiday, Hoffer-Q, and sometimes the Barrett's. Now let's see what the literature is showing. This paper was a retrospective analysis of nearly 101 pediatric eyes with cataract surgery, and they found that SRK2 was the least variable, and Hoffer-Q gave the most variable results. But a similar paper by Nihalani et al. Said that Hoffer-Q gave the minimum prediction error in a series of 135 eyes. And we have LV Prasad paper by Dr. Kekunia's group. They studied IOL power calculation in children less than 2 years, and they found that SRK2 gave a minimum prediction error. Now, the newer papers, which are comparing the newer formulae with the older ones, they have also come up with the fact that the prediction error for the Barrett's Universal 2 formula was more than SRK-T. We did a study in our own center where we included about 68 eyes, and we also found SRK-T and 2 to have a lower prediction error. So if you see, as the literature progresses, we still find the SRK2 and T to be more predictable, and the preferred practice pattern for most pediatric ophthalmologists is SRK2 for pediatric patients. Now comes to the next question of undercorrection. We undercorrect or we keep the child hyperopic to balance the myopic shift. Now, this balancing has to be a little titrated between the risk of amblyopia by keeping the child very hyperopic or the risk of having a high myopic shift. And there is no one formula fits all. The factors which need to be considered also are the other eye status, the visual acuity in the other eye or the same eye, the parents' refractive error. Myopic parents might have myopic children, and the expected compliance to glasses. So this again, this paper was published by the LV Prasad group, and they validated the guidelines of undercorrection. The usual guidelines for undercorrection that we follow is that suggested by NED and Associates, and there the age at surgery and the targeted postoperative refraction usually adds up to 7. So they found that this particular guideline had 50% of the children achieved a refraction of 1 diopter and nearly 90% within 2 diopters. So they found that these guys achieve acceptable refractive error at 7 years of age. So how are we looking at the future? We have in pipeline one of the concept of two lenses, a front lens which can be changed as the power of the child changes. So this is something that we can look forward to. We also need a customized IOL formula for children. We need newer IOL designs to tackle refractive surgeries, and we need studies to understand the factors which are responsible for the refractive changes. Thank you.
Thank you, Dr. Sujata. We will have now the last talk from Dr. Jai. She is speaking on capsular access techniques. Dr. Jai is a consultant at the National Institute of Ophthalmology at Pune.
Okay. I think Dr. Sujata needs to stop sharing her screen. So
yeah, you need to unshare your screen.
Yeah, just 1 minute.
Yeah, please go ahead, Dr. Jai.
Yes.
So meanwhile, if you have any questions, you can go ahead with the questions. So for all the panelists, there is a question of the use of toric lenses and multifocals, if anybody has a take on them in pediatric cataracts. Dr. Sujata?
Multifocal IOLs for small children is really not an option because A, the IOL power calculation is a little unpredictable. B, we really don't know how these children's axial length is going to behave in future. And C, the multifocality itself reduces the image quality, which can actually aggravate the amblyogenic impulses. For older children, maybe if they are more than 15 years or so, yes, you can attempt multifocal lenses. But for young children, I think the answer will be no with most pediatric ophthalmologists.
What's the experience with toric lenses?
Similarly, for multifocal, as in multifocal, in small children, because the contraction of the capsular bag is a little more than that of adults, so the toric lens might rotate more than what they do in adults. So in smaller children, the multifocal and the toric lenses, which actually depend on the capsular contraction to maintain its central position, is not really feasible. For older children, more than 15 years, where all these are actually minimized, you can have torics as well as multifocal. That's my take on it.
Thank you, Dr. Sujata. Dr. Jai, you ready? So another question for Dr. Kavita.
Yes.
Do you prefer when you have a 3-piece or a PC rent primarily and a traumatic cataract? Do you do a capture? Do you attempt a capture in all cases?
I personally haven't attempted capture. I rather prefer putting the IOL in the sulcus, a 3-piece IOL in the sulcus, but capture I haven't done actually in those situations.
capture actually stabilizes the lens. So I would actually advocate a IOL capture onto the capsule, because the 3-piece lens also can move out of its central location. So a capture works beautifully.
Yes, ma'am, I
The
agree.
anterior or the posterior axis.
These 3-piece lenses are sometimes actually small and they do displace when we place it in the
Yes.
sulcus, but capture is a very good option during that time.
While they set up, another thing I would like to mention is that if you have the cornea very distorted, you can actually take the K reading of the other eye for the biometry. This is done in situations of traumatic cataract where you are not getting any kind of topography or keratometry reading in the eye that is to be operated.
Yes, ma'am.
Coco, you're still around? Dr. Coco, are you still logged on? Okay, so for another question is, how do we really assess whether the cataract requires surgery? If anybody's take on it.
You mean generally?
Is it really required to do, because we are going to lose a near vision as soon as we do a
Very true.
cataract?
Actually, there is a good number of situations where, especially zonular cataracts, they might look like, they might look really significant in the slit lamp, but sometimes these children are very less symptomatic and they may even have 6/9 vision bilaterally. And in these situations, just seeing a significant cataract doesn't warrant surgery if they're having a very good near vision. Like you said, losing near vision permanently is a thing that we have to look into in children. Yeah, there are situations, and even trauma, sometimes very minimal lens opacity, a little off center. But if the children is asymptomatic and have relatively good vision, like 6/9 or 6/12 even, at the cost of leaving accommodation intact, we may defer or postpone surgery. Yeah, that's a very good point that you raised.
So as Sujata had mentioned about actually taking the corneal readings of the other eye in case of a corneal scar, I think sometimes post-operatively that we land up with a lot of surprises in those situations, mainly with the cylindrical errors and things like that.
See, with such a large corneal scar, you will end up in surprises. Yeah, there is no way you're going to have a absolutely accurate biometry.
So any role of just putting an RGP, is there a role of putting up an RGP lens, flattening the cornea, and then doing the biometry?
Yes, that is another one. I mean, another
especially if the cataract is not
yes.
mature, you can get a reading and then.
True. Sometimes standard K of 44 is a little more reliable than taking the other eye K.
Yeah, the other eye should actually have kind of standard case if you're taking it. But putting a RGP and trying to freeze a K or get some kind of topo is a good idea.
Dr. Chai, are you ready? Because we have already overshot our time.
Okay, then I must apologize. I am not able to get my videos on the screen, so it's not happening.
Can you go ahead without your presentation? Can you speak without your presentation?
No, it was mainly a video-based talk about
capsular so any pulse we need to take?
This pulse that actually I had planned to show that if you put an IOL,
you
with
can just speak about the OVDs you use, the instruments you use to do the access.
So for Rexis, earlier I used to use, I had tried with a cystitome, but naturally because the capsule is very elastic, it's very easy to do it, or rather controlled to do it with a Rexis forceps. The main important thing to remember that is you have to repeatedly grasp and re-grasp, especially at the advancing edge. The capsule will tend to be long, so Rexis will tend to be long, much bigger than what you're intending. So be very careful and keep on pulling the Rexis towards the center so that the Rexis doesn't run off. It is good to have a good anterior capsular, wide anterior capsular axis. Children do have a tendency to get a lot of capsular phimosis afterwards. So a big capsular excess than what we plan in adults is definitely better. Another thing about posterior capsular excess is that we have many stalwarts who are doing it with the forceps. But I personally feel that after doing it with forceps, in my hands at least, I could not titrate the size of the capsular excess. So I found out that after you do the good anterior capsular excess, thorough cortical cleanup with capsular polishing, you put the lens, but don't put the lens completely inside. Just put the leading haptic in the bag and let rest of the lens be inside the AC or just dangling outwards, inside the eye, but not at the incision. And then with a vitrectomy cutter, I find it much easier to go inside and make a properly graduated or a calibrated posterior capsular excess opening. That saves time also, because at the same time, you're also doing the anterior vitrectomy. Whatever tags that are coming towards your pupil are also taken care of by that technique. And once you're complete with your posterior capsular excess with the cutter and the anterior vitrectomy, putting the trailing haptic inside doesn't become very difficult.
And you
Earlier,
usually
I
put
have
your
tried to do a capsular excess and put a lens, but then in my hands, I found that either the superior haptic would then disengage and come out in the sulcus, and that would lead to a lot of handling in these eyes. It's better to have as a smooth surgery as possible. So these days, I find that doing the posterior capsular excess with the cutter, with the lens in situ, going behind the lens, definitely works better.
do you usually use tricot to stain the?
Tricot assisted, yes. So if I think there are tags, then yes, diluted tricot definitely in the anterior chamber, and
So is it a
because you
usual
get an
protocol
idea
for
if
you,
there are
or
any tags remaining.
is it usually a
Sorry?
protocol for you to do it in every anterior vitrectomy, or you just do it
Not every
per
anterior
case basis?
usually let the how the lens is rotating and what is the pupil. If the pupil is not peaking anywhere, then you are sure that there are no tags. But yes, when you're initially starting and you're not sure, it's always better to have tricot at hand, because it stains the vitreous very well, leading to a very good proper vitreous cleanup. You don't want tags in the anterior chamber or coming out of the incision.
Thank you, Dr. Kelkar. I think we have already overshot our time by 20 minutes. So we need to wrap it up. So if anybody has a last comment, we can take it now, or we will thank the panelists and all the speakers on behalf of BOA.
Thank you.
Thank you.
Thank you very
Thank
much.
you,
Thank you so
everybody.
much.
Yeah.
Thank you, all of you.
Thank you, Pankaj.
Yeah, thank you, sir. Nicely moderated and conducted the session very well. There's a lunch break actually. There's no problem. We have overshot the session, but still we have 1 hour.
Hello. Hello.
Is there anyone? We can just check our presentation. Dr. Varsha, can you hear me?
Yes, good evening, good afternoon, Shreya.
Good afternoon. How are you?
Yeah. How are you?
Yeah, I'm fine. I was just asking somebody's.
I don't think somebody from
So
the.
it is not started, right? It will be.
It's not. Actually, previous session was late, a bit late.
Okay, fine. Then we'll wait.
Welcome, Bhaskar.
Sir, good afternoon.
Good afternoon. Good afternoon, Bhaskar.
Thank you, sir. We have attended your previous session also with CM, sir. Yes, sir. Very informative and interactive session.
Hi, madam.
Hello, good afternoon, sir. Varsha Pandey from Nagpur.
Varsha, good afternoon. Sunana, madam, good afternoon.
Namaste, sir. Namaste.
I saw you on TV. आपका मीटिंग टीवी पे देखा. टीवी
कौन सा अभी ये ना?
सीएम का.
हाँ.
टीवी आ रहा था तो मलिक सर और मैंने दोनों ने देखा.
हाँ, अभी सीएम सर के साथ मीटिंग था.
और डॉक्टर खेरे कैसे हैं आप?
भास्कर is now in Ambejogai.
अच्छा हो मैडम. बिल्कुल बढ़िया.
खत्म हो गया क्या?
सरांचा टॉक छान झाला आत्ताचा. पीडियाट्रिक कॅटरॅक्ट. सरांचा टॉक छान झाला पीडियाट्रिक कॅटरॅक्ट.
मी टिप्स अँड ट्रिक्स बद्दल सांगितलं ना थोडक्यात. तो आणखी मोठा होता पण मला तिकडे ते सीएम साहेबांची मीटिंग जॉईन करायची होती म्हणून मी त्याच्यातले
फेसबुक वर लाईव्ह
8-10 स्लाइड काढून टाकल्या मध्ये आणि मग मध्ये त्या गुड्या घेऊन तेवढं 1-2 व्हिडिओ आणि ते दाखवलं. नसतं त्याच्या टिप्स अँड ट्रिक्स मध्ये
पण चांगलं म्हणजे कव्हर झालं मेन इम्पॉर्टंट टॉपिक.
Yes, it is covered.
Hello, Dr. Shreya.
Hi, good afternoon.
Shreya.
Namaste. Good afternoon.
Namaste, Shreya. Namaste.
Good afternoon, sir.
Good afternoon.
Hello. Namaste, Sunana madam. Hello.
Hello, Varsha. Namaste. Reshma, make yourself visible. Actually, lunch time भी हो सकता है अभी.
थोड़ा सा पहले का सेशन थोड़ा सा जरा लेट हुआ.
अपना सेशन शुरू होईल 2:15 बजे सेशन शुरू होगा क्योंकि अभी लंच टाइम में और इधर इसमें कांस्की हॉल में ये करो भी उधर सब ये कर रही है गाने गा रही है.
अच्छा.
मैं जरा करोबी को विजिट करके आता हूँ. वो बोली आए
वो गा रही है क्या? ओके.
Difficult to arrange na all these things online sub virtual conferences.
So many
Possible version. See, there is no other option. We don't have any other option right now.
Yeah. Good afternoon, Dr. Shubhangi.
Everything is going on, going on. All conferences are going on. Everything is going on.
Good afternoon. Good afternoon.
Good afternoon.
Hello.
Hi.
Hello.
Hi, Shubhangi.
Hi.
Hello.
But it's so nice.
Hello.
Faces, even if on Zoom. Nice to meet up at least. Why are you looking so thin? You really lost weight, it looks like.
Are you speaking with me?
Yeah.
Yes. I don't know. I guess we can blame it on the pandemic. No, we can blame everything on it, I think.
Everything except pregnancy.
Hi, Dr. Pooja.
Hi. Good afternoon, everyone. Video on the
Hello, Charita.
Still, we have 7 minutes, right?
But I think, but actually, the last Sunday when I joined in, the earlier session was going on, but we were kind of included in that. I think this time they have refined it a bit, it looks like. Only our session moderators and speakers, chairman, so on.
No, that's because there was a lunch break before us, so that's why there was a. That's why we are not.
There's
Yeah.
nothing
Nothing was happening here for last 15 minutes. Yeah.
But this is a nice way of doing it, Sunday to Sunday. In between, organizers also can relax, and so
Yeah.
can the audience.
Yeah. Rather than 4 days at a straight, it's very good idea.
In fact, actually, AIS is also thinking of going virtual, na? This time.
Yeah.
Thinking of means they have to. There is no other option left for them. Because they have thought that in June they'll be able to have a conference in Kolkata, but it's impossible now. So, somebody suggested that why should you have the usual 6-7 days conference which you normally do? Cut it short, cut it down to 3 days. Don't have so many halls, because then you won't get audience in any of the halls.
True. Absolutely right.
Let's see what they do. It's up to the scientific committee to decide.
Madam, this idea of
Hi, Dr. Shubhangi.
to Sunday is very.
Pardon, Dr. Kere?
Yeah.
You are muted.
Hello, can you
Yes,
hear?
yes, I can hear you.
This idea of Sunday to Sunday sessions is very good.
Yes. Only difficulty is that it's a bit long period, like 9 to 6 in the evening. Even if there is a lunch break of an hour, in that also there is a concert. So if there's someone you really want to hear, then you are not going to log off. So it's practically the whole day.
Yes.
डॉक्टर खेरे, आज शाम को डॉक्टर मारिया के लिए वो है
Yes,
condolence meet. आपको
condolence meeting. Yeah.
आपको खबर मिली ना?
Yeah. I will be there.
Yeah.
How are you, Shreya?
Hi, I'm fine, Dr. Shubhangi. How are you?
Okay. Yeah, now I'll just stop my video. I just put it on to say hi to everyone.
I know.
Yeah.
Got another 5 minutes to go.
Hi, ma'am. Hi, Surena, ma'am.
Hi, Rita.
How are you?
Good. How are you?
You're looking also good. Thank you. I still remember the days when I had come all the way to Solapur, Kolhapur, and we had done one instruction workshop on contact lenses. You were such a great support at that time.
Contact lenses has always been one of my favorite topics.
I know, something close to heart. You never remember. I like.
Still is.
But with corneal refractive surgeries, its lost its importance.
No, I think it still has a place. In fact, I have a talk on that in my portfolio. Why contact lenses are still.
No, but only die-hard fans like us will still go on about it. The new generation wants to go ahead with only refractive surgery.
No, but there are patients who are not willing for refractive surgery. And so what do you do for them? You have to give them an alternative.
Correct.
It still has a place in the armamentarium of the general.
But it would have really grown because the amount of varieties that have come in contact lenses, that kind of exponential growth has not happened because it has been countered by refractive surgery.
Yeah, that is true. That is very true.
Because when we learned all those things, very minimal stuff was available. But if you really go to see the stuff available today, I could give them an array of things available and they could choose out of it. But very few people actually want it.
But even today, I have so many contact lens patients who keep coming back because they're not waiting for surgery. Some people don't want to touch with their eyes. Just that. They don't want anything done with their eyes. And in fact, I got my son's LASIK done also about 8 years back. and now his error has come back. So
Oh.
now, yeah, so now he's wearing glasses and contact lenses.
Back. But number must have been lesser, no? Now not.
No, his number was pretty high, and it was a compound number. Now the number is very less. Now it's less, but with so much screen time now during this lockdown, it's increasing.
Oh.
Because he's very fond of the TV also. Hi, Prachi.
Hi, good afternoon, everybody.
Good afternoon.
Hello.
Prachi, you're looking as pretty as ever, huh?
Yeah. Your talk was good. Myopia.
Thank you.
Prematurity and
Thank you.
ROP.
Ashwin sir, hi.
Hi Prachi, how are you?
Good. New lockdown look.
Good afternoon, Dr. Hemalini.
Yeah, that's true. We're hiding behind PP so you can do what you want, grow your hair.
Hi Shreya. Hi Ashwin, Charita, everyone.
Hi Hema.
Hi, Emma.
Hello. Busy.
Himalini has also grown her hair. Huh?
Yeah,
Yes.
Little bit, ma'am. Little bit.
Lots of work to do, Hemalini, right?
And it's not easy to find a salon, nowadays, which is open.
Net user.
We have 1 minute more.
Yeah. Starting time. Let's start it time and finish it time.
Mute.
Anita ma'am, how are you?
I'm fine, beta. You have grown hair. मैंने सुना है.
I think we can start. Puja, start.
Yeah.
Doctor, we are in live.
Good afternoon, everyone. I hope you've been having an amazing Sunday. And as we begin this session, I would like to call upon our chairwoman, Dr. Mrs. Sunaina Malik. And we are very privileged to have her with us. She was the ex-president of the MOS and a very revered practitioner from Aurangabad, not needing a great introduction. Also to add to her, we have the co-chair, who is our powerhouse, Dr. Neeta Shanbhag, one of the finest teachers with several accolades and a very integral part of the Mullen Ophthalmic Association. We have Dr. Shruti Mittal, who is the convener. She's an alumnus of Shankar Nethralaya and a freelancing practitioner in pediatric ophthalmology and strabismus in Thane and Mumbai. And we have Dr. Rushabh Shah, who's an alumnus of Arvind Eye Hospital and is the director and practicing in Mumbai, private practicing in Mumbai. I would like to hand over this session to Dr. Shruti and Dr. Rushabh. As we want to stick to the time, and in case we have any technical glitches, I just have a request that the second speaker also keeps the presentation ready so that in case there is a problem with loading, we will load the next presentation. Thank you. Thank you, Dr. Pooja, for the introduction. A very good afternoon to all the faculty members, the chairman and the co-chairman. I would like to introduce Dr. Pooja. She will be the moderator for our session. She is alumnus of Narayan Nethralaya and she is currently practicing as a pediatric ophthalmologist and strabismologist in Mumbai and Thane. Now, I would like to invite our first speaker without wasting too much time. Like Dr. Pooja said, we want to stick to our time discussion towards the end. I call upon Dr. Shreya Mehul Shah. She has many years of experience in pediatric ophthalmology and she is the founder of Drashti Nethralaya. Dr. Shreya Shah.
Good afternoon, everyone. And I'm grateful to Dr. Sunaina ma'am and especially Dr. Hemalini Shah, for allowing me to speak on very, very rare topic, which is management of chemical burns in pediatric age group. And we know all the substances which are causing chemical burns. Acid cause less damage, but hydrochloric acid causes is an exception, and it does the damage as the alkali does. Sometimes penetrates the posterior segment in first sitting only. There are lots of classification, Huggies, Thoughts, Roper Hall, but we are using newer classification which involves the conjunctiva also. So we'll talk in 5 phases for chemical burn: immediate, acute, early reparative, late reparative, and sequelae. And for all the structures, we'll look into what happens to cornea and conjunctiva. But the first most emergency response is to be thorough wash, preferably with Setter eye wash. And sometimes we may have to use Morgan lens just to facilitate the irrigation. And then proper examinations, wipe out all the chemicals from the fornices and continue examining eye till the pH becomes normal. And when the eye enters into the acute stage, there will be a lots of inflammation, copious discharge. And the goal here is promote epithelial healing, reduce pain, decrease inflammation, and prevent bacterial superinfection. So in grade 1, usually we prescribe antibiotics, steroids, cyclopentolate, and follow at least every other day. But grade 2 to 4 or 6 needs more follow-up. Topical prednisolone for more days, long-acting cycloplegic like atropine, topical broad-spectrum antibiotics, oral tetracycline, and high dose of vitamin C always helps, and control of IOP is must. These patients always have to follow up daily, and sometimes after few hours, and sometimes we may have to add as methotrexate also. But what happens, we have done all the listed thing. This 8-year baby had been treated somewhere else and was treating since 1 month. But after 1 month, when we looked, the still line particles were lying under the upper fornix. So don't ever forget to double evert the lead. That is the utmost important. Debridement is the choice of treatment here to restore the corneal clarity, normalize the ocular surface, and prevent glaucoma. The 7-year girl had a Lyme injury, and what we did, we have to debride all the necrotic tissue. We took the limbal cell from the normal eye, her own, and then we glued the amniotic membrane on that injured eye with the fibrin glue, and we cut this limbal cells. We segregated on the amniotic membrane to allow it to culture, and then we put the bandage contact lens. So this is after 1 month. We did same procedure. It is called SLATE by Dr. Sangwan. We did same procedure in another boy, and this is 3 months post-op, which was published in IJO also. So when cornea and conjunctiva enters into early reparative stage, they will have mostly symblepharon, may sometime present with diplopia. So symblepharectomy is the choice of treatment, maybe with or without AMG. Simple symblepharectomy sometimes works, but when there's late stage, you need to put amniotic membrane graft. All the time we may not have fibrin glue available with us, so we may suture the amniotic membrane, but don't forget to remove all the scar tissue before going further. Sometime in this patient, to gain normal vision initial period, we may put hole in the central hole in the amniotic membrane. Let's look what happens to lead, socket, lacrimal area, orbit. For lead also in immediate, usually there will be a skin burn, may be associated with thermal burn. But in acute stage, there will be lots of lead edema, so need to take care. When it comes to reparative stage, patient usually presents with ptosis, and this ptosis is because of, again, symblepharon. This 3-year boy had a symblepharon and ptosis. We released the symblepharon and put the mucous membrane graft. So this is 1 month post-op and 3 months post-op. Sometimes patient presents with strabismus just because the chemical has entered to muscle, and also it has damaged the posterior segment, but we may have to regain the motility also. Don't forget to put fornix forming suture here. Sometimes patient presents with entropion, and majority of entropion here is the shortening of posterior lamella. Patient may have trichiasis, and we do ciliary bed transfer special procedure for this trichiatic patient. We take the whole trichiatic bed from the lead margin, partial thickness cut in the tarsal plate foot, and this whole bed shifted to 3 to 4 millimeter below and anterior to the lead. So this will not be a problem later on. The same boy had trichiasis, and this is 6 months post-operative. Sometime this girl presented with lots of keratinization. So mucous membrane graft is the choice of treatment here. Properly remove all the keratinized tissue. Properly remove all the keratinized tissue from upper and lower lid, and then mucous membrane is glued on the surface. So similar girl after 3 months. So you can regain the cornea. Again, another girl we had done mucous membrane graft. Sometimes trichiasis with upper lid entropion comes, lengthen the posterior lamella, or here in this case we may have to augment. But usually in children they come with the enkyloblepharon. So in this boy, lucky boy, actually his cornea was very good. We cut this band and he was doing very good. But in this kind of patient, don't forget to treat amblyopia. Ectropion usually because of scarring. Leg ophthalmos can be there, simply can be treated by tarsorrhaphy, or sometimes we may have to support with the skin grafting. So what happens to lead entropion? Lengthen the posterior lamella with MMG, AMG, ectropion, remove the cicatrix and skin graft, trichiasis, ciliary bed transfer, and lead defect, treat accordingly. What happens to orbit? Orbit usually doesn't come as early unless trauma, but late when they may present with shallow fornix, sailed fornix, obliterated fornix, wet socket, contracted socket with lead deformities, dry contracted socket.
1 minute to
So
go.
treatment here is AMG and MMG. We can put this fornix formation construction and then MMG to put the better prosthesis. So sometimes we may have to support with lead skin grafting to put proper prosthesis, but don't forget to put fornix forming suture or symblepharon ring, or sometimes simple conformer box if you don't have anything. This 3-year boy we had to do canthotomy, dermis fat graft, and amniotic membrane to fit the proper prosthesis. So we may not give vision, but give better cosmesis. This kind of patient always needs a lots of follow-up. What happens to lacrimal area usually comes with the canalicular stricture, and conjunctival DCR is the choice of treatment with glass or Pyrex. But we have done our own innovative technique. This is we have designed this modified pigtail probe. So here we just probe the strictured canaliculus upper and lower, and then we have this pigtail shape needle, blunt tip needle, along with the silicone tube, and it comes out through the other punctum, and then we get
time.
Yeah, it's
just
done.
wind up
It's
the
only one slide. So sometimes we look at DCR we may have to do. So finally, what happens to lacrimal system? Canalicular system, thorough wash but no syringing. Conjunctival DCR is the choice, and in our case, we are doing probing with modified pigtail technique, and when the lacrimal sac is involved, probing with bicanalicular intubation when the puncti are normal, but when the puncti are not normal, we have to go for intracat DCR with skin root. So I conclude with that it needs multidisciplinary approach, multiple surgeries, poor prognosis, and sometimes legal issues also. Thanks to my patients. Thank you all. Thanks a lot. I will stop sharing.
Yes. Thank you for the amazing talk. And we would like to call upon the next presenter, Dr. Ashwin Senani. He is a great teacher, and he's been a teacher to me and practicing at Hinduja, and has a private practice in Mumbai. He's going to be talking to us about screen time and blue light, demystifying the myths, the need of the hour. Yes, Dr. Ashwin, you can start.
Thank you, Pooja. Am I audible?
Yes.
Okay, great. So thank you for this opportunity, BOA. And today I'm going to speak to you about screen time and blue light. Now, we've all had patients and parents asking us these questions all through the pandemic. And sometimes I feel that we're answering these questions uh, differently for different patients. And I thought it would be nice to answer some of these questions scientifically. And so the commonest question we get is, oh my God, my child's eyes, my child is on the screen for too long. How much time, doctor, should I allow him to see the screen? Will he get glasses? Will it worsen? Is the blue light harmful for my child's eyes? Does he need to wear blue blocking glasses? How do I prevent all of this? So I thought we'll try and answer some of these questions. Let's see how. Now, there is enough evidence to tell us that screen time affects the body as well. So I thought we'll go through some of these points first. It is proven to be habit forming, and it reduces, it affects the child psychologically as well as socially when screen time goes beyond a certain limit. But most importantly, there is very clear evidence that it affects the cognitive and language development in the younger children, especially below the age of 2 years. There is very good evidence that it disturbs sleep patterns, especially the blue light is something that affects sleep patterns at all ages, not only children. And by virtue of increased screen time, there's reduced physical activity, and that is the association with obesity. So we do know the short-term effects. We are very, very well aware of computer vision syndrome, and dry eyes is a part of it. So reduced blinking and increased evaporation can lead to symptoms of dry eye, and the computer vision syndrome just also includes, neck strain and headache and things like that. But sometimes we forget about the accommodative problems that come along with increased screen time. So there is a sort of an increase in accommodative spasms and accommodative esotropias during this pandemic because of the increased screen time. And so we need to be aware of this condition and pick it up. We're also very aware about myopia progression or appearance of myopia. There's a form of an epidemic of myopia that we are seeing through the pandemic because of increased amount of near work. It is important to understand that this myopia progression is more because of the peripheral defocus during the near viewing task. That is an inappropriate accommodation that is the cause. This inappropriate accommodation stimulates the growth of the sclera, and it's not necessarily due to the screen or the blue light from the screen. So it is important to know that myopia would equally occur with reading a book or a Kindle or any backlit device. So let's understand a little bit about some evidence regarding blue light. Now, there's been an explosion of blue blocking glasses by the online optical partners, and almost every parent, wants to know, schools want to know whether that's something they should be advising children across the board. Now, there is very little evidence, very little clinical studies on blue light damage to the eye. Most of the studies that we have in literature are either in vitro studies or animal studies. There are some studies telling us that it can affect cornea as well. The lens as such acts as a protective sponge, and it absorbs blue light and prevents the transmission of blue light to the retina. And we do know that a younger lens or a child's crystalline lens absorbs more blue light than an adult's crystalline lens. But the main damage that has been proven is of the retina. Still, these are all animal studies. So my studies in rabbits have shown that there is damage to the retina when there is a prolonged exposure to blue light. Probably the only clinical studies we have is ARMD progression post cataract surgery. That is, once you have removed the cataract and now you have an artificial lens. But these were done, before the newer lenses which also block blue light. Now, there is very clear evidence that blue light affects sleep. Our sleep hormone melatonin, it actually has an evening rise, and that's why we feel sleepy. But it is the blue light that inhibits the blue light that inhibits melatonin. Essentially, what it does is it makes your brain believe that it's still daytime, and so exposure to blue light just before sleep definitely affects your sleep pattern. So using a blue blocking glasses or a night mode on your device is something that I do advise my patients, especially for screen just before sleep. If that has to be done, best to avoid that. Now, there's this excellent study done by O'Hagan on blue light damage to the eyes. Uh, the International Commission of Non-Ionizing Radiation Protection has already defined the set safety levels of blue light radiation that affects the retina. So what O'Hagan did is he took all the possible computer screens and tabs and smartphones, and he measured the amount of blue light that is coming out of these screens at the maximum brightness. And he found that the levels were less than 0.5% of the exposure limits set by IC and IRP. He, in fact, even concluded that the blue light coming from the blue sky is far more than the light coming from the LED screen. So he concluded that even under long and extreme viewing conditions, these devices are not a cause of concern for the eye health. I'm talking about only blue light. So some recommendations for screen time. Of course, we give all of these to our patients. I'm just going to enumerate them. Consciously blink, avoid a direct flow of AC or fan on the face. Posture helps not only the neck and the spine, but also keeping the screen slightly below the eye level helps reduce the evaporation. The brightness of the screen should match the brightness of the room, which means if you have a bright room, then increase the brightness. Dim room, reduce the brightness. We all know the 20-20-20 rule, but how many children will remember that 20 minutes have passed and we need to take a break? So you need to bring reminders like 2 chapters or 1 level of the game is over, or put a bookmark, something to remind the child to take that break. Dr. Aarti is going to speak to us about myopia progression. So some of the things that I tell my patients is reduce screen time as much as you can. Online classes have to go on, but take breaks. Should not reduce book reading, 60-minute outdoor activity, avoid screen 1 hour before sleep, and preferably use a television rather than a smaller screen. And of course, visit your pediatric ophthalmologist to know whether low dose atropine is needed. Finally, the biggest question, how much screen time is safe? Well, there are no studies, but there are some recommendations. There are some Canadian pre-COVID studies that have recommended less than 2 hours of recreational screen time. But
I would like you to conclude, Dr. Ashwin.
yeah, this is my last slide. So the online classes, there have been some limits put in by Ministry of Human Resource Development, and they said 30 minutes for pre-primary, 1.5 hours for 1st to 8th standard, and 3 hours per day, 9th to 12th standard. But I don't think any of the schools are following this. Finally, the American Academy of Pediatrics has recommended no screen below 18 months, some screen between 18 and 2 years, and 1 hour between 2 and 5 years. And this is all for cognitive development, not eyes. But they said that there is no specific limit for 6 years and older as long as it doesn't interfere with sleep and physical activity. Thank you for listening.
Thanks, Dr. Ashwin. That was a really nice talk. Now I call upon our next speaker, Dr. Sunaina Malik. She is a phenomenal medical teacher, an ophthalmologist, and a strabismologist. She has been a founder and honorary secretary of Aurangabad Medical Ophthalmology Association and immediate past president, Maharashtra Ophthalmological Society. She's going to speak on how to counsel a patient with strabismus. Over to you, ma'am.
Yeah, I'm just trying to share. I'm screen sharing, but I'm not getting my, yeah. Okay, thank you. Sorry for the delay. Now, the topic given to me is a very nice one because I like offbeat topics like these, you know, which I can talk about from my experience, which is pretty vast, about 43 years of work in ophthalmology. So I think I am in a position where I can talk about how to counsel a patient with strabismus. Now, the dictionary meaning of counsel means advice, especially that which is given formally. And I would like to tell you how you begin, because you don't begin when you start talking actually to the patient, but the process begins from the time the patient enters your room. You have to observe his or her demeanor, mood, facial expressions, because that will give you a lot of clue as to how apprehensive the patient is, particularly if he's a minor. You have to look for all this in the accompanying parents or guardians who also can be very worried. And all this actually helps when you begin counseling them really. Another point which I would like to make is that when you begin talking about the surgery, please send the child out of the room, because that can be scary for the child to hear. We don't realize it because we are used to that on a day-to-day basis, talking about operations and surgeries. But for lay persons, it can be really bad, and especially for children. So please send them out of your consulting room with a accompanying adult, and then talk to the parents or the guardians, whatever you need to. Now, point to remember is that no matter how many optometrists, counselors, or ophthalmic assistants you have, the final counseling has to be done by you. There can be no other way other than this, because it makes a huge difference to the patient. After all, they are coming for you and no one else. Many times a patient will ask me, "Ma'am, are you going to be doing the surgery?" So I tell them there's no one here other than me, because mine is a one-woman show. So, because when you talk to them, it enhances their trust in you. And at the end of the day, that is exactly what matters. Why they will agree to go in for surgery or treatment. Even if you're doing amblyopia treatment and not just strabismus surgery, that also needs a lot of counseling and trust by the patients in you. What are the questions generally asked and your answers? I've taken it this way. So the first question which is generally asked is it hereditary? Now my answer is it could be, because if there's a family history which is positive, it is possible that it is hereditary, but it may not be also. Then is it treatable? Of course, it is eminently treatable. All of us as strabismologists know that. We have to emphasize on the fact that it is treatable and they must treat it. How is it treated? This depends on the type of squint, associated conditions, but the options which are available with us are optics, occlusion, orthoptics, and of course, operations. Then the next question which comes particularly when the child is small is, how safe is surgery on my child? And my answer is, it is very safe nowadays, particularly because of modern drugs and new trends in anesthesiology. And anesthetists are very good in pediatric anesthesia. So there's no need to worry on that score. Guarantee. This is a question which every relative will tell you to answer. Will it be 100% corrected? My answer always is, there are no guarantees. Because there are no guarantees in life. My best answer is, I will do my level best, and that's the most that I can do. And I think that generally satisfies the parents or the guardians, because they understand that you can't do more than that. Then the next question is, will it become all right in one surgery? Now, this I've learned the hard way, that you should always tell them about the need for a second surgery. Even if it may not be needed after one surgery, tell them right at the beginning, because I did this mistake once, I did not, and the patient needed a resurgery, and they got the impression that I was trying to fleece them, which was not true. But make it a point to tell them that the child may require another surgery depending on the degree of squint. Now, this is a patient of mine, my very favorite patient. I always show her picture. It was a huge XT. And your answer should be, it also depends upon the amount and the type of the squint. Here, she was absolutely unwilling to undergo surgery, but because of her mother's insistence, and more because she was shifted from the front desk in her office to the back office, she decided that, okay, she has to undergo surgery. She understood that it was a cosmetic problem which was bothering her employers. And this is the result of one single surgery which I did on her. This was the first and only time that I have tackled 4 muscles in one surgery. I never do that. But then she became perfectly all right. So the next question is, will it come back? It generally doesn't, but there are many other factors involved. So we cannot give a promise that it will not come back. Then, especially at marriageable age, will people come to know that he or mostly she has been operated? Of course not, unless you tell them. But When it's a person of marriageable age, when the patient is of marriageable age, especially if it's a girl, I tell the parents to please tell the opposite side about the surgery that has been done, because why should you hide it from them? It is not something that you have been doing wrong. She's corrected, she's perfectly all right. The fact that she's undergone surgery should not be an obstacle in her marriage, but if it comes to light afterwards, she may face the consequences. So better to keep your cards on the table right in the beginning. Will glasses be needed after surgery? Now, this is very important to counsel that squint and refractive error are two different things and they are not to be mixed up at all. Because many parents feel that once we correct the squint, her refractive error will go away. But no, it may not. In fact, it doesn't. We have to treat both the things simultaneously. Now, the $1,000,000 question, of course. How much will it cost? So again, that depends on a lot of things. For example, number of muscles to be operated, etc. And here I'd like to tell you a small incident of a patient that came to me. The father brought his daughter, and after examining her and telling him of the need for surgery, he asked this question. So I told him it will cost this much. So then he came out with, he didn't tell me in the beginning that they had been to someone else. At this point, he told me, but I have shown her to another doctor and he said a lot less than you. So then I asked him, then why didn't you get her operated there? He said, no, नहीं, आपका नाम बहुत सुना था, इसीलिए. So I said, फिर आप ऐसा समझो कि आप नाम के पैसे दे रहे हो, जो एक्स्ट्रा दे रहे हो, वो मेरे नाम के पैसे दे रहे हो. After that, he was quiet. He didn't say anything further. But you do get patients like this who ask you very silly and funny questions, you know. So I acknowledge all my patients for teaching me all of this so that I can tell all of you about this, especially the newcomers who are beginning their practice. And because sometimes you may go wrong in telling them and the patient may not stay with you or may not come back to you. But I do acknowledge my patients. Thank you so much. Please stay home, stay safe, all of you. I want to meet up with you personally after all this is over.
Dr. Sunaina, this was a very relevant and practical topic that all of us need to take. And now I would like to introduce the next speaker, Dr. Varsha Pandey. She is a private practitioner and practicing pediatric ophthalmology and business since 25 years in Nagpur. She's a regular faculty in state, national, and OC conferences.
Yes, hey everybody, I'll share my screen. Yes, yes. Hello, can you see my slides?
Yes, yes. Varsha, go ahead.
Yeah. First, I would like to thank Scientific Committee BOA for giving the opportunity. I'll be talking on vision assessment in pre-verbal and preschool children. Vision assessment meaning estimating maximum ability to see, and it is defined as resolving power of eye or ability to see two separate points. And these two distinct points will be visible only when two separate cones are stimulated. And the normal standard vision 6/6 is equal to angular separation of 1 minute at fovea. So in adults, it is very simple to assess vision with a Snellen's chart, but measuring vision in pre-verbal and preschool children requires special skill, time, patience, and special tests because the visual system is immature and there is no patient cooperation. So the methods of vision testing in children depends on child's age, abilities, knowledge, and available facilities. We all know the normal visual milestones, but just a reminder, it is helpful in estimating the visual potential. So the maturation of visual system in fixation usually is developed by 2 months, and the response to moving objects by 2 to 3 months, and the pointing to objects and matching form is by 2 to 3 years. So the various tests for vision assessment are grouped in 3 types, like detection acuity test, recognition tests, and resolution acuity tests. The vision tests in infants are the important one is CAT4 drum test. It is useful in infants and preschool children. It is a detection acuity test. The pendular eye movements elicited as the child follows the oscillating drum with dots determines the visual acuity. The dots of various sizes are there, and the test is done at 2 feet. And the smallest dot that evokes pendular movement determines the visual acuity. But the disadvantage is that it overestimates the vision. Another important test is preferential looking test. These are psychophysical tests based on preferring to fixate a pattern stimulus rather than a blank surface of the same brightness. So commercially available PL cards are available and they can be used in clinics. The Telerecuity card, these are the simple and rapid testing done for children up to 18 months, and it is modification of preferential looking test with the 17 cards are there. And the highest frequency grating which is seen gives the measurement of acuity, and it can be converted into Snellen's notation. But the drawbacks is that the test is for near acuity, and it may miss myopia, and sometimes it overestimates vision. Then the Cardiff acuity cards are based on the principles of preferential fixation on cards. So cards have pictures of vanishing optotypes. There are two dark lines with various width of space in between. And depending on that width, the pictures vanish at some distance. And the optokinetic nystagmus drum traversing slowly before a normal infant's eye produces involuntary jerky nystagmus, and the smaller the target producing optokinetic nystagmus indicates better visual acuity. But again, visual acuity cannot be graded with this. VEP is another highly advanced test to determine the integrity of the nerve transmission from eye to occipital lobe. It is a non-invasive test done monoocularly, and it records the electrical signals generated by occipital cortex in response to visual stimulation. It is an objective record of underlying visual pathway. It excludes organic pathology, and the stimuli can be pattern or unpatterned flash, and we can have flash VEP, pattern reversal VEP, or sweep VEP, which this sweep VEP is important in cases where their vision is very poor. It produces 20 stimuli in swift fashion, and it is a rapid test, and it can be done in just 10 seconds and can give you an idea in very kids with infants with poor vision. But again, disadvantage is that it overestimates vision, it is expensive, it is time consuming, and most of the time it is not available because of the availability. It cannot be done in all cases. So what all these tests are there, but I would like to emphasize more on this, the indirect assessment of visual acuity in infants. And this is very important and practical, and everybody, general ophthalmologist also can get an idea about vision. If we take a proper brief visual history, if the examination of anterior and posterior segment is done nicely, detailed, and then the pupil reaction, presence of squint and nystagmus, then cycloplegic refraction, blink reflex, Bruckner's test for screening, and fixation reflex. These tests will definitely give us an idea about the vision. Then the reflex response, the baby blinks at birth in response to sound or touching the cornea. So blinking on approach of the object by 5 months. So clinically, this blink reflex gives an idea. See, even if it is taken so close, the infant is not looking at the object. Then the fixation again is a very important, fixation reflex is again a very important point to be noted. It is present at birth, and it is an important clinical test well established by 2 months. It is practical and easy. Here we can just see, even if the light is thrown to the, so there is no response, there is no fixation even to the bright light. So that gives us the idea that the vision is very poor in this infant. And the type of fixation, central steady fixation, is a very, very important examination, and it will give you a good idea about the if the fixation is central, that means he is fixating at fovea steady, there is no nystagmus, and it is maintained, means there is no ocular dominance, and this should be observed by both eyes open as well as separately. And if this chart, everybody knows about this chart, and it definitely gives a very good idea about if the vision is very less, like if there is gross eccentric fixation, the vision is less than 1 meter. And if there is a steady central fixation but it is not maintaining, then it could be 660 to 636. If there is a central steady fixation, prefers other eye, then it could be better vision between 624 to 69. And if there is central steady fixation freely alternating, that means vision is good in both the eyes. Then another important test is if the child is fixating with only one eye, preference of fixation, like in unilateral squint in this case. The other eye, right eye, is not taking fixation at all, indicates amblyopia or poor vision in the right eye. And so this good examination definitely tells us the amount of vision the child is having. Then resistance to closure of one eye. If you try to cover her left eye, the child will cry and will try to remove the cover. So indicates poor vision in the other eye. Then induced tropia test is 10 prism based down in front of apparently fixing eye. Normally it causes both eyes to jump up if there is a good vision. Just one. And if there is no vertical movement, then the vision is poor in the fixating eye. Then in between 1 to 2 years of age, the child's attention is easily distracted after 9 months. So teller acuity cards, Cardiff acuity cards are not useful. We can have Boeck candy test where small edible candies of 1 to 2 millimeter size shown from a distance of 33 centimeter. And if there is difficulty in picking up, that means the vision is less than 24. And again, in this, each eye can be tested separately and difference is noted. Ivory ball tests, these are balls of different sizes rolled on floor, and the smallest ball picked up will give you about vision of that kid. Then in between 2 to 3 years, miniature toys tests, coin tests, dot visual acuity tests, smallest dot identified correctly on the illuminated box will give you idea about vision. Then Allen picture cards are also useful in preschool children. These 4 plastic cards. Yes, just my last slides, madam. So these are the various tumbling EC, Sheridan tests. These are all in the 3 to 5 years of age group, and these most of us are using in our OPD. So just to conclude that visual acuity tests in pre-verbal children needs expensive test material. They are operator dependent, time consuming, and did not give correct vision always, and may overestimate, may miss amblyopia. So purely objective tests like VEP can give you idea, but it is mainly in the institutional setups, costly, and so may not be available always. So most of the time, I think the careful examination, observation of the child is must, and it gives important clues about from the fixation pattern and response to occlusion. And another important point in testing vision that establish a good rapport with the child and the parents, the reward for positive responses. Exam should be more fun than the test, and several tries at different times within the child's attention span will give you a good idea about the kid's vision. Thank you for the patient hearing.
Thank you, Dr. Varsha. It was a really nice presentation. We move on to our next speaker, Dr. Bhaskar Khare. He is presently working as a professor and is head of the Government Medical College at Ambe Jogai. He has a special interest in oculoplastic surgery. And this topic for today is community approach to management of a squint. Dr. Bhaskar.
I'll stop the sharing. Just a minute. Yeah.
Hello, good afternoon. Can you hear me? Hello.
Yes, you are audible.
Yes, we can hear you.
Thank you, BOA, for giving me this opportunity to share my experience of community approach in the management of squint. I dedicate my presentation to all my patients. This was a teamwork done by 3 different departments of the government of Maharashtra, which includes education department, which provided the funds, the equipment, and the drugs required for this management of the patient. The public health department provided the infrastructure required for doing treatment of the patient, and the medical education department, from where the expert manpower was provided. This was a prospective study done for consecutive 3 years in the 3 districts, which included Ahmednagar district, Bid district, and Latur district. All the students were from the Jilla Parishad school from 1st standard to the 10th standard. This is done under the school health screening program, and the screening was done at 3 different levels. The primary screening of the students was done at the school level by the school teachers, and students with some ophthalmic problem were listed out, and then they were referred to the PSC or rural hospital for the secondary screening level. At the PSC level, the students were examined either by the medical officer or the ophthalmic officers posted over there, and the students with specific ophthalmic problem who require further treatment were again referred for the final screening to the civil hospital. At the civil hospital level, all the students were examined by the ophthalmologist, and accordingly, 4,636 students were examined at the civil hospital level by the ophthalmologist. And these are the some of the problems which we could find out in all the students. The refractive errors were present in almost 75% of the students. The squint was observed in 15% of the patient. 3% of the students were having congenital ptosis. 1% of the students were having congenital cataract. Then vitamin A deficiency, congenital malformations, congenital glaucoma, ocular trauma were some of the other ocular problems observed in the students. Now, all the squint patients, we know that squint is nothing but the misalignment of the visual axes. In simple word, it is nothing but the deviation of one or both the eyes. Etiologically, squint can be because of the hereditary reason. The refractive errors may be responsible for the squint. There may be developmental delay. In some patients, there may be anatomical cause, or there may be innervational anomaly. The thorough examination was done in all patients, which included detailed history regarding the squint. For example, since when the squint is present, is it since birth or it is acquired, whether the one eye is deviating or both eyes are deviating, whether the squint is alternating, and whether it is stationary or increasing. All these points were noted. Then general examination of the student was done, and thorough ophthalmic checkup was done in each and every student, which included recording of the vision of the both eyes, doing cycloplegic refraction in each and every case, and redistribution of spectacles was done whenever the child was having refractive error. Fundus examination was done to rule out any fundus pathology responsible for the poor vision. Then cover and uncover test was done to know whether there is presence of pseudosquint or true squint, or there is any heterophoria in a given case. Whether the squint is unilateral or bilateral, it was noted. Whether the squint is, whether the child having esotropia or exotropia was also noted. Hirschberg's corneal reflex test was used to know the degree of squint, and depending upon whether the reflex is in the center of the pupil or at the pupillary margin or at the limbus, the degree of squint was recorded. Extraocular movements were tested, and the sensory evaluation was done. So these are the observations. All the students were in the age group of 15 to 16 years. Boys were, there were 298 boys and 400 girls. Esotropy was present in 380 students, and exotropia was present in 316 students. Going about the degree of the squint, the 15-degree squint was present in 65 students. The maximum number of students were having 30-degree squint, that is 503 students were having 30-degree squint, and 130 students were having 45-degree squint. Regarding the management of the patients, they were examined for the refraction, and whenever patient was having refractive error, the spectacles were prescribed and given free of the cost. The surgery was planned for the residual squint, and before doing a surgery, pre-operative counseling of the patient, that is students, parents, and the teacher was done. This is how we did the screening and counseling of the patient. Now, the students selected for the surgery, the criteria was patients with the concomitant squint, either iso or exotropia. Only patients with horizontal squint were included. The students with any vertical component, or students with any other ocular abnormality, or students with any problem with the extraocular movements were excluded. The goal in doing surgery was to make the eyes straight and to improve the vision. All the patients were operated under general anesthesia using short ketamine without intubation. Standard.
So to conclude.
Using standard recession and resection technique. One muscle was operated in with 15 degrees, with 30 degrees squint, two muscles were operated, and with 45 degrees squint, the surgery was performed in two settings in two eyes. This was the follow-up done for almost 1 year. In under correction was seen in 10% of the cases, and no any other major post-operative complication was observed. These are some of the pre-operative and post-operative photographs. In 90% of the patients operated, orthophoria was observed with good cosmetic correction and good patient, parent, and teacher satisfaction. So in the society, the squint patients, it is supposed to be a stigma, and they are not accepted in the society. And moreover, as the Malik madam has mentioned, whenever the girls become of marriageable age, again there is problem. So the take-home message is the squint is one of the treatable cause of childhood blindness. Knowledge about the squint and its correction should be imparted in all the schools, and particularly to the teachers. Proper parent and patient counseling is must before doing squint surgery. So to conclude, early detection and management of the squint will improve the cosmetic appearance, will improve the school performance, will improve the mental and psychological development of the child, which will lead to healthy child, healthy society, and healthy nation. Because after all, it is about the vision, it's about the children, and it's about the nation. I would like to thank my team for giving cooperation during all this work. Thank you for patient listening.
Thank you, sir. Moving on to our next speaker, Dr. Rebecca. She's an associate professor in strabismus and neuro-ophthalmic services at RP Center, AIMS, and has over 70 publications to her credit. And she's going to be speaking on amblyopia and recent advances. Thank you.
Rushabh, before she starts, I want to say something about Bhaskar. Bhaskar is my guru also. Bhaskar taught me oculoplastic surgery and squint surgery in Ambi Jogai. Thank you, Rushabh. Thank you,
sir.
Sure.
Thank you, sir.
Thank you, sir.
So, am I audible?
Yes, you're audible.
Yeah, thank you so much. So, at the outset, I would like to thank the organizers, Dr. Himalini, for having me here. And I'm quite delighted to share this platform with such amazing speakers. So, the topic for today, it's amblyopia and recent advances. Well, amblyopia is something that, becomes an obstacle in the management of most of the diseases that happens in childhood. And so I would just brush up the few basics and then come on to the recent advances. So coming to the definition, well, it's the decrease in the vision in one or both the eyes that's caused either by the abnormal binocular interaction, as we see in case of strabismic amblyopia, or a pattern vision deprivation that we see in case of the refractive or visual deprivation amblyopia. And this occurs during the critical period of visual immaturity. That's the initial 2 to 3 years. Well, it's broadly classified into these three types, and another fourth type is a reverse of the occlusion type that may be seen as a consequence of overtreatment with occlusion. And visual deprivation amblyopia, well, it's the most difficult, the most severe form of amblyopia, the most difficult to treat. Well, pathophysiology, it has been given by the pioneering work of Hubel and Wiesel that we all know. They showed that how the ocular dominance columns in the eye received, basically ocular dominance columns that receive the input from the amblyopic eye, they tend to become shrunken, while those receiving from the better eye are expanded. So it would be, not wrong to say that amblyopia is a neurodevelopmental anomaly. So in the workup, well, workup consists of a basic vision assessment. Pre-verbal children, it can be challenging, and that has very well been beautifully been described by Dr. Varsha. You have to check for ocular motility. Do rule out an organic cause, because we should first be very clear that it's an amblyopia and not an organic pathology. Otherwise, the management is going to fail. Check for the sensory functions like binocularity, stereoacuity. Prevention is very important. That can be done by early screening of children, by prescribing appropriate refraction, and by treatment of any underlying cause, if any, like a cataract, etc. Then comes your management. Well, before we start with the management, the main thing is that efficacy of any management of amblyopia decreases with increasing age. So important is the early identification and the early initiation of the amblyopia therapy. Well, the conventional therapies are the optical correction, occlusion therapy, or penalization. And the newer ones that are evolving are the active vision therapy, pharmacotherapy, and perceptual learning. Whatever be the therapy, there are a lot of factors that influence the outcome after the management of amblyopia. The important ones being what is the age of starting the therapy, baseline vision, type of amblyopia, density, compliance. Compliance or adherence to therapy is a very important factor that determines the outcome. So first step in the management becomes the optical correction. So you do an age-appropriate cycloplegic refraction and prescribe the glasses. Well, pedic studies, the amblyopia treatment studies have shown that just with refractive correction, you can obtain significant improvement in cases of not only in refractive amblyopia, but also in cases of strabismic or mixed amblyopia, and as well as in older children up to 17 years. So maximum improvement is seen in the initial 4 to 12 weeks. That's referred to as the refractive adaptation period. Then the next step is the occlusion therapy. Now, occlusion therapy still remains the gold standard for management. And what's the best way to do it? Well, you apply an opaque adhesive patch onto the skin of the better eye, but remember, ask the child to wear the refractive correction over it. So it causes a preferential stimulation of the amblyopic eye. So occlusion therapy could either be a full-time occlusion, could be a part-time occlusion. Well, full-time occlusion, it could be given in preschool children. It causes a faster recovery, but there is a higher risk of occlusion amblyopia. Part-time occlusion has been preferred by amblyopia treatment studies, and they have shown that in severe amblyopia, 6 hours of patching is equivalent to a full-time patching. In moderate amblyopias, 2 hours of patching is equivalent to 6 hours of patching. So basically, the gist is you start with lower duration of patching, lesser duration. And if the child is accepting it, if the vision is improving, continue. But if there is no improvement, then you can consider jumping to a greater duration. Plus, we can also add various adjuvant near activities like, a high eye-hand-eye coordination task or active vision therapies, etc. So usually an improvement is expected in the initial 3 months, but if there is no improvement in the amblyopic eye on 3 bi-monthly follow-ups, well, it's defined as a failure. And the most important factor that leads to failure is the poor compliance. So it's always a good idea that you counsel the parents and then counsel the the children about the importance of the therapy, motivate them at the initiation. Otherwise, the chances of failure are quite high. Then maintenance, yes, do not abruptly stop the occlusion therapy once your vision has been fully or maximally improved. Rather, you should have a maintenance duration of around 1 year usually, and in which you gradually decrease the duration of your occlusion. Otherwise, the risk of recurrence is there. And recurrences are most commonly seen in the first year of stopping the treatment. So a maintenance therapy followed by an observation follow-up of at least 1 to 2 years is always a good idea. Now, newer occlusion therapies that are being tried are the intermittent occlusion therapy. An example is the liquid crystal glasses using Ambly's glasses. Well, they tend to alternate between opaque and transparent phases. It's believed to be more child-friendly. Compliance is expected to be better. It's a promising technology, but there is paucity of literature. So, yet evolving. Penalization, it's a form of partial occlusion. So, it's more effective in cases of mild amblyopia or as a maintenance or weaning off therapy. Now, it could be either optical, using overcorrecting plus glasses that causes a distance blur, or it could be Banjota's filters, which are stuck to the back of the glass. Then pharmacological penalization using cycloplegics like atropine, it tends to cause a near penalization. And amblyopia treatment studies have shown that even a weakened atropine dose is quite effective. So it's quite convenient for the children to put it, and the compliance could be better, but remember it's only for mild cases or maintenance cases. Then newer alternatives, we have the pharmacotherapy. Well, the basis is that it tends to augment the CNS plasticity. So we can either, the most commonly used drug is the levodopa, and that's a dopamine precursor, and it's an important neurotransmitter in the visual cortex. So there are contradictory reports, but it has been seen that higher doses, especially in treatment-naive cases, can show improvement. Then citicoline is another neuroprotective agent, and oral formulation is available for this. So there are lack of well-designed RCTs in this, but we did a RCT from a center, that is Dr. Vishal's thesis, in which he compared citicoline as an adjuvant to occlusion therapy versus a placebo drug that was given orally, adjuvant to occlusion. And it was found that the ultimate recovery was the same at the end of 6 months, but definitely the citicoline group had a faster recovery. So we must keep in mind about the various side effects before prescribing these therapies. Then comes the active vision therapy. It could be just simple near vision tasks that requires hand-eye coordination or video games. So the possible role is that it stimulates your visual processing and thus enhances the cortical plasticity. So it could be a monocular video game therapy. This is a thesis published from our center, Dr. Archita's thesis, where she found that monocular video games as an adjuvant to occlusion therapy shows significant visual recovery, much more than the occlusion therapy alone in children, and isometropic amblyopes less than 10 years. Dichoptics. Well, 2 eyes are better than 1, so that's the basis of dichoptic therapy. Here you are giving 2 independent stimuli to each eye. In the amblyopic eye, you present a better contrast image. In the better eye, a lower contrast image. You decrease the difference between the two as the binocular functions improve. So you can use any of these dichoptic games, the Tetris game with red and green glasses, Dig Rush game, and it has shown to improve visual acuity and even binocular function.
I could conclude. We are over time.
Just 2 more slides, 2-3 slides.
Yes.
So a study from a center, it showed that we got superior results with dichoptics in terms of contrast sensitivity and stereo acuity, but the PEDIC study did not concur with the same. However, in both the studies, what we noted was a poor compliance because of the repeated play. So there is need for more engaging games. So as of now, we can say that dichoptics are not better than patching, but it can be used as an adjuvant to patching. Other methods are using dichoptic movies or interactive binocular treatment system. VR display, yes, that's a new trending thing. You use VR display, the headsets and the softwares are there. So it's still evolving. It seems to be quite promising. Perceptual learning, well, it could, we had the experience of using Revital Vision where you give these GABA patches to the patient, but still an equivocal response was seen. So I think it still needs a little more development. And these are a few other options that have been tried like acupuncture, transcranial magnetic stimulation, but doubtful results. In adults, well, I would say that PEDIC has shown that occlusion and refraction both tend to improve the vision even in adults up till 17 years. And even beyond that, up till the early 50s, it has been seen that you can add the adjuvant therapies like pharmacotherapy, active vision therapy, or perceptual learning. So I think this is in brief about the recent advances in amblyopia. Thank you.
Thank you, Dr. Rebecca. That was an informative talk. We would move on to our next speaker, Dr. Charuta Bape. Dr. Charuta is a practicing pediatric ophthalmologist at Nashik. She's an alumnus of CMC Vellore. She's gold medalist from Tamil Nadu MGR University, and she's done her fellowship from Shankar Nethralaya. Over to you, Dr. Charuta.
Good afternoon, everyone. Am I audible?
Yes, you are.
Okay. Thank you, BOA and Dr. Himalini, for giving me this opportunity. I'll be talking about management of trauma in the pediatric age group. Trauma is an important cause of preventable unilateral blindness in children, and it can cause a lifetime disability. The common causes, as you can see here, are bow and arrow injuries, firecrackers, sharp pencils, shuttlecocks causing blunt injury, scissors, and hooks in the case of infants. The pediatric ocular trauma score is used to prognosticate penetrating traumas at the initial examination, and along with vision, they have the age of the patient, the wound location, and concomitant eye pathologies. Now, there are some problems in pediatric trauma which are different from that of adults, and that is a delayed presentation and lack of proper history many times, because it's some time before the parents realize what's happening. You're surrounded by anxious relatives. There is difficulty in pre and post-operative examination. No matter how good your surgery is, the visual outcome is always limited by amblyopia. There can be severe inflammatory response, and considering their long life expectancy, you have more disability adjusted life years to account for. In the primary management, you should take a proper history to rule out polytrauma, IOFB, etc. Try to assess the vision, but do not use force to examine. If the child is uncooperative, defer the examination till GA is given. In the meantime, in case of an open globe injury, you can patch the eye. Confirm the immunization status, and if the child is not immunized, then you can give TT. Start oral antibiotics, no topicals, explain the emergency of the situation to the parents, ask for a GA fitness, and keep the child NBM in the meanwhile. Give a full idea about the expenses. Make sure all this is properly documented. If a B scan is required, it's better to defer till after the primary repair, because a gentle B scan on the closed lids is generally not possible in children. And if an IOFB is suspected, then a CT orbit with 1 to 2 mm cuts, axial and coronal, can be asked for. During the counseling, the presence of parents and immediate relatives is essential. And like Malik Madam said, the child can actually be sent out. A video recording is a good idea. Explain about the risks of GA, guarded prognosis, possibility of multiple surgeries, need for glasses, amblyopia treatment, and a lifelong follow-up. An informed consent, both for the general anesthesia and the trauma repair, is very essential. Now, just going to some individual types of trauma. In lid and lacrimal trauma, a proper layer-by-layer alignment, preferably under the microscope, of the torn lid margins is essential. For marginal sutures, a mattress suture is essential with a little bit of pouting at the end to avoid notching of the lid margin. And in canalicular tears, particularly in small children, take your time to localize the torn end of the canaliculus and repair it by putting a stent like a mini Manoka. This is just the outcome of a child who had a lid tear. Now, regarding the principles of corneal tear and traumatic cataract, I'll just speak as the video plays. It's essential to put in the speculum gently under the microscope, clean the wound properly. It's a good idea to stain the capsule with a dye for proper visualization. Before suturing the wound, it's very essential to sweep and remove any iris tissue or cortical matter that is stuck into the wound. The suturing is done with a 10-0 nylon. The margins of the wound are not grasped. You should not hold them with the forceps. The globe should be well inflated before putting the suture so that they're not too tight or too loose. The suture should be through 90% depth and perpendicular to the wound. All the sutures should be equidistant. And it is very, very essential, particularly in children, to bury all the knots. You can take your time to do that, but each knot has to be buried. Then for the traumatic cataract, the torn capsule can be tackled with a combination of the cystitome and the side port rexus forceps. The direction of pull should always be towards the center of the globe to avoid running of the capsule. And if you're stuck, then the VR scissors can also come into play to release the capsule. And it is very important to do a thorough cleanup of all the cortical matter as much as the visualization permits in order to limit the post-op inflammation. If a PC rent is suspected, then a combination of vitrectomy along with the IA should be used so that we are sure that we are not pulling on the cortex. We're not pulling on the vitreous. This picture shows equidistant sutures perpendicular to the wound at 90% depth with buried knots. And the picture on the right shows a good outcome after a corneoscleral tear and traumatic cataract surgery and a secondary IOL. When we plan to do secondary IOLs in these children, we'll either put them in the sulcus or do an SF-IOL. It's important not to delay the secondary IOL too much because we want to minimize the amblyopia. So within once everything is settled in 2 months, we can go ahead. Slow tapering of the steroids is essential because children have a great inflammatory response. Topical NSAIDs are not that necessary in children because CME is not too much of an issue, but PCO is a big issue, and so posterior capsulotomy and anterior vitrectomy is required if the PC is intact. And also don't forget the proper IOL power calculation. The age-related undercorrection of 20% below 2 years and 10% above 2 years is essential. And also consider the refractive correction of the other eye because we do not want to create too much of anisometropia, particularly in good prognosis eyes. In scleral tears, it's important to assess the posterior extent fully. If the tear is going behind, we can use the railroad technique where we leave the sutures ends long and pull them in order to go behind. And if the tear is going under a muscle, then we may need to disinsert and reinsert the ocular muscle while suturing. If it is a scleral perforation, we have to suspect an IOFB, and we may need the help of our vitreoretinal colleagues to remove the intravitreal foreign body. Just a few pointers about vitreous and retinal trauma in children. The placement of sclerotomy in children is closer to the limbus, 2 to 2.5 mm, and should be done after visualizing the pars plana. It's preferable to suture the sclerotomy. PVD induction is more difficult, and if you're suspecting a traumatic endophthalmitis, it's better to give an intravitreal antibiotic while the child is under GA. Also suspect traumatic glaucoma. Yeah. And you can check the pressure by tonopen or Perkins tonometer under GA. Orbital trauma can also occur, and for example, this child here had a blowout fracture, and it was recognized and treated initially with steroids and surgery with mesh within 2 weeks, and that restored her ocular motility and her head tilt to normal. And last but not the least, don't forget the post-hoc visual rehabilitation. Your work doesn't end with treating the trauma. Insist and persist on glasses and occlusion therapy. Thank you. Stay safe.
Thank you so much, Dr. Charuta. That was a beautiful presentation and extremely well depicted. I would now like to call upon Dr. Aarti Kabra, and she's going to talk to us about COVID and myopia. Dr. Aarti is the director at Jhambar Eye Hospital in Pune, and she is a fellow of Shankar Nethralaya, and she has done extensive work in community ophthalmology, strabismology. Dr. Aarti, you can start. We can now see your screen, but we cannot hear you.
Good afternoon, everybody. Can you hear me?
Yes, now we can.
Yes. Thank you, BOA and Hemalani, for giving me this opportunity. Today, I'm going to talk on, after an extensive scientific discussion on various topics, today I'm going to talk on something different, a new terminology that we all have been introduced to, that is the quarantine myopia. Myopia, as we all know, is a major health issue around the world. WHO estimates that around 50% of the population will become myopic by 2050, and various factors that go in favor of this are insufficient time spent outdoors, duration of the work that we are doing indoors, and the intensity of the work. Now, COVID-19, which we all are dealing with here right now, has definitely played an impact on all of this. About 80% of students from more than 130 different countries have been affected by this quarantine myopia. And what are the main causes? The traditional classroom learning has now been replaced by a lot of digital work and e-learning. And thereby, the link between COVID-19 and the current pandemic and myopia is quite obvious. Most of the school children are sitting at home because of school closures. There has been a shift to online learning and more screen time. In view of the social distancing, kids are sitting together indoors and doing more screen use. There is fear of community spread due to outdoor activities, and hence there is significant decrease in all of this. But most important of all this, which I feel I have experienced in my practice, is the delayed diagnosis. Now, what do I mean by this? Previously, when a child was not able to see a blackboard, the parents would immediately bring them saying that the child is not able to see for distance. But now, because of the extensive indoor use of gadgets, the child hardly sees anything outdoors and a far distance thing. That leads to delay in the diagnosis of myopia. Secondly, inability to reach the hospital for eye care is another factor which is causing the delay in the diagnosis. Most parents are doing work from home now, and hence they are also spending inordinate time in front of the screen, which has definitely affected the role model image of the child. Because of their work from home, parents tend to use different devices as a calming medium for the children, which has to be avoided. From 2015 to 2019, the prevalence of substantial myopic shift has been estimated in an article in JAMA, which says that there's almost a 400% increase in myopia in 6 to 8 years of age group of children. And 9 to 14 years does not show much change in this study, but I'm sure most of you would agree that even this age group is significantly affected, as we all see in our practice. The main issue being excessive gadget use and reduced outdoor activities. Now, excessive gadget use, as we all know, and as Ashwin has already discussed, causes digital eye strain, dry eye disease because of reduced blinking, and definitely myopia progression because of sustained near work and closer working distance that leads to progression. Most children are at risk to this, but some high-risk children are those with a history of myopia in one or both of the parents and a lesser hyperopic error that is found in cycloplegic refraction. Also, children studying in schools with some excessive academic pressure tend to be at more risk. So again, repeating, how will the child present? The digital strain may present like an accommodative spasm because of excessive gadgets being excessively used without adequate breaks. Also, there will be dry eye disease because of which there will be irritation and burning redness of the eyes. And of course, myopic progression because of sustained near work. So sudden unexpected jump in myopia should arouse an suspicion for myopic progression. Accommodative spasm can be seen as a sudden jump and progression in myopia, and hence it is important to rule out by doing a proper cycloplegic refraction in all children and also comprehensive assessment of binocular vision. Besides cycloplegic refraction, it is also important to document the eggshell length by ocular biometry in each and every child whom we are suspecting to have a myopic shift. The children whose eggshell lengths are greater than 26 millimeters need to be followed up at regular intervals because they tend to have more risk of visual impairments. So what is the solution? So as we all know, difficult problems usually have very simple solutions. First, there is a definite role of the education system in this control of myopia. The education system needs to have encouraging children to participate in outdoor activities, or rather I would say non-screen based indoor activities, thereby encouraging positive screen time. Most important, I feel, is the solution at home. More than a healthcare professional or an eye doctor, I think the home plays more role in all of this. The home should have a definite digitally free zones inside the house. There should be digital fasting time and rules applied. Kids should be encouraged to do some outdoor work as well as digital hygiene, including appropriate posture, adequate lighting, and proper distance from the screen should be taught. The rule of 20-20-20, as Ashwin has mentioned, and I'm going to talk about it a little bit more again, has to be taught. Encouraging students to take breaks, a healthy or a positive screen time, participating in indoor physical activities, and co-activities along with other household members such as cooking, baking, cleaning has to be encouraged. Now, how much should be the screen time? Again, there are lot many studies going on, lot many articles have been published. There is variation about the thought of this, but commonly I would say that the children less than 2 years should not be exposed to any kind of screen except occasional video calls from the relatives. Children between 2 to 5 years should not exceed 1 hour, or it should be even lesser than that. But the cream population comes for older children and adolescent. Here, it is very difficult to define the screen time because of the demanding life that the kids are educationally facing. So it is important to teach them how to balance the screen time with other activities, like at least an hour of physical activity, adequate duration of sleep, and time for schoolwork, meals, hobbies, and family time. There is definite role of authorities, which I feel as an eye care professional, we can suggest to the government to take care of a proper home-based learning curriculum and encourage learning and not just online education. Taking breaks from outdoors. Yeah, just a bit. There's role of doctors, as we all know, regular eye examinations and myopia treatment. Apart from this, it is important if some child is on a pharmacological treatment like atropine, there should not be a lapse in the treatment. 2020 rule, I'll just quickly say that it is basically 20 minutes spent using a screen. You should try to look away at something that is 20 feet. And why? For a duration of 20 seconds. So finally, my take-home message would be that the counseling should not be just for the children, but for parents also. We as doctors should insist on digital hygiene because this is the new way of life. And now this seems inevitable and the new normal. So rather than telling them to reduce the screen time, it would be appropriate to teach them how to use screen properly. Simple patient education in the form of good lighting, good posture, and emphasis of Rule 20-20-20 would go a long way. We should explain the role of a positive screen time to children rather than just taking away the entire screen time. And there should be emphasis on periodic and regular refraction. We should start pharmacological treatments apart from appropriate spectacles in suitable patients. Thank you.
Thank you so much, Dr. Aarti. That was a wonderful discussion. And I would actually like to continue with the question, with the topic that we've ended. I wanted to know your experience in the requirement of low-dose atropine, and have you observed any trend in what patients required for controlling the progression of myopia, and whether the low-dose atropine patients had lower progression that you noted during the pandemic?
Sorry, I didn't hear the last sentence.
So if you had children who were coming in on low-dose atropine, did you notice that their progression in the pandemic was lower versus the children who were not on low-dose atropine? Like newly diagnosed, or you felt that earlier they were not progressing, but they progressed more during the pandemic?
Yes, I feel definitely low-dose atropine has definitely played a role, and there is significant less progression in these children. So I would rather emphasize on starting low-dose atropine to all suitable children, whoever fit in that criteria.
So have you altered any of your protocols for starting with low-dose atropine now? After seeing your...
to be honest, because of because of lack of ability of patients to reach the hospital periodically or regularly, more or less we are starting it in all general patients who are in the suitable age group and who do not have any direct contraindications. We are starting it for all the patients now.
Wow.
Assuming that they will not be able to have a very, very periodic follow-up, just to be on the safer side.
So everyone who is myopic, you all are starting on low-dose atropine?
Yes, it's not flat rule, but definitely we do take in consideration the other factors also.
Got it.
Like overall, the compliance of the patient, how periodically they'll be following up, is there family history of myopia? Like if they are high-risk people, definitely we will start them.
Perfect. Yes. So we did have a small study that was done at our center here with and what they noticed was also that the children who were on low-dose atropine were quite protected during the pandemic, versus the children who were not.
Yes.
Yeah.
One problem that I faced when prescribing low dose atropine, my patient was unable to get it because probably in Aurangabad many people are not using it. So when I wrote it out, the patient couldn't get it at any medical shop. So then
There are many companies, madam. Now there are many companies.
I know, but I think the chemists were not stocking it because possibly there was no requirement coming for it from the ophthalmologist. So that could be the reason. I felt
And there
that
was a problem with the myopin brand also. So they have stopped producing myopin now, basically.
I have also seen
so
one
that was the
chemistry.
problem. And they have now changed the name to Myoped. So mainly patients who have been prescribed myopin, they really faced this problem a lot.
I've also seen sometimes chemists have given substitute of some other brands, atropine 1%, and then parents come back saying that the pupils are dilated and child cannot see anything. So I now insist and write in each and every prescription the percentage, and I counsel the parents to read up the medicine before they buy, that it should be 0.01%.
That is important point. You have to underline it actually. This is the percentage. It happens.
I think we have overshot our time because I think our session was till 3:30, but Ragini.
I have one more question, Dr. Shruti, because the next session, I've kept a buffer time. So next session is starting at 3:45. So one last question.
But before you take that last question, just I'm so sorry I forgot in the beginning of my talk to thank you, Hema, and to thank BOA and MOS for giving me this opportunity to talk today.
Dr. Rushabh, you have any question? One last question.
Yes, to Dr. Rebecca, I saw she mentioned about dioptic therapy.
Yes.
Do you routinely use it, and what are the patients in whom you advise them?
So basically,
within adults as well?
actually, so basically we did a thesis where we used a Tetris game. So where there are several games which are available, but not all of them are free of cost. So that's a limitation. So this Tetris game was available free of cost, and we had to provide anaglyph glasses to the patient. So you need to provide red and green glasses, or if the patient is affording, can buy it. It may be available online. So that's how, that's we prescribe it. We do not prescribe it as a primary therapy. Rather, it is given as an adjuvant to occlusion, especially the cases which are responding slowly, are poorly responding, and have a little older age group, where this therapy is starting later on, maybe after 10 years of age or so. So there we see, and also the affordability, because at our center we deal with a lower socioeconomic background as well. A lot of people come from there, but smartphone is something which is now available with everyone. So that has eased things for us. So Tetris game is what we have used, sir, and we have found that yes, it definitely improves or helps as an adjunctive therapy. But again, compliance becomes an issue because the children, they get bored playing same type of game. It's a falling block game, so there is need for more engaging and different sorts of game.
So the same problem that I faced with one of my patients who was on this game, which I had advised them. The parents said that he's bored of it. It is so simple, and children nowadays can do more complex games, really. So maybe we need to sit down and devise some games for amblyopia for them.
Yes, ma'am. In fact, there are a lot of game, dig rush game also they tried, and some bugging squash, but there are very contradictory results. So probably we still need to devise and go ahead with evolve this technology further.
And again, then the question of affording these games which are to buy.
Priced ones, yes.
It's not free to download.
True.
Do you still prescribe Citimet or Citicoline for amblyopia?
Ma'am, Citicoline we had tried for the thesis. We found that, it was versus a placebo oral drug that was given as an adjunct to occlusion therapy. And 500 mg BD was a dosage because the patient were all more than 10 years, so 10 to 18 years. So we found it just, hastens the recovery, but the final visual outcome at the end of 6 months was the same. So it doesn't really make sense, exposing the children to those extrapyramidal side effects. So we have stopped using it.
Yeah. Good comment on this. Ashwin, Would you like to comment on the use of?
Yeah, I think mostly patients who who have a failure of amblyopia therapy are mostly because either you have started too late or the compliance was an issue. So I think more than dichoptic, just using regular games with occlusion, and you can give any game, increases the compliance of the occlusion, which is really the gold standard. And I just want to know, for those who have really failed occlusion and you've got an older child and they have still got unequal vision, do you then move to dichoptic? Is that really better in those situations to gain a little more? In my experience, I'll just say I think I have found my patients gaining that little more with dichoptic once they have done maximum occlusion with maximum compliance.
Exactly.
Which age group, Ashwin?
Yeah, beyond 8.
Okay, because
Yeah.
My theory for amblyopia treatment is we try it at any age. The patient comes to you at 17 also, give it a shot. There's no
I'm just saying once you have given up on occlusion and still you've got unequal vision, for those situations, that's my
Which
indication for
software do
dichoptic.
you use, Dr. Ashwin?
No, so we have a center that has the Binox software, and I send it there. They do some in-house, one or two few sessions in-house, and then they transfer it onto an online sort of mode.
Sorry to interrupt, but I think we should wind up now. Does somebody want to give a word of thanks?
I think Pooja can do it, or Risha.
Sunana ma'am, you do it.
Okay. Well, thank you, everybody. As I said before, thanks to DO and MOS for giving all of us, all of the speakers, and especially I see a lot of new faces in strepsirrhology. I'm very happy to meet all of you because we want strepsirrhology to develop further and further. Whether we are there or not, but it should remain. So thanks. Yes, Rebecca, you wanted to say something?
No, that.
She put up her finger.
Ma'am, I was just saying thumbs up. Thumbs up to you.
Okay, so thanks everybody. Thanks particularly to Emma.
Thank you. Thank you for the opportunity. Thank you.
Thank you, madam. Thank you, all of you, for participating.
Thank you all.
Those of you who wish to continue for the next session can remain logged on.
Thank you, Dr. Hema, for this beautiful session. Good afternoon, Lane sir. Thank you, Malik madam, and thank you, everybody. Dr. Lane sir, sorry I interrupted you. Please say something.
No. Only one thing I was to say, that Dr. Malik madam is my teacher. She was my lecturer. So she taught me all these things. If I know something, she is to be given credit. If I don't know anything, she is to be blamed, not me.
That's nice. That's nice. Thanks,
Okay,
everybody.
thank you for the speakers and all the moderators, co-moderators, and chairman and co-chairman.
Thanks, all of you.
Emma, you can go for the next session.
Yes, sir.
Thank you.
Thank you.
We have the next session's speakers here logged on. Dr. Riddhi, are you here?
Yes, madam.
Ashini?
Ashni is also there.
Cool. So Shreya is also there.
Yeah. Thank you.
So we can start then. Riddhi, we can start.
Yeah. Good afternoon, everyone. I welcome you to this session. This is the 5th session for pediatric ophthalmology and squint today. And should we start with the speakers directly?
Yeah, you can start with the speakers.
So our first presentation is by Dr. Monica Samant, X-Files in Pediatric Ophthalmology. Now, just to introduce Dr. Monica, she's an eminent pediatric ophthalmologist, having completed her fellowship from LV Prasad Eye Institute and also a research fellowship from University of Pennsylvania. Presently, she is a consultant and associated with Lakshmi Eye Institute.
Sorry to interrupt. I'd also like to introduce Dr. Shreya Shah, who is head of Drishti Netralaya in Dahod. Thank you, Shreya madam, for agreeing to chair this session. And we have Dr. Abha Kanade, who is an eminent ophthalmologist in Pune. Thank you, Abha madam.
Thank you so
Thank you,
much.
ma'am. Thank you for giving the opportunity.
I would also like to welcome Dr. Reshma. Reshma, are you here?
Yes.
Okay. Thank you for participating, Reshma.
Oh,
Monica, you can start.
yeah, my video is not starting. I don't know why.
Okay. Do you want us to go on to the next speaker then?
You could actually. I don't know why it's not starting. Just a minute. I'll just.
Sai can help with this.
Yeah.
Oh, that is that her problem is at her end, ma'am.
It's the video only is not starting. I've unmuted myself.
Okay.
We'll start with the next one, I think.
So our next speaker is Dr. Pooja Sasurkar, and she is also an eminent ophthalmologist from Kolhapur with 14 plus years of experience. And she's going to talk on sensory evaluation of strabismus.
Yeah. Just a minute, ma'am. I'm just sharing my presentation.
Good afternoon, everyone.
Are you ready?
Just 2 minutes, ma'am.
Share the opening.
Mitali, are you ready with your presentation?
I think she is also asking.
Yeah, just a minute.
All the husbands are coming to help.
Can I give my presentation on ROB files?
I'm ready.
Okay.
Who is ready?
Can you see the screen?
No.
Who is ready?
Go ahead with Dr. Reshma.
Yeah, the last one. Yeah, I'm the last speaker actually in this session. So can I continue with mine, the ROB files?
Yes, ma'am, you can.
Yeah.
The screen is shared by Dr. Mitali.
Can you hear me? Hello? May I audible?
Yes,
You are.
Go ahead.
Dr. Mitali, you are audible.
Oh, yeah. I'll start. Is it okay?
Yes.
Okay.
Okay, good afternoon, everyone. I will be presenting today the motor evaluation in strabismus. We will cover the motor examination under the two heads, ocular motility evaluation and muscle imbalance evaluation. Now coming to ocular motility evaluation, what is meant by the ocular motility? What are the position of gazes? How do we test ocular motility? What abnormalities we see? How do we document these abnormalities? Now, ductions are the uniocular movements and versions are the both eyes are moving together in the same direction. Whereas the versions are the both eyes are moving in opposite direction. Now coming to the position of gazes, there are two ways we can document the position of gazes. This is the midline central up and down. This is dextro up and down. This is the levo up and down. The other way of documentation is the primary position, secondary positions, and the tertiary gazes. Now, how do we test the ocular motility? We can test it voluntarily by using the fixation target with the help of the thumb and also by the doll's head maneuver. What abnormalities we see during the checking the ocular motility? Underactions can be checked on the horizontal muscles and the vertical muscles, and it can be checked both in the ductions and the versions. If there is absolutely no movement, we can grade it as a -5 underaction. If the globe reaches up to the midline, we can grade it as a -4. Just crosses the midline, it is a -3. If it's between the midline and the canthus, it is a -2. And when we can see just a little sclera, we can grade it as a -1 underaction. Now coming to overactions can be seen only in the vertical muscles and tested in versions, and it can be graded from +1 to +4. What other abnormalities we see during the ocular motility examinations are them? In the aberrant regeneration of the third nerve, we can see the retraction of the lid, whereas in the DRS, we can see the narrowing of the palpebral fissure and the widening of the palpebral fissure height. Now, how do we document this abnormality? We can document this abnormality using this line diagram. And we can grade it over action as a +1 to +4 and under action as a -1 to -4. Now we'll see how we are going to evaluate the muscle balance. What is normal and abnormal muscle balance? What are grades of muscle imbalance? How can you detect muscle imbalance? How do we document it? And how can you measure the degree of muscle imbalance? Now, what is normal muscle balance? Visual axis of both eyes meet at the object. Image of the object falls on the fovea. And what happens in the abnormal muscle balance? Visual axis of one eye becomes misaligned and image of the object does not fall on the fovea. Now coming to what are the grades of muscle imbalance? It is the latent deviation, intermittent deviation, and the manifest deviation. We can use the opaque occluder as well as the translucent occluder. Now coming to cover test. In cover test, we cover the one eye and then we'll see the movement in the other eye. If we can see there is a movement in the other eye, we can call this as a constant deviation or the manifest deviation. Now coming to uncover eye. In uncover test, we'll see the movement of the eye below the cover. Now in this video, we can see that the left eye is covered with the help of opaque occluder. And when we have removed the occluder, the eye moves from out to in, showing it's the exophoria. Alternate cover test is a combination of the cover and the uncover test. By doing the alternate cover test, we can diagnose the latent phoria, intermediate deviations, and the manifest squint. Now in this video, we can see just after covering, the eye moves from in to out, showing the esophoria. And here again, once we have removed the occluder, we can see that eye is moving from out to in, showing the exophoria. Now, what is the intermittent deviation? In intermittent deviation, sometimes the present shows the manifest deviation and sometimes it's exactly central. Intermittent deviations can be graded as a good control, fair control, and the poor control. In good control, we can see that the patient looks straight, and once we occlude the eye, patient's eyes start deviating. Now we are doing the cover uncover test, and once we'll take out the cover, just a minute, the video, yes, we can see the eye is moving from out to in. It's showing that's the good control. Without blinking, the eye has come from out to in. Now what do you mean by the fair control? In fair control, the patient is looking straight. Now we have, examiner has covered the one eye and see the patient has deviated. There is a squinting, but still it's not coming. Now the patient has blinked and the eye is central. Then we can call this as a fair control. In poor control, the patient is already deviating without the occlusion. Now, constant squint we can classify into unilateral and the alternate. Unilateral means only one eye is continuously deviating, and alternating in which sometimes the right eye deviates, sometimes the left eye deviates. How can you measure the degree of muscle imbalance? We can measure the degree of muscle imbalance with the help of prism bar and the loose prisms. We can use the different tests to measure the degree of muscle imbalance, such as the Hirschberg test, Krimsky test. In Krimsky test, we will hold the prism apex toward the deviation in front of the deviated eye. Whereas in modified Krimsky test, we'll hold the prism in front of the normal eye. Now coming to the prism cover test. Prism cover test can be applied if the vision in the deviating eye is good or more than the 624 and the extraocular motility is good, then we can do the prism cover test. In prism cover test, always the apex of the prism goes towards the deviation. Means if it is exotropia, apex will go to the out, and if it is the esotropia, the apex will go in. Now we will do the we will hold the prism in front of the eye and we will do the cover uncover test to measure the angle. We'll move increasing the prisms and until the neutralizing movement of the eye will achieve. If we want to add another horizontal prism, we cannot add in front of the same eye. We have to keep that prism in front of the another eye. If horizontal deviation is associated with the vertical deviation, then we can add the horizontal and the vertical oriented prism together. How do we document it? Exophoria can be documented as X, esophoria as a E. Intermittent exotropia and esotropia can be like X, E and in bracket T. Constant esotropia as a ET and the constant exotropia as a XT. Now, how we are going to document this abnormal muscle balance? We can document it by using this line diagram showing the 9-gauge photograph. This we can read as a 20 prism of intermittent exotropia in the primary gaze. whereas this is a 40 prism of intermittent exotropia in the upgaze. This is a 20 prism of intermittent exotropia in the dextrogaze, and this is the same as the levo version and the downgaze. Thank you.
So next speaker is ready. By the time Dr.
Monica ready?
So by the time next speaker gets ready, I'll just add to Dr. Monica. When we have a very larger degree of strabismus and we are not able to put cruise prism in front of one eye, we can collect two prism, apex to apex, but in that case, then the addition of both prism should not be counted. We have to apply Prentice rules. C square is equal to square root of A square plus B square. So that works. It's not exactly addition. And when we do modified Krimsky test, for especially for esotropia, when you are putting prism on good eye, then again you can ask them to look at torch and again do PBCT. So
Just
that
one line.
a good thing. Okay, anybody's ready? Dr.
Yes.
Abhay, want to say something?
Yeah. Just I wanted to say the squint examination of the squint patient starts the way the patient enters in your room. So just note down if the patient has any abnormal head posture. Note it down. It may or may not be significant. Because what happens, our other examinations, they are in the primary position. So sometimes the patient may not adopt and he becomes conscious. So he may not adopt the abnormal head posture. In that case, you can ask him to read the Snellen's chart binocularly and he may adopt the abnormal head posture. So I just wanted to stress that point that as soon as the patient enters in your room, abnormal head posture.
Otherwise, shares the entire screen will be shared. Dr. Monica is ready now, I think.
Yeah. Just a minute.
Dr. Riti, shall we move to?
Is Dr. Monica ready?
Yeah, I am. I'm just sharing the screen.
Yes, okay.
Okay. Open कर तुझे हे minimize कर
Dr. Pooja, keep yourself ready after Dr. Monica.
Just a minute. I'm sharing the screen now. Okay. Can you all see now?
Yes.
Yes, we can.
Yeah, okay. So good afternoon, everyone. At the outset, I want to thank all the BOA faculty and especially Dr. Prachi for making me an active participant in this meet today. So my presentation is a little different. It's not strabismus, it's pediatric ophthalmology, different cases that we will run through. So case 1.
You can click on enable editing and then you'll be able to do slideshow, I think. Yes.
Let me see. Yeah. So the first visit is it's an 11-year-old male who came to a general OPD in July 2020, complaining of pain and redness in the right eye since 2 days. He was diagnosed elsewhere as acute anterior uveitis and was on treatment with steroids and cycloplegics. So when the examination was done, the positive findings were that he had ciliary congestion and the anterior chamber showed 3+ cells. Now the diagnosis remained the same at that stage. Only thing that they revised and gave him a little stronger topical steroid and increased the frequency of the steroid. Subsequent visits were again there in the OPD. After 1 week, the patient had responded to the treatment and so the steroids were tapered. Now the same patient had a second episode in September. He was again given the same treatment and again he was okay in another 3 weeks. The patient then comes to us in third episode in November. Now this point in time, he was referred to a pediatric OPD for the same complaint of pain and redness. So when he visited our OPD, we got a detailed history regarding any joint pain, swelling, if he had any fever, cough, or he had any trauma. So everything was negative. And what we found was he had ciliary congestion, posterior synechia, and cells were 4+. So if you can see in the picture, ciliary congestion and the posterior synechia. So now the question was, there are two questions that come. Acute anterior uveitis in children, how common is it? And when do you say it is dangerous? So pediatric uveitis is actually a rare disease, the incidence of which is around 4.3 per lakh. And 50 to 80% of the cases of uveitis are anterior uveitis, of which 70 to 90% cases are derived from non-infectious causes. So the common causes are JIA, that is juvenile idiopathic arthritis, of which 80% uveitis in JIA is anterior uveitis with chronic course. Usually these patients have white eye. Now, in JIA also, you have rare presentations which can come with redness, pain, decreased vision, which is usually seen in children who have arthritis, idiopathic arthritis, but have HLA-B27 positive in them. Second common cause is sarcoidosis. This is a multisystem inflammatory disease, and usually 30 to 60% have eyes involved with non-granulomatous anterior uveitis. So we investigated this child for routine investigations. We did a tuberculosis test, Montooks, which was negative. And to our surprise, even the CRP was normal. We sent the patient for pediatric opinion for immunology workup. And he had HLA-B27 positive, which pointed towards the arthritis. In fact, his ACE levels were 95.3. So was very high inflammatory markers, which is pointing towards sarcoidosis, because he did have a lymphadenopathy later, but did not have COX. So they had done an HRCT and had derived. So this is an extremely rare possibility of having arthritis with sarcoidosis in an 11-year-old. So what are they started him on systemic treatment by the pediatrician. We started him on local treatment and patient responded well. And now for the last 3 months now, he has no repeat episodes in the eye. So what are a few takeaway things from this case? Anterior uveitis in children is rare, but it's seen. A detailed history is important. If the attacks are frequent, that is like twice in a month, or not responding to treatment like it was with us the first time when he came, need systemic evaluation. Third pearl, patient may not have systemic signs, joint swelling, or may not have any arthritic signs. Only ocular signs may be present, even for an inflammatory clause like sarcoidosis too. Pearl 4, always keep these patients under your follow-up for seeing what are the recurrences in them, treating them, and especially for IOP because they can have secondary glaucomas. Now going on to case 2. So a child who is 2-year-old male came to the OPD in July 2016. He had come with high myopia, microspherophakia, and megalocornea diagnosed elsewhere, and was advised both eyes clear lens extraction. When we examined him, he has -23 on retinoscopy, and he had 3/48 vision. The patient was advised examination under GA. So what we saw was that the pupil was phakic in the pupillary area, though he had phacodonesis, but no subluxations. He was myopic, and the axial length was 24.98 millimeters in the right eye and 24.84 in the left eye. We investigated him. To our surprise, he had urine homocysteine positive, whereas his serum homocysteine was normal. He did not have any heart abnormalities. So we gave him glasses, which he was comfortable with and had a follow-up visit with the glass. After 3 months, when the child was 2.5 years old, what we saw in the EUA, again when we did that, was that this patient had phacodonesis with mild subluxation. Now this subluxation was infranasal and it was covered by the lid. The pupillary area was still phakic. We had a retinal evaluation done for him and we were discussing whether we should have a lens extraction pars plana approach or we wait because his pupillary area was still phakic. The patient was advised to continue glasses. We talked with the parents, told them the various possibilities of it, and would think after 6 months whether we really need to go for a surgery or not, depending on the pupil area and the lens status that time. After 6 months, when the child was 3 years old, he comes to us and he had already had a lens drop and he was in the left eye 6/24 with +8. Whereas his right eye was still -22 with counting fingers 1 meter. So now we again thought we would still wait, give patching for his left eye, for the right eye with the high myo, and see what happens next. The patient comes after 3 months, and now to our surprise, his right eye was following exactly the path of the left eye. The subluxation was same like the left eye, going in the same direction. So we decided we'll wait and watch. At the age of 4 years, this child is now both eyes aphakic, has +6 diopters of hyperopia, and was 618 N6. By 6 years, he's 69 N6 with +4, still aphakic, has myopia with lattice degeneration because he's more cooperative now for examinations. And this is how he looks now. So if you can see in the above picture, you can see the aura, you can see a few lattices, and you can see both those lenses which are really very nicely sitting in the vitreous with no symptoms at all. And the child is happy, the mother is happy, because from -20 to thick glasses, it's like now +4 very thin ones. So if the takeaway was, if a child is too young and if the pupillary area is phakic, one should wait and watch. But at the same time, a long-term follow-up is needed for life in such cases, because you need to diagnose early secondary complications. See, as lens is an immunoprivileged organ, the only time you would like to remove it would be if it's causing any inflammatory signs or it's causing any other signs like increased IOP or glaucoma, or his lattice degeneration worsens and he gets an RD. So you keep him at least till 18 years with us and then later in the adult OPD. Case number 3. So this was a 3-year-old female who presented with decreased vision in the left eye. The right eye was status post repair for penetrating trauma 1 month ago elsewhere. So this is actually a little sad. She had come to visit her parents for a holiday, and in that time she had right eye trauma, and they had got it operated. They were doing repeated follow-ups, but somehow she was not able to see. That is what her parents came to us telling after a month. Now the right side picture shows you the left eye picture, which is media hazy with an exudative RD. On examination, the right eye was no PL, but the left eye was close to face, thick membrane in the AC, and the posterior segment was hazy. The B scan showed choroidal thickening, and the left eye was a sympathetic ophthalmia, which had presented after a month. So treatment was started on systemic and local immunosuppressions, and very
Monica,
strong, like we had, yeah?
1 minute more.
Yeah, sure. So we had at 1 month and at 6 months. Gradually, we actually followed her for, after 6 months, she was lost to follow up from visit one. From visit 1, after 1 year, again, she had a recurrence. Then after 11 months, we retreated her. The new issue was cataract. We operated her under severe, heavy systemic steroids and immunosuppression. Now she was 612 N6, but gradually she has developed glaucoma. She's right now on topical steroids and topical anti-glaucomas, with the current vision being 624. So a few takeaways: always see the other eye. Sympathetic ophthalmia is not rare as it seems. Close follow-up with multidisciplinary approach is essential, because we were constantly in touch with the pediatric immunologist and repeated tests on her. And extensive and timely counseling of patients in regards to treatment, side effects, and nature of the disease is pertinent. Very important. Case 4, the last one I'm telling. So first visit, a 8-year-old child came to the pediatric OPD. Complaints of redness on temporal side of the left eye since 1 day. They attributed it to a small drop of oil in the eye, gone 8 days back. And he was already presenting with occurrence DH, which he was putting for 4 times. There was no history of pain, stickiness, discharge, fever, sore throat, trauma, nothing. So on examination, there was temporal congestion. We started him on antibiotic steroid combination and asked him to follow up. After 1 week, there was improvement in the temporal congestion. But if you observe this picture right now, in spite of that treatment, that patient had developed an infero-nasal congestion.
I'm sorry to interrupt, but you will have to summarize this case because you short your time.
So this is, so family had COVID history. Parents tested negative 1 month back. So basically, review of ophthalm, if you see, conjunctivitis is common. This patient was RT-PCR positive in spite of the family being positive a month back and then negative again. So patient was started on systemic treatment and he responded very well. His younger brother later came on to have the similar complaints. So he also was treated, again, RT-PCR positive and treated systemically and improved. So basically, COVID is not only just, you have to look at it whether it's infectious or immune mediated, and we'll go with systemic treatment and not just with local treatment. Thank you.
Thank you, Dr. Monica, for the lovely presentation. We'll move ahead.
Call upon Dr. Pooja Sasurkar to start her presentation on sensory evaluation of strabismus.
See the next one, that's important for you.
Dr. Pooja, are you ready?
Yes, she started her screen share.
Yes.
Perfect.
Good afternoon, everyone. Am I audible?
Yes, you are, ma'am.
Yeah, actually in Kolhapur, it's heavily raining, so my connection is getting off. So let's see how it works. Today's my topic is sensory evaluation of strabismus. Basically, I want to introduce into the four categories like normal binocular vision. As we all know, normal binocular vision is like binocular sensitivity and binocular vision are absent at birth. But horizontal binocular connections develop at the age of 3 to 6 months of the age. And even the stereopsis develops in 3 to 5 months of the postnatal age. So what is a binocular singular vision? It is a bifoveal fixation so that each eye contribute to a common single perception of the object of regard. So binocular singular vision has been graded into 4, that is a first
She lost connectivity again.
Yes.
I think you keep her to the end, towards the end. Otherwise, you guys will not have any time for questions, Ashini.
Okay, ma'am. Dr. Pooja, can you hear us? No, I think she cannot.
She can hear actually. Mr. Sai can help. You can stop sharing.
Mr. Sai, please stop her screen share. Pooja, please stop your screen share.
No, I think she's lost connectivity.
Somebody has phone. Yes.
So I
Now
guess
keep her in the end and
yes,
go with the next one.
So I call upon Dr. Shruti Mittal to talk about paralytic versus restrictive strabismus.
My connection is yeah.
So Dr. Shruti Mittal has done her pediatric ophthalmology fellowship from Shankar Netralaya, where she also worked as a consultant for over 5 years. She expertises in pediatric ophthalmology, squint neuro-ophthalmology, nystagmus surgeries, etc. I now call upon Dr. Shruti to do her presentation.
Very good evening to all of you. Am I audible and is my screen visible?
Yes, Shruti,
you're audible and the screen is also visible.
Okay. So I shall start. I'm Dr. Shruti. I'll be talking about paralytic versus restrictive strabismus. So when do you suspect a paralytic or a restrictive strabismus? We'll see with a few examples here. This was a 53-year-old lady who presented to us with sudden onset of squint and double vision and inability to move the right eye laterally. On a detailed evaluation, she was found to have right esopropia, which worsened in right gaze, and there was an associated limitation of abduction in the right eye. Similarly, this was a 60-year-old female who presented to us with the left eye appearing larger than the right eye and intermittent diplopia. And on detailed evaluation, she was found to have a lid retraction in the left eye, a right hypertropia, which worsened in upgaze, and a limitation of elevation in the left eye. So what both these cases have in common is an concomitant strabismus and limited duction in one of the eyes. So whenever there is a limited duction, it is either a paralytic etiology or a restrictive etiology or a combination of the two. So paralysis basically indicates a weak muscle action or a complete loss of muscle function. And the main etiologies can be classified as cranial nerve palsies, primary muscle disease, or mechanical disadvantage of muscle pull, like in a stretch scar. On the other hand, restrictive strabismus is due to two general mechanisms, either due to a mechanical teether on the eye movements or a misdirected muscle force that works against the normal agonist muscle. So these are some of the causes of restrictive strabismus. So both these etiologies would present either with a strabismus, abnormal head posture, motility limitation, or a double vision. So while examining these cases, a few things that we need to keep in mind are measure the squint in all gazes. Most of them would have concomitants. The deviation should be measured with either eye fixing, that is primary and secondary deviation, and the secondary deviation, if larger than the primary deviation, would indicate a paretic etiology. If there is a vertical deviation, do a Parkes 3-step test. And if there is a particular pattern, it indicates the presence of a vertical or a oblique muscle palsy. Look for an abnormal head posture. Most of these patients would have one to avoid diplopia. And if there is a facial asymmetry, it indicates the presence of a long-standing palsy, like in case of congenital superior oblique palsy. Look for associated signs. A presence of anisocoria could indicate the presence of third nerve palsy. Ptosis could again indicate a third nerve palsy or presence of myasthenia. Any signs of ocular or orbital trauma would indicate possible orbital fracture. Weakness would indicate there is a presence of myasthenia. So there are various tests to differentiate whether it's a paralysis or a restriction. We'll see some of these tests one by one. So saccades are the fast eye movements, and recti muscles are mainly response for the saccadic movements. So when we are testing for saccades, we are testing for rectus muscle function. So here in this video, we can see that in the left eye, the abduction saccade is definitely slower than the adduction saccade. So we look for the briskness of the saccades and always compare the agonist and the antagonist muscle, as well as compare it with the other eye. The advantage of this test is that it can be done easily without touching the patient, and it is a bedside test and therefore can be easily used in children. In paralysis, characteristically, there is a slowed saccadic velocity or a floating saccade, and in restriction, there is an abrupt stop, also known as dog on a leash phenomenon. Coming to forced duction test, here we look for restriction to passive duction. You anesthetize the eye with topical proparacaine drops and hold it at the limbus with the help of 2 tooth forceps and try to passively rotate the eye in different directions and look for any resistance to movement. Important thing to remember is that if we are looking for recti, the globe has to be proptosed. And if we are looking for the obliques, then we have to retropulse the globe. Please note that positive FDT does not rule out the presence of a coexisting palsy. So here is a video which shows the FDT for obliques. We can see how the globe is being retropulsed. And if we are looking for the superior oblique, supposedly, the eye is rotated superonasally and then rotated superotemporally while feeling for a bump or lump posteriorly, which would indicate a taut or a tight superior oblique muscle. Coming to the force generation test, here we measure the active muscle force after anesthetizing the eye with topical proparacaine. We feel for the muscle pull against the forceps. So always compare it with the antagonist again and with the other eye, and a weak pull or a tug indicates paresis. IOP changes are often seen in a restrictive etiology. IOP increases when the eye tends to forcibly move against the restriction. This is characteristically seen in cases of thyroid eye disease. Palpebral fissure changes in restriction are in the form of globe retraction and narrowing when the eye moves away from the restriction, whereas in paralysis, there is a relative proptosis and widening. Aberrant regeneration indicates a paralytic etiology. Like in this case, we can see there is lid retraction and downgaze, which would indicate a traumatic third nerve palsy. Hess chart in paralysis and restriction would show characteristic changes. A smaller field is usually of the affected eye, and the greatest inward displacement indicates the primarily underacting muscle. Here we can see a right lateral rectus palsy. And in this case, we can see that the left eye field is compressed both superiorly and inferiorly. Such compressed fields usually indicate a mechanical or a restrictive cause. In this case, it was a left orbital floor fracture with inferior rectus entrapment. So here we can summarize the various findings in different tests in restrictive and paralytic strabismus. Important thing to remember is that they are not mutually exclusive, and both the etiologies can coexist in the same patient. Principles of management I would like to highlight is we usually wait and watch in these cases and not immediately jump to surgery. Treat the systemic associations, and if surgery is planned, it is mainly for an abnormal head posture or to correct the diplopia. The patient should have realistic expectation and has to be counseled well and should be motivated enough. So why do we need
1 minute more?
Yeah, this is my last slide. So why do we need to differentiate? In the words of Dr. Kenneth Wright, management begins with the understanding of cause. So if we are looking at restriction, we release the restriction during surgery. And if it's a paralysis, we strengthen the muscle by a recess resect procedure or by transposition. I would like to thank Dr. Himalini Samant for giving me this opportunity and the BOA organizing committee. And thank you all for a patient hearing.
Thank you, Dr. Shruti, for the lovely presentation.
I now call upon Dr. Aloka Hedao to speak on infantile esotropia. Just to introduce Dr. Aloka, she is an eminent pediatric ophthalmologist who also specializes with special eye needs for special children, along with pediatric ophthalmology and adult strabismus.
Thank you for this opportunity, BOA and MOS and Dr. Prachi. A small prayer for all struggling all over our country with COVID and now with cyclones. So hope that a lot of us who have lost loved ones get some peace here. I think the slide is running. So first of all, this is for postgraduates where you need to know what is pseudoesotropia. So epicanthal folds, short interpupillary distance, and negative angle kappa. And the way you can differentiate it is by just lifting off the skin fold, and you can differentiate between a true and a pseudoesotropia. The characteristics of essential infantile esotropia, they present by 6 months of age. There is usually no neurological deficit, and most of these children do not have hereditary parameters or genetic markers which are passing on through the family. What is the area of origin? Area of origin, is it nuclear? Because these are children who have esotronus but good abduction, so less likely to be nuclear. Is it cortical? If it is cortical, then it has to have some motor involvement. So usually the area of origin in these patients is subcortical but pre-nuclear in origin. Now, what do we mean? Now, this is how when the eye object falls on the nasal hemiretina, we have crossing over which happens here at the chiasma, and it goes into the cortical area. But there is also another pathway which goes through the subcortical nuclei, including the cerebellar nucleus and the vestibular nucleus, and then it goes to the parapontine reticular formation and oculomotor nuclei and to the extraocular muscles. And this causes esotonus to happen. Now, in normal babies, we see that by 3rd month of age, this subcortical pathway is not there. This pathway is there only in some primates who have laterally placed eyes. But this pathway continues in infantile esotropia, and that is known for the cause for esotonus as well as optokinetic asymmetry. Now let us see what happens. This is the routine optokinetic drum that we use. So as the patient starts the pursuit movements, we see that there are these corrective saccades which happen, and these are typical of optokinetic. This is typically a sign of health called optokinetic nystagmus. Now, in infantile esotropia, even if you correct the patient, nasally directed saccades will continue, but temporally directed optokinetic motion will not elicit any optokinetic nystagmus, and this is typical asymmetry in infantile esotropia. Now, as Dr. mentioned earlier, we have a Wieth-Muller circle, and if any of the objects they are following in this circle, there is motor fusion, and there is sensory fusion, which is higher level of fusion, that is binocularity and stereo acuity. But in infantile esotropia, this does not happen because there is no corresponding points, and therefore there is suppression and amblyopia. Their associations usually are DVD, latent nystagmus, angle should be large angle, low level of hypermetropia, amblyopia, cross fixation, and many cases have primary inferior oblique overaction also. Now, this is a typical case of latent nystagmus, as well all the other features of uncorrected infantile esotropia seen in an elder child, where you see DVD, you see primary inferior oblique overaction, and gross amblyopia too. Visual processing, we receive information through our senses, we organize this information, and we use it to interact with the environment. So not only viewing, but decluttering of toys, selecting your shirt, or selecting socks from a drawer, reading a book, writing from a presentation, all this requires skills of visual processing, and these are essentially affected in children with infantile esotropias. What are the threats? The threat is amblyopia, poor stereo acuity, poor binocular vision processing, and surgical undercorrections and overcorrections. how will you categorize now when you want to understand, success rate, duration of surgery, so when you should be operating, is the patient emblyopic, is there manifest nystagmus, is there DVD, and what are the chances of motor fusion. So the routine the care should be, first you have to correct amblyopia, surgical management, and plus or minus Botox. So surgery for infantile esotropia, what are your outcome parameters? What is the post-operative angle of strabismus, immediate as well as long-term stability? Are you going to regain binocularity, and how many operations are you going to require to get this goal? Now, we have seen that stable long-term alignment in patients with infantile esotropia depends on these factors. If you have better stereoacuity post-op, if you have less nasal OKN bias, and you have less MVP asymmetry. That is what I was explaining earlier. So earlier surgery done, the nasal versus temporal asymmetry bias that we see on optokinetic nystagmus is lesser. Now, timing of the surgery for infantile esotropia is one of the biggest debates in our societies here, and there are lots of studies done. One of the major studies done by Dr. Wong and group found out that large constant esotropia, if operated early, less than 10 months of age, gives very good outcomes. So they were proponents of early surgery. Now, why early surgery has been a debate? Because some people still feel that early esotropias can be self-resolving. Now, in this big study, which was done by the PEDIC group, they found that those who had intermittent esotropia, which were variable angle and very small angle, less than 40 or less than 30 prism diopters, are the only ones which are more likely to resolve. But all patients who have squinting which persists beyond 3 months of age, constant squinting, larger squinting, these are less likely to resolve and they should be operated. So all these studies, they found that early surgery, the asymmetry of OKN was also better. This is the important slide where clinical profile of infants will benefit the best from early surgery. And here you see that the patient persistent esotropia from 10 weeks to 6 months, constant esotropia of more than 40 prism diopters on 2 separate examinations, small hypermetropia, and absence of all these features. These are the ones who will benefit most from early surgery. Now, Helveston and group found out that 3 to 6 months of surgical time would be very good. They have very good surgical alignment, and these are the patients who did very well. They gained very good stereoacuity. There was Ellis group, which is the European group where they studied early versus late infantile study. And as we all know, European societies, many a times they opt for later surgeries. And here they compared early surgery at around 20 months and late surgery around 40 months. That's almost around 5 months of age, where they found that early surgery did gain good binocularity, stereoacuity, and they had good psychomotor development. But in later surgery, the angle of deviation measurement was much more precise, and therefore they could have less undercorrections and overcorrections, and also DVDs or the secondary motility disorders could also be elicited much better and handled much better. There is another study which says that till you do the surgery, at least start doing alternate eye occlusion because this prevents or this decreases motion processing abnormalities which are seen in infantile esotropia. Now, which surgery do you select from? Bilateral recession, unilateral recess resect, 3 muscle, pattern surgery, or do you try Botox before or as an adjuvant? Now, this study, they had a large profile of 576 patients, and they divided the surgeries, of course, according to the angle of deviation. And they found that there was really not much of a difference between various surgeries that they did. Only here they found that there was less asymmetry in the movements when they went ahead with multiple muscle surgery rather than an enhanced bimedial recession. And small angle single muscle recessions also did better. This study was very interesting, where they studied the outcome in preterms versus term babies. And they found that preterm babies had much more overcorrection with the same formula as compared to a term baby. And they found that like per millimeter muscle, 4.4 prism diopters was gained in preterm baby compared to 3.99. So they suggested that
you
when
have
you
a
operate
minute
on
to
preterm
go.
babies, when you operate on preterm babies, you can undercorrect or can change your formulas and recess lesser for better outcomes. So my take to office message here is, because there's no home anymore, we're all locked in our houses, and take to office messages: operate early. That early should be up to 18 months of age. At least get 2 measurements properly, treat refractive errors and amblyopia as even before, during, and after your surgery also, and tackle pattern deviations too, because this will prevent undercorrections. Thank you so much.
Thank you, Dr. Aloka, for the presentation.
Our next speaker is Dr. Shruti Nishant. She will be talking on impact of refractive error on strabismus. To introduce Dr. Shruti, she is a known ophthalmologist specializing with pediatric ophthalmology, strabismus, and genetics. Having passed her post-graduation from Arvind Eye Hospital, she presently is working with Kilpunk Medical College in Chennai and also a part of Global Eye Genetics Consortium.
Can you hear me and can you see my slides?
Yes, we can.
Yes, we can.
Okay. Yeah. Good evening, everyone. Thank you. There's a small error actually. I currently work in MNI hospitals. Kilpok is where I did my undergraduate from. Thank you so much for having me here today. So we're going to be talking about the role of refractive errors in strabismus. I thank Dr. Aloka for setting the stage up perfectly by clarifying what infantile esotropia is, so that we are done with that. Now, so let's begin. So we know that strabismus is basically when we're talking about strabismus and refractive error, we're talking majorly about hyperopia and myopia. Of course, we're going to be talking about anisometropia also. So hyperopia is more commonly related to, or is a risk factor for esotropia, whereas myopia is for exotropia. So having said that, let's go to hyperopia. So we do know that 90 to 95% of babies who are born are hyperopic by nature, and then most of them, almost a majority of them, have adequate accommodative efforts through their age, appropriate accommodative efforts, and end up with emetropia, and some even progress to myopia. But there is a small subset of kids who either have high plus or they have hypoaccommodation or hyperaccommodation, which in turn leaves them with a squint. And if they do have hypoaccommodation, they end up with having a constant esotropia and amblyopia. And if they do end up having hyperaccommodation, they end up having accommodative esotropia. So that's how it progresses. Now, this is a 4-year-old girl with left eye squinting. It's been there and now it's getting worse. And she had a +4 power, and with the cycloplegic refraction, she had her glasses on and the squint resolved. So this is a case of pure refractive accommodative esotropia. Now, why does refractive accommodative esotropia happen? That's because hyperopia as a nature in itself causes increased accommodative effort, and that increased accommodative effort leads to increased convergence, which in turn leads to esotropia. So this is how the hyperopic esotropia happens. It's usually seen between 1.5 to 4 years of age. It's usually about 1 to 2% of the general population, and you can see there is a relevant family history that you can pick out sometimes. They do have a subnormal Randor test, and the association of hyperopic and anisometropia is also commonly seen. Now, hyperopia and esotropia are generally related in a dose-dependent manner, and this is very interesting because this is a meta-analysis where they studied the increase in the risk, and they found that between 2 to 3 diopters, there's a 10-fold increase. Between 3 to 5 diopters, there's a 40-fold increase in the risk of esotropia. And more than 5 diopters, it's a big jump of 218-fold increase in the risk of acquiring esotropia. So apart from the refractive accommodative esotropia, which is basically when you put in a perfect pair of glasses with the full cycloplegic correction, the esotropia disappears or gets less than 8 prisms. So that's pure refractive accommodative esotropia. There are 2 more components. One is the partial accommodative esotropia, or the decompensated variety, where you have, after cycloplegic correction, you put in the glasses, there is still a residual refractive error of more than 10 prism diopters for distance. There is a subset of this which is called the high AC by ratio, where we have a difference of 10 prism diopters for near after full cycloplegic correction. So here you can see the partially accommodative esotropia. This is a child who has a left esotropia with glasses partially corrected, and after surgical correction, you get the full
orthotropia. Here again, when we measure for correcting the residual squint, it is very imperative to measure and operate for the value that you get on top of the glasses and not without. And the second is the accommodative esotropia with high AC by ratio, where you can see the glasses, the executive type bifocals, which bisect the pupils. And this is a child who's been weaned off the glasses and is now orthophoric. Okay, so this is just to clarify that such squints do not fall under the refractive category. This is an infant who has a large angle exotropia, and you can see that this child is less than 1 year, and they tend to have cross fixation, and they tend to have these combinations of primary inferior oblique overactions and DVDs and so on. So in these cases, operating them way earlier is very prudent, and they don't fall under the refractive category. And of course, their hyperopia is also very less, like less than 2, and that's how you identify them. When it comes to accommodative component surgery, you always treat the amblyopia first, and we prefer bimedial rectus recessions. And when you have an associated AC by A ratio, you perform a posterior fixation suture like a Fardens or a Scott's procedure. So to answer, can anisometropia cause strabismus? Yes, they can. So anisometropia is usually associated with both esotropia and exotropia in children less than 5 years of age. But they're usually more commonly seen associated with hyperopia than myopia and astigmatism. So let's move on to component of myopia. Here you have a child with a right exotropia who has been having it on and off over a period of time. And he just came in with this complaint of squint. But when we did measure him, he had a refractive error of around -3. And with glasses, you can see that his control over the squint is much better. And this is a component of intermittent exotropia. So here there is a direct link between the fusional control, the control over the squint with the help of glasses. Now, there has been a 70% association of myopia with intermittent exotropia, and the risk factors are female gender, younger age, and excessive near work. And ideally, it's good to correct them appropriately. But why does this happen? What is this relationship? Is it a classic case of the chicken and the egg? Did myopia come first, or did the squint come first? So now there are two schools of thought. The traditional school of thought is that myopia causes a decreased accommodative demand because they don't need to accommodate, which in turn decreases the convergence demand, and that increases the risk of exotropia. Well, the other school of thought says the intermittent exotropia came first, which increases the convergence demand, increasing the accommodative demand, causing a progression of myopia. The first school of thought is a more traditional school of thought here. So apart from giving a regular minus lenses, we can also prescribe over minus glasses for these kids in order to bring about better control of their squinting or their exotropia. So it's usually tried in small angle exos between 1 to 4 diopter, but I usually don't go beyond 1.5. And they stimulate the accommodative convergence, and especially in terms of convergence insufficiency type, they're really helpful. And before and after surgery, even after surgery to control the microtropia, we can try them. Surgical considerations in intermittent exotropia, there are a few pointers here. Always measure the squint with the glasses on. I think it's a given here. Apart from that, we should also take in the component of glasses thickness here, because the thicker the glasses, the more basin effect the prismatic effect is going to give. So we need to add corrective factors. So how does the glasses affect? Minus lenses increase the exo deviation, and plus lenses decrease. So there is an inverse relationship, which means that we will have to undercorrect whenever you measure over a minus lens and overcorrect over a plus lens. Now, when is this significant? Anywhere where there is more than 5 diopters of glasses, there you will have to either use a contact lens or use such correction tables in order to accommodate for the difference in the prismatic value. So I'm going to end up with this. Can myopia really cause esotropia? So yes, there is a component called the esotropia-hypertropia complex, or the heavy eye syndrome. What happens is when this high axial length and high myopic eyes, you get these huge eyes which are 30 mm, and they don't have space in the orbit to grow. So what happens is the only space available is the superior temporal quadrant, and then when they expand along that side, the superior rectus becomes nasal and the lateral rectus becomes inferior. In such cases, what happens is, this can be seen on the MRI of brain and orbit. In such cases, the eye goes into hypotropia and esotropia. So what we basically do in surgery is to identify the lateral rectus and the superior rectus, and identify 14 mm behind, and pull using a non-absorbable suture. We kind of pull these two ends together and push the globe back, the herniated globe back into the orbit, and then close them up. So here you can see we're just hooking the muscle, but towards the end, now this is the superior rectus and that is the lateral rectus. We have now identified and sutured the portions there, and then now we tie them both together. So this is how it was pre-op, and then with the esotropia has recovered with improvement in abduction. So this is my take-home message. Myopia is associated with exotropia, and minus or over minus glasses help. Hyperopia is associated in a dose-dependent manner with esotropia, where glasses help. Definitely an isometropia and astigmatism can be a causative for strabismus. Reduce the measured deviation in high myopes with glasses, increase the measured deviation in high hyperopes with glasses. Thank you. Thank you for Dr. Prachi, and thank you BOA for this wonderful opportunity.
Thank you, ma'am, for the presentation. We now proceed on with Dr. Darshana.
So Dr. Darshana is going to talk to us about tips in pediatric ophthalmology evaluation. She has been successfully practicing general and pediatric ophthalmology from Aurangabad.
At the outset, I would like to thank the organizers for giving me this opportunity. And I will be starting with my talk on tips for pediatric ophthalmic evaluation. Examining a pediatric patient can be a daunting task. However, if extra time is taken initially to gain the trust of the child, the rest of the examination will go on more easily. So it all begins with establishing a rapport with the child, and a child-friendly ambience can put the kid at ease. One should always remember the dictum, one toy, one look, and have an adequate collection of toys in our clinic to facilitate the assessment. Also, reward stickers and sweets kept handy can do wonders. Important to review the case history before so that we know exactly what to assess, as children are amenable to examination during the first moments of encounter. Also, get the child talking and do the external examination, because as the child talks, more likely that he'll be cooperating for the examination. Do non-contact things first. Try to engage the child, making every step of the examination again. Use of light should be preferably towards the end of the examination, because some children are very sensitive to light and turn up being uncooperative. In older kids, it helps to explain the procedure to the children. While examining uncooperative young children or in newborns, this can be easily done by restraining, in which two assistants will help to stabilize or immobilize the child, and one can get our evaluation done. If a detailed evaluation is needed, lit speculum with topical anesthetic can be used. Demonstrating the procedure on the parent can help sometimes. Often toddlers will allow a quick look at the slit lamp if we keep the light as dim as possible and we have in mind what to see and look at that first. If the child is uncooperative for a standard slit lamp, the indirect ophthalmoscope with a 20D lens is a good magnifier which can be focused on the cornea. The red reflex test is also another very good test which can pick up small anterior segment opacities which can otherwise get missed without a slit lamp. It is done with a retinoscope or a direct ophthalmoscope. In small focal pediatric cataracts, it's important to assess the red reflex in the undilated state to assess the visual impact of the cataract. An asymmetrical red reflex is always a cause of concern. Lens rack is very useful for quick refraction in kids. However, some kids would object the lens rack over their face, in which case we would have to hold the lenses by hand and do the refraction. In such cases, we should be able to gauge the cylinder axis by eye. Important to remember keep a track of the working distance while doing the retinoscopy, and also keep an eye on the child's head position. Anisocoria evaluation can be done with a retinoscope from a distance. We place the retinoscope bar at 180 degrees and sit far enough to have the light hover over both pupils while looking through the retinoscope. This can be used for both light and dim settings. When screening of pediatric vision, one should know that kids are notorious for peeking, and patching of the fellow eye always helps. Asking the older kids to read backwards is also useful because kids tend to memorize the vision charts. In the absence of nystagmus, there should be no significant improvement in acuity testing when tested with both eyes open. While assessing monocular vision in nystagmus, placing an occluder close to the eye can worsen the nystagmus. Hence, it is important to use a slightly, like hold the occluder slightly away from the eye, or use of high plus lenses for fogging rather than an occluder, or using a semi-opaque occluder. While testing vision in the pre-literate, it is important to familiarize the child with the pictures, either by reciting or pointing with the key card while testing with the picture chart. The goal of the vision testing in the pre-literate age group is to ascertain equality of vision in both eyes in the shortest possible time, rather than a 6/9 or a 6/6 vision. True esotropia or pseudo-esotropia can be easily demonstrated to the parents by pinching the nasal bridge and demonstrating the centered corneal reflexes. The doll's head maneuver is another extraocular movements. In this child, we can see with alternating esotropia, the abduction is normal as elicited by the doll's head maneuver. It can differentiate between comitant and incomitant squints also. Anomalous head posture has various etiologies. Patching of an eye should improve an anomalous head posture if it is due to strabismus, but not if musculoskeletal or neurologic in origin. Confrontation visual fields can be done in small kids with the two-toy test, where a toy is placed in the primary position and another toy is introduced in the peripheral field, and the first change in the refixation towards this peripheral target is noted. This can be repeated in all the 4 quadrants, and we can diagnose neurological defects with this. In children who complain of watering, but without the classical signs of discharge or matting of lashes, the dye disappearance test can rule out the presence of an outflow obstruction. Indirect ophthalmoscopy is the last part of the examination. Important to use a low illumination as possible. No manipulating of the lids. Quick view of the each eye can be obtained. It also helps if we can have the child focus on a mobile playing song or a cartoon. For a detailed or a peripheral evaluation in younger children, restraining can be done. Instilling of eye drops, before instilling a dilating drops, using a topical anesthetic before the dilating drops can help. In an extremely non-compliant child who refuses to open his eyes, placing the child supine with the eyes closed, a single drop can be placed in the sulcus between the medial canthus and the ipsilateral side of the nose. Child should maintain supine. Ocular penetration is achieved with this method, although it is lesser than the conventional method. So to summarize, maintaining a directed flexible approach throughout the examination can ease a pediatric eye evaluation. An early diagnosis of a treatable condition is the reward for success. Thank you.
Thank you, Mom. Thank you for the lovely tips. They are surely going to be helpful for all of us.
I now call
We'll
upon
move ahead.
Dr. Kuheli Bhattacharya from Goa, and she's going to talk to us about use of social media to enhance pediatric ophthalmology and strabismus practice.
Kuheli, are you there?
Hello, Prachi? Can you hear me? Can you speak?
Your voice is cracking.
Is my slide?
Voice is cracking a little bit. We can hear you, but it's cracking a little bit.
Okay.
Yeah, now you're
you can
audible.
also hear the cyclone.
Now you're audible.
Now you're audible, ma'am. Yes,
Okay,
you're audible.
Am I? Okay.
Yes.
We'll try and go ahead. Let's see if this is
No, I think she's not audible. I think you'll go.
I think
Go
we'll
ahead
go
with the next one.
next presentation, ma'am.
Dr. Reshma. Dr. Reshma.
Dr. Reshma Mehta.
Can I start my presentation?
Yes, please.
Okay.
Reshma, start your screen share.
Yes.
Dr. Reshma, you'll have to share your screen again.
Yes, yes, just a second.
Okay, ma'am.
Dr. Reshma's.
My screen.
Yes, ma'am, it's showing as loading to us.
Okay, can you see?
Yeah, it's visible.
Yes, it is visible.
Um, uh, we have been hearing a lot about strabismus. I am a little off track. I will be talking about retinopathy of prematurity. Thanks to BOA organizers and Dr. Prachi for giving me this opportunity to present few cases in ROP. All of us know retinopathy of prematurity. It is because of the premature babies who have been given a lot of oxygen and their STOMI and ICU stay. All these babies are actually not blind, and hence we need to screen them, and it is a preventable cause of blindness if not screened on time. Screening is compulsory in all the babies with less than 34 weeks of gestation and 2 kgs, and those babies who are less than 28 weeks of gestation and less than 1200 grams, we should screen them much earlier. Usually we go with the tagline of Tees Din Roshni Ke, given by Dr. Subhadra Jalali ma'am from LV Prasad. This tagline is important. So once the baby is 1 month old, they know that they have to undergo screening. There is international classification of retinopathy of prematurity, which has 5 parameters: the zone, clock hours, stage, plus disease, and pre-plus. For all the patients of retinopathy of prematurity, laser holds as the mainstay of treatment, and the responsibility of diagnosing and recognizing the infants with ROP lies with the pediatrician or the neonatologist. So we have to be very friendly with them, and they should let us in their NICUs to screen these babies and avoid from being blind. After screening them, communication with the parents and considering them the STOMI NICU stay, and then asking them for the screening program and frequent follow-ups and the treatment is very important, and the onus lies on the ophthalmologist. The international classification of retinopathy of prematurity, it tells us about the zone 1, 2, and 3, where the disease is. Usually most of the babies in the NICU have zone 3 and stage 1, and very few babies we get them in zone 2 or zone 3. So I will be presenting few of the cases here. The zone stage 1 is where you can see a demarcation line between the vascularized and the avascular retina. Stage 2 is the demarcation line is with elevation, and stage 3 is demarcation line with fibrovascular proliferation. We'll have few slides with plus disease and the pre-plus and the APROP, the aggressive posterior retinopathy of prematurity, where it does not follow any of the stages, but suddenly the baby lands into retinal detachment. The pathophysiology of retinopathy of prematurity is the baby is prematurely born, and hence there is incomplete retinal vascularization. They're exposed to increased oxygen concentration, which leads to vasoconstriction, vasoobliteration, and further leading to VEGF factors, which are increased, leading to tortuosity of the vessels, plus disease, neovascularization, fibrovascular proliferation, and along with it, NBI, pupillary rigidity. So this is the first case which shows tortuous vessels, venous dilatation, and arterial tortuosity. The baby This baby was 31-week gestation and born with the birth weight of only 900 grams. This is after sequential follow-up visits, the vascular area has increased and there is abnormal branching of the peripheral vessels with few fibrous conglomerations or the popcorn lesions, which are very frequently seen. And then there is formation of the double ridge, and which is extending in almost all 360 degrees. So later this baby was taken up for laser. This is stage 3 ROP, retinopathy of prematurity. The same baby, we can see the abnormal vascular proliferation and the new vessels branching and the increased in the size and the width of the ridge and the hemorrhages which are increasing in the ridge area. And there is large avascular area which is not vascularized and needs quick treatment. The next baby, this baby is born at 30 weeks with 1200 grams with 2 doses of surfactant given, history of RDS, sepsis. The baby was on ventilator for 4 days, CPAP for 3 days and nasal catheter for 4 days again. So this was diagnosed as APROP, that is aggressive posterior retinopathy of prematurity. You can see a lot of hemorrhages and the abnormal vasculature, especially the immature vessels, and they are totally abnormal vessels, not fitting into any criteria of any of the stages. So later again, this baby was also lasered because otherwise this will go into retinal detachment. Baby 3, this baby was born in 32 weeks with 1500 grams, and this shows normal vasculature, but there is a vascular area and abnormal peripheral vascularization, and few collaterals can be seen here. So this was just put as stage 1 and frequent follow-ups were done. But later this did develop into a demarcation line, a white demarcation line, but after few follow-ups it did resolve. So in this pandemic, it is very important that the patient comes for follow-up, and there is good confidence level between the parents and the doctor or the ophthalmologist that definitely he is going to come, or otherwise the baby may land into further complications and retinal detachment. So medicine helps in follow-ups, because then the machine can screen the babies in the periphery and the rural parts, interiors of Solapur or Maharashtra district.
A minute more to go, ma'am.
Yeah. This is the 4th baby, which shows the stage 2. And we followed up this baby with sequential follow-ups, which shows that there is decrease in the vascular area. This is another baby with stage 2 ROP, and this one is stage 4A. This baby we had seen in the NICU, but they were very reluctant for treatment. And you can see stage 4A, huge fibrovascular band with lot of hemorrhages and tortuosity. And finally, the baby is lasered now and has to go for surgery for the tractional bands. And this is another case of APROP with strong or abnormal vessels and venular dilatation and arterial tortuosity in zone 1, and lot of hemorrhages all throughout for continuous 3 follow-ups. Pupillary rigidity can be seen, lot of hemorrhages, and later this baby, we gave them Avastin and then had to follow up with laser. This is another case which I've just seen 2-3 days back. Right eye is totally normal, but left eye shows a huge hemorrhage with abnormal vasculature and abnormal disc vessels. You can see some few fibrous bands also around the disc, and there is a huge hemorrhage. So actually this is a questionable thing, because this is not retinopathy of prematurity. B scan is done, but still they say it is RD, retinal detachment with choroidal detachment and subhilar hemorrhage, but still under investigation and treatment. There's a small video.
Ma'am, can we summarize here, please?
Yeah. Okay.
short of time.
A gift that keeps
Dr.
me going.
Reshma, you'll have to stop
After
your
screening
video.
almost more than 2,000 babies
Dr.
for
Reshma?
ROP since 8 years, I always fear about medico-legal complications
Dr. Reshma, you will have to
associated with
stop
this.
your video.
Yes.
Thank you, Dr. Reshma.
Yeah, sure. Thank you. Thank you, Dr. Hemalini. Thank you, Dr. Prachi, and thank you, BA organizers, for giving me an opportunity to present in this webinar. Thank you so much.
Ashni, do we have Dr. Pooja and Dr. Kuheli now?
We have Dr. Kuheli, not Dr. Pooja.
So let Dr. Kuheli try again.
Let me just try once more.
Sure, ma'am.
Stop sharing.
I'm unable to share the screen.
You can try now, ma'am.
Screen sharing is right. Am I audible? Is the screen seen?
No, the screen is not seen.
Okay. For me, it says I'm sharing the screen. Is the screen?
No, I'm unable to see it. I think Dr. Kuheli has. I think
Dr. Abha and Dr. Shea, are you all there? Dr. Abha, madam?
Yeah, I'm here. Yeah.
Till Kuheli gets ready, do you want to make some comments on the various talks, or you want to ask any questions or anything?
See, all the talks are very nice. They know their subject very well and they're doing very well. And I'm really, like Sunaina Malik madam said, that they are so much interested in SQUINT. So I am also very happy. I just wanted to add one or two tips that when we examine the child who is below 2-3 years of age, I usually don't do refraction in the OPD. I give them the cycloplegic and they come. Or sometimes even if we do it in the OPD, I ask the parents to put the drops in the child's eye. And another thing is, while doing fundus examination, we have to take a proper position, which Dr. Darshana had showed. But before that, because the child cries a lot, so I always ask the history of breath holding while the child cries. So it's better because sometimes they have a habit of breath holding. So that I rule out. And really, they are doing very well. And sensory.
Ashni, you have any questions?
I think Dr. Kuheli has started.
Okay. Okay.
I think we'll take up the questions after she finishes her talk.
See, the problem is that she's not able to start, and you all have exactly now 10 minutes more because.
So you continue with the questions, I think, till the time she really logs in and is able to speak.
So I had a question for Dr. Monica, ma'am. How frequent do you ask for the follow-up for the children who have the intraocular lens which is dropped inside, the natural lens? So how frequent do you ask for the follow-up? Is it a 3-monthly follow-up or a 6-monthly, yearly? How does it?
Yeah, so depending on the age actually. So if you see this child, I had like after both the lenses have fallen down, initially at 6 months and then once a year.
Okay. Okay, ma'am.
But if it is like this baby, I had one eye drop and one eye still, I definitely call them after 3 months once, every 3 months to see what is this situation.
Okay.
Ashni, I think Kuheli is ready.
Yes, ma'am.
Yeah.
Kuheli, please start. Prachi, what should we do?
I don't think she will have enough connection. I think because of the.
Okay, then leave it. We'll continue with the questions and
maybe Kuheli, you can just make comments.
No, Kuheli,
your voice is not good actually. So if you want, you can just make some comments in short if you can, and if we can hear you. Because I don't think you'll be able to make the presentation with the kind of connection you're having.
Is this better?
This is better.
Yes, it is.
It's not audible.
Okay, try talking now. Try just continue.
this better?
Yes.
Yeah, Koeli, you can continue your presentation.
Okay.
And if we can't hear you, then we will just stop.
So good evening, everyone. I'm so sorry that we had to,
No, Prachi, I think we'll call it quits, man.
Yes. Because of the cyclone, there's a lot of internet issues.
Yeah.
Instead, we'll take 3-4 questions and then we can.
Yes.
Dr. Shruti? Is Shruti, Nishant there?
Yes, I'm here.
Shruti, there's a question for you that, a lot of, you spoke on strabismus and refractive errors.
Yeah.
And, you get a lot of patients in private practice with high myopia and strabismus. So for the benefit of the audience, what would you advise them if they ask you for LASIK? Would you advise LASIK first, followed by strabismus, or the other way around?
Okay, so again, so when we have adults who are beyond 18 or 21 or wherever they have a stable refractive error, we do go in for this. I mean, such patients who want LASIK and they don't know, and sometimes they even put the question back to us saying, whatever you suggest. So in those cases, I give them, I do measure them with the glasses and without the glasses, and I see what difference in refractive error, I mean, what difference in the squint value we get. And based on that, I take a call. If there is not much of a difference with and without glasses, then I advise them to go for the squint first, followed by the LASIK. If there is a difference, then I do ask them to go for the LASIK first, followed by the squint. So it's a very tailored approach. I don't have
And how much time gap do you keep?
So I give 6 months for complete healing. That's how much time I space them out. But I do know that there are people who do it at 2 or 3 months also. But I give 6 months.
Right.
Any cases which have decompensated?
Very unlikely. That's the thing. Actually, they're very unlikely that the LASIK does really influence. In fact, there's not much of a thing. Though we have learned a lot about that, but we do see that it doesn't really influence. So either way, it works. But just for the safety of the procedure in itself, it would be good to do the squint first, then the LASIK, going against the traditional teaching.
So I would like to just add on to what Shruti has said. The fusional amplitudes actually are the way, I think, to really decide what we should go in with first. So if the patients have very good fusional amplitudes, post LASIK, they improve by themselves, and then generally they don't require a squint surgery. However, if the fusional amplitudes are very poor, then probably it's a better idea to correct the squint first before going in for the LASIK. And also for the high myopes especially, it's a good idea to measure them with the contact lenses on. So that gives us an idea as to what their status would be after LASIK. A closer, that would be a better evaluation. So the fusional amplitudes really make a difference in really deciding what we should be going in first with.
We have time for one more question. Riddhi, you want to ask a question to anybody from the audience? Sorry, from the speakers. Prachi, do you have any question for the speakers?
Yeah, I would like to ask Monica one question. So especially with respect to diagnosing sarcoidosis in the pediatric age group, Monica, are you there?
I am there.
Yeah. So you talked about the raised serum ACE values. So as we know, generally the ACE values are known to be on the higher side in the pediatric age group. So do you really add on to getting the serum calcium levels as well as an HRCT?
Yes. So yes, so serum calcium levels as well as HRCT would be advised. And then depending on that, you will actually bifurcate between tuberculosis and sarcoidosis, depending on the lymph nodes, caseation, and also that is the next thing. I actually didn't show that slide because but that is how you go about with ACE and then serum calcium, urine creatinine, and go about doing the HRCT. Yeah.
Is there time for one more question?
Yes, one last question.
I would like to ask Dr. Shruti and other panelists also, like many a times we get these adult patients who've never used glasses, but they're hypermetropes and have esotropia. And how do you, so they want a cosmetic surgical outcome. And do you end up undercorrecting them, or what is your target for the esotropia? Because these are the ones who don't want to wear the glasses. And they have a significant +4/+5 cycloplegic retinoscopy. So how do you go about it?
You mean to say they would like to wear their glasses, but they don't
want to wear glasses. They want a cosmetic squint correction. They are somebody who have never been corrected for squint or glasses earlier.
Okay, so the question is, how would you correct the squint in such cases?
Yes.
So in these high pluses, so the plus actually underestimates. So when we measure, we kind of have to slightly undercorrect them. That's what I would do. And are you asking in terms of the laser as well, or just the squint?
So what happens in these patients? These are ones who have never worn glasses. They have been uncorrected hypermetropes. They might be accommodative esotropia in childhood, but they never got glasses then, and they remain esotropes throughout. Now they don't accept your plus because they have a very their cycloplegic retinoscopies are high, but otherwise they're around 6 parts uncorrected. So these are the ones where you can't give a glass. You need to do a squint surgery. So is there a different plan that you take for these patients? Anybody from the panelists can also go and...
No, I think ideally the dictum is that, even if they've never worn glasses, you have to first give them glasses. I sometimes don't hesitate giving atropine adaptation followed by glasses, trying to explain to the patient that it's in their own interest. And then after coming, after they come back for a follow-up, reassess the squint, measure the angles again. And maybe in these older patients, who've been detected hyperopia for the first time, maybe you won't want to give the entire plus correction. You might want to undercorrect them a little bit.
So as soon as you give that atropine, they're going to jump the lane and go to the next ophthalmologist, because that's what many a times
but that's
with
the
a
right
lot
thing
of
to
us.
do.
Let them go, no problem. Let
That's
them
true.
go, no
That's
problem. Yeah.
Yes.
Ma'am, and how long do we wait after giving the hypermet? Suppose if we've undercorrected and it is showing a moderate change in the esotropia, then what to do next? Do we wait, give another trial
No,
of the...
then I would wait for some time, and then once the atropine effect is worn off, measure the angles again, and then operate for the residual angle. But I have to still tell the patient that even post-surgery, some amount of hyperopic spectacle correction will be required, either in the form of glasses or in the form of contact lenses.
Okay.
Basically, the accommodative effort cannot be corrected by surgery. That's
So we will have to, so that's what I was about to say. We initially had one patient like this. Invariably, they do end up having some amount of amblyopia as well. So we do have to address that issue. So we did one patient with similar, like I think +4 anisohyperope. And what we did for that patient is we gave the glasses, we gave contacts. In fact, I did adult amblyopia therapy for him. He got better up to 6/9, and then we did the squint. In fact, he underwent LASIK actually. Hyperopic LASIK, got that corrected, and then we corrected the squint later. So we follow the same process as how we follow for a child is what we have the same patients and work on each aspect of it as we work on a child. Himalini ma'am, anything would you add?
No, I would quite agree with you. I mean, yes, hyperopic LASIK is also an option. And then exactly like what you said. I think we'll wind up. Does somebody want to give a vote of thanks and conclude the session, please?
I do the info. So thank you, Abha Madam, Dr. Shreya Madam, and the entire VOA team, Himalini Madam, and all the wonderful speakers, Monica, Shruti, Anuka, everybody, one and all. So it was a lovely session, and hope to see you physically sometime soon in an actual conference.
And apologies to Kuheli and Dr. Pooja. Sorry, you were not able to join because of your network issues. So apologies for that. Thank you, everyone.
Thank you, Dr. Himalini, and
thank you,
team
Abha
of
Madam.
VOA.
Thank you so much.
Yes, thank you. Thank you. Yeah.
Thank you for taking out the time
really,
and for your patient listening. Thank you so much.
I have joined since morning, but I was from the audience link. I thought I will come here for the faculty link afterwards. So I've seen your session since morning. Yeah, it was going on very well. Yeah.
Thank you. Thank you, ma'am.
Yeah, thank you.
We enjoyed it so much.
Chalo, bye.
Bye, everyone.
Bye.
No screenshot.
हाँ ले लो screenshot ले लो. Taken?
Chalo, bye.
Bye.
Bye, ma'am.
Bye. Thank you, everybody.
Thank you,
Bye,
Ashni.
Dr.
Thank you,
Emily.
Riddhi.
Thank you, ma'am.
Thank you,
Bye.
ma'am.
Yes, good evening, everyone. Darade sir.
Good evening. Good evening.
Good evening, sir.
Good evening, Sumit.
Yes, sir. Sir, Sandeep Wankhede sir has joined here.
I think not.
Okay, fine, sir. I will try and contact him.
Yeah. Yes.
Okay. Just then we will wait for him for 2 minutes, sir. If he doesn't
Yeah, yeah.
join, then we will start. Dr. Lahane
Yeah,
sir has
yeah.
also joined, sir. Sir,
Yes.
it's a free paper session 4, and we have
Yes.
judges here as Dr. Darade sir, Dr. Rupa Naik ma'am, and Dr. Renu Magdum madam. Lahane
Yes.
sir is also here.
Okay, Rupa has joined, Renu madam has also joined, the Darade sir has joined, and all the presenters. So thank you very much, madam. Both madam, thank you very much. Rupa, how are you? नाही माईक बंद आहे तुझा माईक चालू बोला
Welcome, Lane, welcome.
How are you?
Fine, thank you.
Okay. Renu madam, कैसा how are you?
Very well, sir. Thank you so much.
Good. Nanuma?
Fine, sir. Thank you so much. आपले आशीर्वाद आहेत, sir.
Okay. Very good.
Yes, sir.
Rade, good evening.
Good evening, ma'am. Good evening. How are you, ma'am?
Very fine,
Yes.
thank you. Thank you so much. Renu
Yes,
madam,
yes.
good evening.
Good evening, ma'am.
Good evening, Renu ma'am. Good evening.
Good evening, sir. So nice to see all of you.
Yeah. Thank you so much. After a long time, after a year.
Yes. Thanks to COVID, we all out.
Yeah. In last examination, AMS after we met.
Yes. Been a
Yes,
long
after
time.
that, this is after a long time, after 1 year gap.
Sumit, good evening.
Yes, good evening, ma'am. Ma'am, I am not able to contact Dr. Sandeep Wankhede sir. I had spoken to him in the morning, but there is some problem. So if you permit, then can we start with the session now?
Yes, Sumit, yes.
Yes, you can start.
Yes,
I think
sir.
so. Yes, madam.
Okay.
Yes, please go ahead.
Can we start?
Okay.
Yes, no problem.
Yes.
Okay, so welcome all to the free paper session 4, and we have our respected judges here, Dr. Rupa Naik ma'am, Renu Magdum ma'am, and Dr. Nanova Darade sir. And with the esteemed faculty, we would be starting presentation, and the first presentation for a day is Ravin Punamia. Ravin, have you joined? Dr. Ravin?
Yes. Am I audible?
Yeah. Please start sharing your screen.
Is my screen visible?
No.
Still not.
Not exactly. Yeah.
Yeah.
Okay. Yeah.
Yeah.
Fine.
Next slide show.
Make it full screen. We'll start your time. Duration is 6 minutes and 2 minutes is question answer.
Good evening, respected judges, my seniors, and my dear colleagues. My topic for today is reliability of rebound tonometry with gold standard tonometer and its correlation with CCT. The aim of my study is to compare the IOP readings taken by rebound tonometry with gold standard with rebound tonometry and gold standard Goldman's apprehension tonometer, and to correlate this with the central corneal thickness. Introduction. Measurement of intraocular pressure is a routine investigation in overall eye checkups, and IOP still remains the only modifiable factor in treatment of glaucoma. And lessening of the IOP has shown to decrease the progressive field loss in patients with glaucoma, and therefore the importance of accurate and precise measurement is justified. Goldman's apprehension tonometer is considered as a gold standard of measurement. The principle behind it being Imbert fixed law, which depends on the apprehension or flattening of the cornea. GAT gives the most accurate value at the corneal thickness of 520 microns. Rebound tonometry, it is usually done by eye care tonometer, which is a handheld device. A very light probe hits the cornea and rebounds back, and an induction-based coil system is used for measuring the motion parameters. The deceleration of the probe and the contact time is calculated into the IOP, and the average is displayed on the device after 6 rebounds per measurement. Higher the IOP, faster is the deceleration, and shorter is the contact time with the cornea. Material and method. This is a cross-sectional observational study. Patients above the age of 18 years coming to the OPD in the month of October 2020 were considered for the study. All the patients were informed and counseled regarding the study, and proper consent was taken. Basic history examination and vision was done. A thorough slit lamp examination of the anterior segment and the dilated fundus examination was done. Eye care pressures were recorded, and then GAT was done for both eyes by 2 separate examiners who were masked from each other's results. Central corneal thickness was recorded after the measurement of IOP, and all the data was entered in the Excel sheet for analysis. Measurement was taken from both eyes for the study. Inclusion criteria includes all the patients above 18 years with a normal anterior and posterior segment. Exclusion criteria involve patients below the age of 18 years or mentally ill patients. Corneal pathologies like corneal dystrophy, degeneration, and any opacity or dry eye. Anterior segment pathologies like uveitis or lens-induced glaucoma. Known cases of glaucoma on medical treatment or post-trabeculectomy. Posterior segment pathologies like vitreous hemorrhage, retinal detachment, and diabetic retinopathy. Statistical analysis. Paired p-test was used for the comparison between RBT and GAT. Correlation between RBT and GAT was with CCT was determined using Pearson's correlation coefficient. A p-value of less than 0.05 was considered significant. A total of 200 eyes were considered for the study of 100 patients. The male to female ratio was 43:57. Mean age was 65.78 years, and in males it was 65.77 and 65.8 in females. The mean IOP measured by RBT was 14.4 plus minus 3.15 millimeters of mercury, and that by GAT was 14.87 plus minus 3.06 millimeters of mercury. The difference between the mean IOP was 0.47, which is statistically insignificant with a p-value of 0.06. The mean central corneal thickness was 511.1 microns, and in males it was 515.1 plus minus 34.14, and in females it was 508.1 plus minus 33.64 microns. Here we can see a table of correlation of CCT with RBT and GAT. The Pearson correlation for RBT is 0.3425 with a significant p-value, and GAT is 0.3077 with a p-value which is significant. This is a bland Portman chart which shows the average of RBT and GAT on the x-axis and difference of RBT and GAT on the y-axis. The black line represents the mean difference, which is minus 0.47, and the red dotted lines represent the 95% confidence interval limits, the upper limit being 3.95 and the lower limit being minus 4.89. Discussion. It was observed that RBT values of IOP were slightly lower to those measured by GAT over a range of CCT from 419 microns to 616 microns. The difference in IOP between RBT and GAT was statistically insignificant, with the p-value being 0.06813. Jose et al. And Moreno Montañez et al. Found that the RBT tonometers are known to slightly overestimate IOP as compared to GAT. However, in a study conducted by Nakakura S, they found that the IOP measured by iCare was slightly lower than GAT due to the higher mean age of the patient. And this can be seen in our study as well, where the mean age is 65. Chen et al. And Jose et al. Also stated some disadvantages of GAT, which include it requiring anesthetizing drops, it requiring a fluorescein dye, slit lamp, and a trained examiner. It is also dependent on the corneal pathology, and because it's a contact procedure, it also increases the risk of infection and spread of infection from one patient to the other. iCare tonometer does not require any such anesthesia or fluorescein dye, and it is a relatively easy instrument to use, and it is portable as well. RBT and GAT have shown positive correlation with CCT, RBT being more positively correlated with CCT than GAT. Various other studies have shown similar results. The deviation of IOP readings affected by CCT varies differently between different studies according to Chen et al. Conclusion. The result of the study demonstrates that iCare rebound tonometer can measure IOP with a relatively small difference in measurement and can provide a reliable reading in comparison with GAT across a wide range of central corneal thickness without hampering the corneal health. Thank you.
Over to judges, please. Stop sharing.
Yes.
Oh, sorry.
Judges, you can go ahead with your questions.
Dr. Arvind, you have talked about some other studies which had different results from yours. So were the studies, your study done in a different manner, or the mechanism or the methods were exactly the same?
The methods are similar. Both RBT and GAT were taken by two masked examiners, and the statistics was conducted by another masked person who did not perform the examination.
Okay, then your study is mainly on checking the intraocular pressure. So why did you exclude the posterior segment problems patients?
Patients with posterior segment pathologies can also have an effect on increase in IOP.
Yes, but you're measuring the same IOP with two different instruments, and you're seeing how much they differ.
Yes, ma'am.
So was there any other reason for excluding? Hello?
No, ma'am.
Yeah.
Please answer your question quickly so judges can ask you more questions, or you can pass on the question. Otherwise, you will be losing your own scoring thing.
Yes, ma'am. No, ma'am.
Okay. Hello, Ravi.
Yes, sir.
Can this rebound tonometer can be used in pediatric age group?
Sorry, sir.
Can it be used in pediatric age group?
Yes, sir. It can be used in pediatric age group.
Okay. Whether it is FDA approved or not, and when?
Sir, I'm sorry, I don't know that.
Okay. Okay. Over to Rupa, ma'am.
Hello.
Yes, ma'am.
What is the difference in cost of two tonometer, and which is more beneficial?
Ma'am, I don't know the cost difference.
Okay. So in your view, which tonometer is good?
Ma'am, GAT is considered as a gold standard, but in patients in which there are any corneal pathologies, we can use iCare as an alternative method.
Okay.
And it can provide us with a reliable IOP.
Okay. So one should have that one. Okay. You must have told about the cost also. No? Okay. It's all right. All right. Okay.
Okay.
Bye.
No problem.
Thank you so much.
Thank you. So we'll move on to our next speaker, Dr. Bennett Matthew, and he will be talking on predisposing factors for iris claw lens implantation. Over to you, Dr. Bennett. Your time starts now.
Am I audible?
Yes, very much.
Yeah. Good evening, judges, seniors, and my dear colleagues. Today, my topic is predisposing factors for iris claw lens implantation, a study at a tertiary eye care center in central India. There's no financial or personal interest involved in this presentation. So the aim of the study was to evaluate preoperative and intraoperative indications of iris claw lens implantation and to analyze visual outcome of retropupillary fixation of iris claw lens as a primary surgery. The complete visual recovery in aphakia has always been a challenge for every ophthalmologist. We know that spectacles and contact lenses have been in the scene for a long time, but surgical methods for aphakia are considered the best, and the options include scleral fixated intraocular lenses, angle-supported anterior chamber intraocular lenses, and iris claw lens. Anterior chamber lenses, as we know, are associated with an increased corneal decompensation and secondary glaucoma. Esophyles, as we know, preserve the anatomical integrity but are time consuming and require high technicality. Iris claw lens was invented by Wurst in 1980. The advantages of iris claw lens as compared to esophyl is that the implantation is technically easy. And as compared to anterior chamber IOLs, it reduces the risk of corneal endothelial damage. But at the same time, there are few disadvantages, like there's a high incidence of pupillary distortions and iris atrophy, along with secondary glaucoma. There may be a wound suture related astigmatism in cases where sutures are used, and it's a bit costlier than the regular lens, regular posterior chamber intraocular lens. So the study we did was a retrospective study. We used the data of 3 years from January 2017 to December 2019. We included patients with surgical aphakia with poor capsular support. All of our patients underwent manual small incision cataract surgery. Preoperative assessment included regular examination as done for every cataract patient. The iris claw lens used in our study was Excellence, which is a PMMA biconvex iris lens with a total length of 8 millimeter and an optic size of 5.5 millimeter. The A constant was 117.2, and we preferred the SRKT formula for IOL power calculation. During the normal manual SICS, once the iris claw lens was indicated, we made a paracentesis followed by an anterior vitrectomy, after which pilocarpine was injected to induce the meiosis, which was followed by the implantation of iris claw lens, and a peripheral iridectomy was done. Rest, the case was closed as in every normal case with a subconjunctival injection of antibiotic and steroid. Postoperative regimen of topical steroid and antibiotic was given in every patient for about 1 month, and normal regular follow-up was done on the first day, 7th day, first month, and if required, up to 6 months. The results of the study, 144 aphakic eyes were enrolled in the study. Of this, as I had mentioned, we enumerated the predisposing factors as well as the intraoperative factors. Among the predisposing factors, 61 of the eyes, that is 42.36% of the total eyes, predisposing factors, of which phacodonosis was the most common one. Among the intraoperative factors, capsular bag delivery was the most common factor which indicated iris claw lens implantation. The average postoperative mean best corrected visual acuity in our study was improved to logmar 0.50 from that of preoperative logmar 1.30. So the demography of the study, as you're seeing, it was dominated by the female population. As I mentioned, among the preoperative factors, the most common one was phacodonosis, which was present in almost 60% of the patients. Among the intraoperative factors, the most common one was the bag, which came out during nucleus delivery or collapse in about 32% of the cases, while posterior capsular rent was seen in 25% of the cases. The other factors were sonular dehiscence and subluxation. Among the postoperative complications in the patients, the permanent complications like pupillary distortion and iris atrophy was seen in 27% and 11.8% respectively. Other postoperative complications like secondary glaucoma, hyphema, transient hypertony, IOL tilt, and postoperative cystoid macular edema were resolved by medical management. Discussing the study, as we all know, iris claw lens is in its prominence as compared to anterior chamber IOLs and esophyls over the past few decades. In our study, as I had mentioned before, the most significant intraoperative factor which led to iris claw implantation was capsular bag delivery, followed by posterior capsular rent. Predatory et al. In the study, which was conducted in 2018, had stated that posterior capsular rent, which amounted up to 47.6% of its patients, as the most common cause, followed by traumatic subluxation and solar dialysis. Our series had a preoperative mean best corrected visual acuity of logMAR 1.30, which improved to 0.50. And it was specifically to mention that 97% of our patients achieved a final best corrected visual acuity, which was better than the preoperative best corrected visual acuity. The results were very comparable to Mansouri et al. Study and Kelkar et al. Study. Another significant study which I would like to mention was by Madhivanan et al., who compared iris claw lens to SFI lenses, whose improvement was just as similar to ours, but he had noticed that iris claw lenses had a better visual improvement compared to SFIs. As I had mentioned before, among the complications, pupillary distortion and iris atrophy was common in ours, which was similar in Predatory et al. And Charaguis et al. Study. But Mansouri et al. Had reported that ocular hypertension to be the predominant complication, which was followed by an oval pupil. Considering the study can be has a scope of conducting a comparative study with SFIL, as well as the follow-up period was shorter one. So a longer follow-up period would indicate a better study. On concluding, I would like to tell that intraoperative capsular bag delivery is the main intraoperative cause of posterior cap support. Improved expertise reduces the complication, and iris claw lens remains a cheap solution. Thank you.
Over to judges now.
Bennett,
Please stop
what do you
sharing
mean
your
by
screen,
primary
Bennett. Please
and
stop
secondary
sharing your
iris
screen.
claw?
Excuse me, sir?
What do you mean by primary and secondary iris claw?
So primary iris claw is in the cases in which we take up for cataract surgery and the iris claw is implanted in the first setting itself. Secondary iris claw are the patients we take up in the second setting. For example, any patient may come up after cataract surgery which was left aphakic, or maybe a traumatic subluxation after an IOL implantation.
Your study was secondary or primary?
No, sir. Our study was exclusively.
Okay, so what formula you used for IOL power calculation?
So SRKT formula was used for IOL power calculation.
But which is a ideal formula?
So the ideal formula would be Haigis formula.
What is that Haigis formula?
Sir, Haigis formula, sir, it involves use of 7 components, 7 factors. Sir, I'm not sure about the formula exactly.
Okay, okay. Over to Magdum, ma'am.
Yes, and Dr. Bennett.
Yes, ma'am.
You've written your title as predisposing factors for iris claw IOLs. Do you think it is the right title to give to this study? You could use the word indications. I think that would have been better.
Yeah.
Right?
Yes,
Indication
ma'am.
and visual outcome in iris claw implants.
Yes, ma'am.
Yes?
Sure.
Yeah.
Thank you, ma'am.
All right.
Any other questions?
Yes, I wanted to know how SFIL is not good and this iris claw lens is good. Means iris claw lens is better than the SFIL?
No, ma'am. Our study didn't compare. I had mentioned in the second last slide that we had a scope of comparing it with the SFILs.
Okay.
And since our center being a high volume center, we rely on iris claw lenses because most of the cases were in the primary setting and anterior segment surgeons were handling the cases. So in a primary setting, for anterior segment surgeon, once the indication was seen intraoperatively, it's always easier to implant an iris claw lens.
Okay. How can manage a complication with iris claw lenses?
Excuse me, ma'am, I didn't get the question.
Yes, yes. What about the complications of iris claw lenses? And
Yes,
how?
ma'am.
What about the management? I am asking.
Ma'am, among the complications, the most common ones in ours was the pupillary distortion and iris atrophy, which can't be managed post-operatively because it's a permanent complication. But apart from that, secondary glaucomas are present, which we had managed medically, and iris claw lens tilt was present in 2 patients, which was taken for retucking on the post-operative day 1.
Okay. Okay. Good.
You mentioned about ovulation of the pupil. How will you manage ovulation if it's more?
Sir, if ovulation is more, sir, once the tucking is done, we prefer not to go surgically. So maybe we can try pilocarpine on postoperative day 1.
Okay, over to Sumit.
Yes, thank you, sir. And we'll go ahead with the third presentation by Dr. Abhishek Patel. Dr. Abhishek, you can start your presentation.
Am I
He'll
audible?
be talking. Yes, yes, very much. Please make it full screen.
My screen?
Yeah, everything
Okay.
is full. Please make it full screen. He'll be talking about reducing the incidence of end-off by proper operative protocols. Please start.
Good evening, everyone. My title of a free paper is The Role of Proper Operative Protocol in Reducing Incidence of Endophthalmitis in a Tertiary Eye Care Center. The post-operative endophthalmitis is a devastating complication and disaster for surgeon, institute, and patient. The cataract surgery is one of the most common ocular performed surgery in India. 90% of post-operative endophthalmitis occur with cataract surgery. The incidence of post-operative endophthalmitis was declined in recent time because of the change in the surgical technique, sterilization procedure, and the better understanding of a risk factor. Globally, the incidence of endophthalmitis is 0.02 to 0.26%. In the study, we have studied a decrease in endophthalmitis rate compared to the previous year in our hospital and overall compared with the other study. Discuss the pre, intra, and post-operative protocol followed, which helped our institute to reduce the incidence of post-operative endophthalmitis. It's a retrospective observational study of 2 years, data collected from a computerized record system. The population study was the patient undergoing cataract surgery in the DBCS program. Inclusion criteria: the patient undergoing age-related cataract extraction and the documented follow-up at our institute. Exclusion criteria: the patient undergoing the procedure elsewhere and combined procedure with cataract or post-traumatic cataract or pediatric cataract extraction. The detailed systemic evaluation, including blood sugar and blood pressure, fitness, is obtained from the physician. Routine ocular examination done by ROPLAS check. Syringing done if necessary. Topical antibiotic moxifloxacin was started 1 hour prior day for surgery. Special attention was given to the patient hygiene. Separate surgical gown, feet cover, head cap was provided to each patient. Periocular area of operating eye was cleaned with a spirit soap before giving anesthesia. After giving peribubble block, the povidone iodine 5% drop was inserted in eye and patched with a sterile gauze before shifting patient into the OR. The surgical hand was done by the surgeon and assistant nurse from finger to elbow with 7.5% betadine scrub for 5 minutes. The intraoperative protocol, the new set was given for each and every patient. The separate instrument trolley covered with a sterile cotton towel covered with a sterile plastic sheet. We used painting with a povidone iodine 5% solution twice, followed by disposable plastic drape was applied. After placing the eye speculum, thorough wash was given with the BSS. MICS was performed. The wound integrity was checked, and at the end, the wound is covered with a conjunctiva with help of a cautery. At the end, 0.1 ml of antibiotic moxifloxacin 0.5 weight by volume injected intracameral in all cases. Subconjunctival antibiotic steroid is injected, and lastly, the sterile eye patch is placed. This is the standard protocol we follow for instrument sterilization according to NABH at our hospital. This is the OT sterilization protocol which we follow, which help us to reduce the cases of endophthalmitis. The post-operative protocol we follow, all the patients are kept admitted for 1 day post-operatively. At the time of discharge, detailed and verbal and written precaution instructions were given. Topical antibiotic plus steroid was started in the tapering dose. Post-operative follow-up was 1 week, 1 month, and 3 months as advised. Patient living in a far area, the follow-up was arranged at the respective PHC centers. When the endophthalmitis is suspected, the diagnosis was confirmed by vitreous biopsy, AC tab, and clinical examination. Culture and sensitive test of the collected sample was done. Surgical complications such as posterior capsular tear or vitreous loss is recorded from the patient operative sheet data. The result, a total of 40,000 surgery were performed in our study period. We have divided them into the 2 groups, from 2018 to 2019 and 2019 to 2020. As you can see in the table, there were 10 endophthalmic cases in 2018-19, while there are only 3 cases in 2019-20. This is the spectrum of a surgeon did to perform surgery, consists of consultant, senior resident, and junior residents. This is the table showing the comparison rate of the endophthalmitis versus the complication of PCR. And this is the table showing the positive agent in a culture report of endophthalmitis cases. More than 50% of sample shows no growth in both the groups. addition, the clinical endophthalmitis incidence in India is between 0.04 to 0.15. In the two large eye care facility of India, the incidence was 0.08 and 0.16. Our hospital operates more than 100 intraocular surgery per day, which include 80% of patients belong from the rural area with all spectrum of surgeon. Our institute rate of infectious endophthalmitis was only 0.015%. The main change what we did in 2019-20 was the introduction of the intracameral antibiotic moxifloxacin at the end of a surgery. The rate of endophthalmitis decreased drastically by threefold comparing to both the years. A similar study was conducted by Haripriya et al. Shows that the intracameral moxifloxacin prophylaxis reduced the endophthalmitis rate by 3.5-fold, threefold in MICS and nearly sixfold in phacoemulsification. Harrington as well as the clinical trial of ESR showed the significant benefit of intracameral moxifloxacin to reduce the rate of endophthalmitis. PCR is the most common intraoperative complication. In our study, the rate of PCR in rate of
1 minute
endophthalmitis
left.
was very less. Statistically, were insignificant, but Vaughan et al. Report that the intraoperative PCR association associated with 8 to 11-fold high risk of post-operative endophthalmitis. Haripriya et al. Show that PCR is a major risk factor of endophthalmitis, but intracameral moxifloxacin helped to reduce the rate of the infection. In the hygiene was very important. So use the povidone iodine eye drop, povidone scrub, and povidone iodine solution for dripping were emphasized. The use of povidone was backed by the study by Speaker and Makinov that suggests the significant lower incidence of positive culture endophthalmitis was observed in the operating room using povidone iodine. The gloves are changed in every case in our setup, but it was contradicted by the study by Ravindra et al. Suggests that the changing of surgical gloves and gown after each case does not reduce the risk of infection. In conclusion, with a proper monitoring and revolution, all the preoperative, intraoperative, postoperative protocol helped institute to give a best surgical outcome. In our study,
Time up.
we reduced the incidence by 3 times. Thank you.
Dr. Abhishek, can you please stop sharing your screen? Over to the judges.
Dr. Abhishek.
Yes, sir.
Whether fogger is good or routine formalin fumigation is good for OT? Which is
Sir,
good
earlier we used to do fumigation, but according to NABH, we have stopped the fumigation and started using fogging.
Okay. What new you have done in your study? What innovation you have done in your study?
Sir, at the main...
This is the routine you have presented, right?
Yeah, actually the main changes we done in 2019-20 was the introduction of intracameral antibiotic moxifloxacin, which helped us to reduce by almost the case was reduced from 10 to 3, and which was supported by the other studies also. So I think the main was the use of intracameral antibiotic. Second thing, we have started giving individual OT scrub to each and every patient, so that we can reduce the bacterial load inside our OR. And thirdly, as I said, the PCR, the infection rate in PCR with the help of intracameral antibiotic was very less.
Okay. Okay. Over to Magdum, ma'am.
Dr. Abhishek, does this study add anything to our existing knowledge? Because these guidelines have been given several times by so many societies. AIOS has also given. So all this is quite well known. So does this study add anything?
Ma'am, after NABH accreditation at our hospital, these are the few changes we have introduced in last year, which help us to reduce the rate. So the intracameral moxifloxacin was the first time we introduced last year.
Yeah, but that is being used by many people since many years. So I think, is there anything else that you feel that you have done little differently?
Lately, ma'am, we have stopped the fumigation and converted into fogging, and use of the few solution which we use for intraoperative cleaning, like bacillocides.
Okay, so thank you.
Over to Rupa, ma'am.
Yes.
Rupa, ma'am.
Hi. Can you differentiate TAS from the endophthalmitis? And what happens in camp surgery? How can you prevent endophthalmitis?
Ma'am, as I said, our majority of protocol of was based on the pre-operative and intraoperative thing. The pre-operative may give most important to the patient hygiene first, because majority of the patients are poor from a poor background, so hygiene was questionable for them. So we have introduced separate OT ground for each and every patient so that the bacterial load inside the OT will reduce. Secondly, to avoid this infection endophthalmitis in a CAM setup, we have introduced this intracameral moxifloxacin, which have shown us given us a good result. Lastly, the TAS is basically the sudden inflammation inside the interior chamber, mostly present in the next day immediately. Endophthalmitis can be immediately or maybe late, but TAS can be resolved with a steroid. And
Okay. Okay, good.
Okay. Okay. Over to Sumit, Dr. Sumit.
Yes, sir. So we'll start with next presentation by Dr. Barnita Das, the tale of trespassing neighbor. Dr. Barnita, you can start presenting.
Am I audible, sir?
Very much.
Yeah.
Okay. Good evening, everyone. I am Dr. Barnita, and I'll be presenting the next paper of this session. These are my self-declarations. Coming to introduction, sinuses and the orbit are the neighbors in the two cells due to the close anatomical relationship. As evident from this picture, 60 to 80% of the osseous eye socket is made up of sinus walls, and thus orbit is susceptible to the diseases from the sinuses. Out of all cystic malignancies, less than 1% belong to the sinuses, out of which 80% arise from the maxillary sinus. These malignant neoplasm of sinuses can extend beyond the sinuses in 75% of the cases, out of which in 45% of the cases they invade the orbit. Thus, a thorough and systematic evaluation of an orbital lesion can help in their early diagnosis, locate the origin of the disease, and improve the high mortality rate. Now, let us come to our case report. We have a 47 years old male who came to us with the chief complaint of a growth below and medial to left eye since last 9 months, along with pain and bleeding from the mass. The patient started having a growth over the inferior aspect of left eye, which was gradually progressive in nature, along with pain over the mass, and there was bleeding from the lesion as well as from the left nostril and nasal blockage since the beginning. The patient also gave history of generalized fatigue and unexplained weight loss since last 4 months. His past and family history were not significant. The patient lost his appetite since last 4 months. He had a disturbed sleep pattern due to the pain. He is a chronic alcoholic and tobacco chewer. So the first photos of the patient 8 years back and the second photo at the time of presentation. Coming to general physical examination, the patient was conscious, coherent, and cooperative at the time of examination with thin build and poor nourishment. He had two submental, one left submandibular, and one left upper jugular palpable neck lymph nodes. His vitals and systemic examination were within normal limit. There was a fleshy growth extending from the lateral wall of left nostril, and it was pushing the septum to the opposite side. As you can see in the picture, it was lobulated in shape, red in color, irregular margins, and bleeding was noted. A mass was also visible in the oral cavity, depressing the heart palate from above. His visual acuity in right eye was 6/9 and in left eye 6/24 with pinhole. Color vision was normal in both eye syringing was positive. On inspection, there was a mass over the inferior aspect of left eye, and there was upward pushing of the left orbit, and because of these, facial and ocular symmetry were lost. Coming to examination of periocular region, there was a fleshy burst or growth through the skin, 1 mm inframedial to the left medial punctum and extending along the malar prominence till the lateral one-third of the lower eyelid. As you can see here, it was lobulated in shape, red in color, irregular margins, roll-out edges, hard in consistency, immobile. There was a brownish black eschar with blood clot at one edge, and bleeding was noted from the mass. On palpation, it was tender. Mass could not be palpated separately from the medial half of maxillary bone and the inferior orbital margin. Extraocular movement ductions were normal as well as the versions. On slit lamp examination, there was grade 3 mechanical atrophy of left lower lid, and fundus examination showed choroidal folds as is visible here, and there was a nasal tilting of the vertically oval optic disc in left eye fundus due to stretching by the mass. So our provisional diagnosis was left eye sinoazo-orbital mass, possibly malignant for further evaluation. So these were the working DDs in our mind. It can be either a malignancy of left nose and sinuses, which was extending to left orbit, or it can simply be a basal cell carcinoma of the skin. Routine investigations were found to be normal. This is CT orbit axial scan, and it is showing hypodense exophytic lesion starting from inferior medial aspect of left orbit, which was pushing the orbit towards outside, and there was a midline shift. Also, there was a diffuse erosion of left ethmoid and maxillary sinus walls along with the left orbital walls, and calcification was noted. This is CT orbit coronal scan. As you can see here, extraocular muscle and optic nerve were free from the lesion. Incisional biopsy was carried out, and this is a histopathology report. And these are the magnified views showing tumor cells arranged in nests and papillary pattern with intercellular bridges. And this is a typical bizarre looking tumor cell with vesicular nuclei, prominent nucleoli, eosinophilic scant cytoplasm. These are the inflammatory cells in the stroma, hemorrhage within the blood vessel, mitotic figure, and necrosis. So it was suggestive of non-keratinizing squamous cell carcinoma. Immunohistochemistry showed poorly differentiated carcinoma favoring squamous origin. So our final diagnosis was poorly differentiated squamous cell carcinoma, probably non-keratinizing type of left maxillary and ethmoid sinuses extending to left nasal cavity and left orbit. Patient was treated symptomatically for pain relief when neoadjuvant chemotherapy first cycle was started. Now, this was the result after first cycle of chemo. As you can see, both the infraorbital and nasal mass decreased in size, and visual acuity was both eye 6/24 with pinhole 6/9. Now, coming to discussion, non-keratinizing squamous cell carcinoma of sinonasal tract is a rare entity arising from the malignant proliferating cells of the respiratory epithelium. The incidence of sinonasal tract malignancy itself is 2.6 per 1 lakh of Asian
1 minute
population,
left. 1 minute
out of
left.
which 15 to 20% of these are non-keratinizing type. The most common site being the maxillary antrum. Males develop at a younger age than the female, but prognosis is better in them. WHO classification also lists this variant of carcinoma with ribbon-like growth pattern, cytological atrophy, and lack of keratinization. As far our knowledge goes, only 6 case reports have been mentioned so far about this variant of carcinoma, and these are those 6 case reports. However, no case reports so far have mentioned orbital invasion and cervical lymphadenopathy at presentation, and this is how our case is a unique one. According to reports, advanced local disease worsens the prognosis and treatment depends on the tumor location and extent. Surgery is the main modality of treatment, but chemotherapy can be given as neoadjuvant therapy or postoperatively. This case report also emphasizes on the importance of the systemic examination in an orbital lesion. It also points towards delay in seeking medical attention due to the ongoing pandemic. So these are few case reports which shows that after COVID-19 pandemic, there were increased number of extensive tumors.
Time up. Time up.
Also, this data from our hospital also shows the same thing. Now, coming to conclusion, NKCA should be included as a DD of such aggressive sinonasal tract carcinoma. A thorough evaluation of all the system is of very much important, and imaging, histopathology, and immunohistochemistry can pinch to the diagnosis and can help in targeted management. These are my references. At last, where there is hope, there is life. So amidst all the chaos going on, please keep your hope alive and keep living. Thank you.
Yes, thank you. You can stop sharing now. Please, over to judges.
Dr. Banita,
Yes,
a sinus tumor invading orbit, what is the more common type? Which type is more common?
Squamous cell carcinoma, sir.
Squamous cell carcinoma. Incidence
Yes, sir.
Incidence, what is incidence?
Sir, total sinonasal tract carcinoma is 2.6 per 1 lakh population. Exact incidence of squamous cell carcinoma, I did not get, sir. But they say it is the most common type.
Okay. So next question for you is what you advise while doing CT scan in these patients?
Sir, I advise 2 mm cut section, axial and coronal scan, sir.
At what level? CT scan should be particular at what level in this case, sinus tumor with orbit?
Sir, at the level of this sinus, starting from the sinus, sir, I advise. I don't know, sir, exactly.
Okay. Over to Renu, ma'am.
Yes. Is there any difference in the prognosis of the two differential diagnoses in this tumor? Squamous cell carcinoma and the sinonasal carcinoma?
Ma'am, sinonasal carcinoma can be a DD of sinonasal carcinoma's one type variant is squamous cell carcinoma, ma'am. And it is having a worse prognosis, ma'am. If there is a locally invasive disease, then prognosis is bad, ma'am.
Okay, thank you.
Yes, sir.
Rupa, ma'am.
Yes.
Rupa, ma'am.
Any questions, ma'am?
Can you add some lines about recent mucormycosis?
Yes, ma'am. Actually, after this COVID-19 pandemic, ma'am, this mucormycosis has increased rampantly in India, ma'am. So it is mainly due to untreated diabetes mellitus, Then it is due to steroid use, tocilizumab use during the COVID-19 treatment, ma'am. So as well, a few days back in our hospital also we have diagnosed one case, ma'am. There was one
early diagnosis prevent mucormycosis.
Ma'am,
early diagnosis.
Ma'am,
We
I
can
didn't
save
get you.
the eye. We can save the eye.
In mucormycosis, yes, ma'am. Definitely, ma'am. You can save that.
Okay. Good.
Okay.
Okay.
Just a note to the judges.
Yeah.
Dr. Barnita, who just presented, got diagnosed as a COVID a day before. She is in quarantine and under treatment. We gave her option to present later, but then she very courageously said that she want to present today itself. And though she is in quarantine, she managed a presentation and she answered all the questions very well. She does need a pat on the back and the applaud from all the faculty and the judges and her colleagues that she is doing everything and even presenting when she is herself diagnosed as a COVID. Very well done, Dr. Barnita.
Yes.
We are very proud of you.
Congratulations and great work, Dr. Barnita.
Yes, very commendable. Very commendable.
Thank you so much, ma'am. Although I'm doing fine, ma'am, actually.
Okay.
Some
Take care, Barnita. Please
Yes.
take care.
Okay.
Sorry, ma'am.
Wish you very speedy recovery and well done.
Yes, ma'am. Yes, ma'am. Thank you, ma'am. Thank you so
Yes,
much.
yes. So we'll move ahead with the next presentation with Dr. Anujit Paul. In
Good evening,
between,
sir. Good evening, ma'am.
just a second. Dr. Sai Suchitra could not present because she has a COVID duty. She will be presenting next Sunday. So number 6 is not presenting. We are number 5 is not presenting. We are going to number 6 directly to Dr. Anujit Paul. You can start now.
Good evening. Am I audible?
Yeah.
Very much.
Good evening, sir. Good evening, ma'am. Good evening to the esteemed panel and my colleagues. I will be presenting a case report titled Basal Encephalocele with Morning Glory Syndrome presenting as chronic dacrocystitis. Morning Glory Syndrome is a congenital optic disc anomaly wherein we see a funnel-shaped excavation of the optic disc surrounded by a central tuft of gliosis and a white annulus of chorioretinal pigmentation with an abnormal vasculature surrounding the optic disc. In general, Morning Glory Syndrome has a well-established association with basal encephalocele and usually presents with midline craniofacial anomalies. Encephaloceles in general are congenital anomalies of the central nervous system through which a part of the brain herniates through, and they are also associated with Morning Glory Syndrome as well. We present a case that presented in our OPD of a 45-year-old female complaining of watery discharge in her left eye for the past 20 years. In her past history, she had a history of a lacrimal abscess 5 years back for which incision drainage was performed elsewhere. Her visual acuity in her right eye was perception of light, and in the left eye was 20/20. Our systemic examination revealed nothing significant. On examination of the eye, surface examination, there was orbital asymmetry, there was hypertelorism, there was a broad nasal bridge with a compressive soft tissue swelling in the inferior nasal aspect of the medial canthus on the left-hand side. Regurgitation test was performed, which was positive, and following which we did lacrimal syringing that confirmed the blockage of the left nasal lacrimal duct, whereas the right one was patent. Fundus examination of the right eye revealed a pale funnel-shaped excavation of the optic disc with central gliosis and arteriolar attenuation, and vessels were arranged like the form of a spokes of the wheel, and there was central sheathing and a concentric ring of pigment around the optic disc. Fundus examination of the left eye revealed nothing significant. We took up the patient for investigations and a CT brain was done, and as to our surprise, it revealed a bony defect in the floor of the anterior cranial fossa and the cribriform plate, which is marked with a white arrow on the image on the upper right-hand side. A portion of the frontal lobe was seen herniating through this defect into the anterior ethmoidal sinus and the medial canthal region. Subsequently, CT dacrocystography was performed, and the left lacrimal sac was displaced superiorly. Bilateral dehiscence of the proximal part of the nasolacrimal duct was also seen. With all this in mind, we took up the patient for bifrontal craniotomy with the help of the neurosurgical team and for excision of the encephalocele and for repairing the defect. And for repairing the defect, we use a tensor fascia lata graph, which you can see over here in the post-operative CT image. Following this entire repair, there was a notable resolution of the epiphora of the patient. Following which, an observant approach was chosen for the lacrimal sac pathology due to spontaneous remission of the epiphora and to avoid any inadvertent neurological sequelae that may result from intervention in an asymptomatic patient. Discussion. We all know that morning glory syndrome is associated with a plethora of ophthalmic findings, which may include persistent hyperplastic primary vitreous, primary pupillary remnants, aniridia, microphthalmos, foveal hypoplasia, lid hemangiomas, ciliary body cysts, Duane syndrome, and pre-retinal gliosis. Sometimes serous and rhegmatogenous retinal detachments have been reported as well. However, chronic dacrocystitis has not been reported, and it forms a conspicuous association in this patient with MGS, and this conjunction is of rare significance. Coming to encephaloceles, these are caused by a defect in the development of the calvarial bones and herniation of intracranial contents through them. Encephaloceles are classified as syncypital as well as basal. Morning glory syndrome has customarily been associated with basal encephaloceles, as we have seen with our case as well. Consistent reported features of encephalocele remain hypertelorism, a broad nasal root, compressive cystic mass in the nasal or the epipharyngeal region, all consistent with our findings. However, chronic dacrocystitis is an unprecedented accompaniment of MGS as well as basal encephalocele. We speculate that this has resulted from a mass effect of the encephalocele on the lacrimal drainage pathway on the left-hand side, or due to a dehiscence of the proximal part of the nasolacrimal duct.
1
So
minute left.
bilateral dehiscence of both nasolacrimal duct is noted in this patient, but this is quite a common preoperative finding. But the resolution of epiphora and repair of the encephalocele offers collaborative evidence. Therefore, neuroimaging may reveal an intricate relation between the herniated mass to the lacrimal sac. Various reports in literature have advocated surgical management of encephalocele to prevent the mass effect, and have also recommended an endoscopic or transsphenoidal approach. In our case, we chose a bifrontal craniotomy with excision of the herniating mass and anterior cranial fossa repair, which resulted in a gratifying outcome with resolution of epiphora and resolution of symptoms. So in conclusion, MGS may be associated with basal encephalocele, and in our case is contralateral. Chronic dacrocystitis is a rare synchronous manifestation. MGS coupled with contralateral basal encephalocele is an unusual entity, and chronic dacrocystitis forms a discernible association with MGS in our region. In this case, thank you very much.
Over to the judges. Dr. Anujit, please stop sharing your.
Hello.
Yes,
Dr.
sir.
Anujit, what are the non-ocular findings in morning glory syndrome? What can be non-ocular finding in morning glory syndrome?
Sir, as I mentioned, it has various associations and is associated with calvarial defects. One of them is corpus callosum agenesis. One of them are encephaloceles, as we have reported. Sometimes it may be associated with regression of the calvarian bones as well, sir.
Okay. What is the differential diagnosis of morning glory disc?
So the differential diagnosis of morning glory disc can be any other congenital optic disc anomaly. For example, optic disc hypoplasia, tilted disc syndrome. Sir,
any specific which can be misdiagnosed as morning glory? That can be misdiagnosed as morning glory.
Sir, optic disc coloboma.
Okay. Over to Renu ma'am.
So why is it important to have this differential with coloboma? Are there any systemic features which are more common in colobomas and have to be ruled out? Do you know the acronym CHARGE?
No. Yes, ma'am.
There's an acronym CHARGE, no, with the manifestations of coloboma of the optic disc. So why is this? What is the reason for this morning glory syndrome to happen?
Ma'am, it is a type of optic disc the vessels that form around the optic disc are splayed, and they result in a sort of a spokes of the wheel pattern. And other than that, the optic disc is larger in size and does not conform to its normal size and shape.
Do you know of the
And
Moya Moya syndrome associated with this?
Yes, ma'am.
What is that?
Ma'am, it is, ma'am, a vascular disorder, ma'am, involving the carotid artery, which result in reducing blood supply to the basal ganglia, and it's seen as a puff of smoke appearance in neuroimaging.
Yes. Okay.
Over to Rupa, ma'am.
Yes, so what's the message you wanted to give to the other peoples? And what about the any other systemic association? Just now, madam discussed one syndrome. What are the any other syndrome which is associated, or any other systemic disease which is related to the chronic disease, dacrocystitis?
The message that I would like to give is for a patient presenting with chronic dacrocystitis for long-standing duration with no resolution, maybe a closer look at the fundus would give us an idea for the dacrocystitis, and maybe neuroimaging may give us an indication of a space-occupying lesion or a mass, or in this case, an encephalocele, which is the actual cause of dacrocystitis and not a lacrimal gland or duct pathology by itself, ma'am.
Okay, good.
Okay, over to Dr. Sumit.
Any more questions from the judges?
No.
Okay, sir. So we'll proceed with the next presenter.
Yeah.
Dr. Maya, who will be presenting on ocular surface melanoma. Dr. Maya, please start your presentation.
Good evening, everyone. I'm Dr. Maya Paul M. I'm here to present a case of ocular surface melanoma, a rare association of xeroderma pigmentosa. Xeroderma pigmentosa is a rare autosomal recessive disorder caused by defective repair of DNA damage caused by UV light. Reported incidence of xeroderma pigmentosa in US and Europe are 1 in 250,000 population, and Japan is slightly higher. Data concerning Indian incidence is not known. Till date, 37 unrelated families with patients were reported in India, mostly from the southern part, according to ICMR data 2015. Malignant melanoma is a malignant neoplasm of epidermal melanocytes. The order of frequency of ocular neoplasms in xeroderma pigmentosa are SCC, BCC, fibrosarcoma, and rarely melanoma. Conjunctival melanoma is by itself a rare tumor, constituting 2 to 3% of ocular melanomas, extremely rare association of xeroderma pigmentosa. A 17-year-old female came to our department with she was normal 4 months back, and she noticed a brownish.
When she told me, I knew that Moya Moya is a thing, but it did not strike. And it said Moya Moya, I was like, yes, it is something disorder.
Excuse me. She noticed a brownish black discoloration in the temporal part of her left eye. Later, at the same location, a brownish black mass started growing.
Like puff smoke appearance. And like, what is the word? Puff smoke. I've seen it, and I was thinking,
excuse me, I can hear some voices.
This is something I learned as a resident. When you're seeing some sort of damage in the ocular surface or something,
she noticed a sudden increase.
Write the word do CT or MRI. What if you're wrong?
Just a minute, Dr. Maya. There is some cross connection.
Please look into.
Yeah. Technical team, can you see who is unmute and what is happening? Abhijit Paul.
And then I ultimately
mute yourself. Host, can you mute Anujit Paul? Host. Okay. Anujit Paul, you need to mute yourself. Okay. Dr. Maya, I think you can restart.
Thank you, sir.
Yeah.
A 17-year-old female presented to our department. She was apparently normal 4 months back. She noticed a brownish black discoloration in temporal part of her left eye. Later, at the same location, a brownish black mass started growing. She noticed a sudden increase in size of the lesion spreading to the whole eye in past 1 month with complete loss of vision, attained the present size in 4 months. There was associated pain, no bleeding, and no loss of weight. Past history, she is a non-case of xeroderma pigmentosa. No history of any previous malignancies, biopsies, or surgeries in the past. Sun exposure was not restricted, or no sun-blocking agents were used. Family history, non-consanguineous marriage, no history of any diagnosed malignancies in the family. One sister is suffering from xeroderma pigmentosa. Menstrual history normal. General physical examination, there were multiple pigmented patchy lesions over skin, face, neck, and limbs. One cervical lymph node were palpable. Vitals and system examination were normal. On ocular examination, in the right eye, a conjunctival nevus was present, which was about 2 to 3 mm in size temporally. Rest of the anterior segment examination and fundus were normal with visual acuity 6/6. Left eye was PL negative. On inspection of the left eye, there was a lesion in the left eye with marked edema of upper and lower lids. A fleshy growth in the left eye noted, which is 3.2 into 2 centimeter in size, involving whole ocular surface. It is lobulated, brownish black pigmented, and lids were edematous. So we came to a provisional diagnosis of pigmented OSSN with orbital extension, since it was far more common in xeroderma pigmentosa. We kept our differential diagnosis of malignant melanoma of conjunctiva with orbital extension. We proceeded with routine blood investigations, which are normal. The CT orbit in the axial section showed a marked periorbital swelling with edema extending up to equator of the globe. A surgery was performed, left eye subtotal excentration. This is a POD3 picture. And to our surprise, the histopathology showed it was malignant melanoma of conjunctiva. Here you can see the conjunctival epithelium, and below what we see is a neoplasm showing spindle cells with interlacing fascicles. This is a more close, high power view, and this showing the marked atypia of the cells and the pigment intracellularly, as well as the chromatin clumps in the nucleus. This is a scanner view of the same, showing scleral infiltration. So metastasis workup was done by the oncologist. CT chest, CT neck, CT abdomen, and MRI brain. The CT neck showed lymph nodes. So we came to a final diagnosis of malignant melanoma of conjunctiva in xeroderma pigmentosa. AGCC T staging clinical was T3C, pathological P-T3. FNAC of cervical lymph nodes level 2 on the left side was planned, and AGCC M staging is M0. Treatment, patient was referred to an oncologist for further management, started on adjuvant chemotherapy, oral temozolomide, advised sun protection, and advised regarding early presentation if any lesion developed, and regular follow-up. So why this case?
1 minute left.
Xeroderma pigmentosa increases the risk of skin melanoma of more than 2,000 folds over 20 years of age. Ocular melanoma is a rare association of xeroderma pigmentosa. Conjunctival melanoma by itself is a rare malignancy and an extremely rare association of xeroderma pigmentosa. So we present such a case. Prevention of this neoplasms lies in evidence of UV radiation exposure from sunlight. Many of the patients, including our patient, had little knowledge about the disease and importance of UV radiation. She is one among the neglected girl child from poverty-stricken marginalized society. Never consulted a doctor regarding her skin lesions. This emphasizes the importance of health assessment drives at grassroots level. As the corona pandemic was worsening, an intensive lockdown was enforced with strict travel bans to control the epidemic. So this had a direct impact on ocular oncology practice. Since the patient was from a remote place, she could not approach appropriate healthcare at right time. This costed her patient's eye. This is the data from our hospital. The enucleation or excision performed for malignant tumors, except for RB. In the pre-lockdown period, we can see 4 cases in 14 months, whereas 6 cases in 10 months were seen post-lockdown. A sharp increase of additional 110% or 2.1 times increase in enucleation or excision for malignant tumors of the eye compared to the pre-COVID times. These are my references. Thank you.
Yeah, thank you, Dr. Maya. You can stop sharing screen now. Over to judges.
Good presentation, Dr. Maya.
Thank you, sir.
Do you know what is the survival rate of this tumor?
The survival rate actually depends upon the metastasis and local metastasis. So here,
so what is the historical survival rate after 5 years and 3 years?
Of 3-year rate, it is about 20% death. 80% survival rate, sir. And 5 years, it is about 70%, sir. And if there is a local recurrence, it reduces survival rate, sir. Like in 2 years, 40% death can the death rate is 40%, sir. In
Okay,
lymph
your
node,
lead to second. So your lead to second question again. What is the recurrence rate?
recurrence rate.
Yeah.
No,
Yeah.
recurrence rate is 40%, sir, in 2 years.
Okay. So what is the incidence of tumor? You are told in ocular melanoma it is around 5%. What is incidence in all tumors of the body?
I don't know, sir.
Okay. Okay. ठीक है. Over to Renu ma'am.
Yes. What kind of inheritance is there in this condition?
Autosomal recessive, ma'am, but we couldn't find that in this case.
All right. And what are the other ocular findings other than tumors? What other ocular findings can be there?
Usually in xeroderma pigmentosa ocular, usually it will be irritation of eyes and all, but as in case of tumors, it usually will be SCC, BCC.
No, other than tumors.
It will be ocular irritations. That is the most common one.
Yes, and lid deformities also, along with your lid position deformities, corneal deformities also. Okay, thank you.
Over to Rupa ma'am.
Yes. What is differential diagnosis of such type of tumors?
Ma'am, since xeroderma pigmentosa, it's OSSN more common, so we kept it as pigmented OSSN, ma'am, since it was blackish brown pigmented. So.
Okay. Okay.
Okay.
Good.
Okay, Dr. Sumit.
If judges permit, I would like to ask a question.
Yeah.
Nice presentation, ma'am. I just wanted to ask, you found scleral infiltration on your histopathology. So your oncologist did not advise any EBRT or radiation to the orbit?
No, they didn't advise. Actually, we planned for a FNAC of lymph nodes. Other than that, they've started on temozolomide for 6 weeks to counter any CNS metastasis to prevent. Other than that, no.
Okay. And what was the
And
last
if
follow-up?
they're planned for if any local recurrence is there, radiotherapy is planned, sir, in the next follow-up.
It's better if you give prior to recurrence, because that can prevent recurrence instead of waiting for it. And
Yes,
secondly, what was the last follow-up? Like how much duration from the surgery?
2 months, 1 month after that, sir. But after that, the patient couldn't come. She went back to her state. So,
So if you can contact her back, it would be good for her. Anyway, nice presentation, nice case. You can make a series of this. Basically, there are very less cases reported with the xeroderma pigmentosa with conjunctival tumors. And if you can just compile a case series and present, that would be good. So we'll move ahead with the next, Dr. Karishma Shah. She will be talking on comparison of water drinking test and a modified diurnal tension curve. You can make it full screen and start presenting, Dr. Karishma.
Good evening, everyone. Am I audible?
Yeah.
Yeah, thank you for this opportunity. So I will be talking about the comparison of water drinking test and modified diurnal tension curve, results of these two tests in primary open angle glaucoma patients on latanoprost and bimetoprost. We all know that the diagnosis of primary open angle glaucoma is based on the measurement of IOP with Goldman's, visualization of the optic disc, and evaluation of the visual field. Now, the peaks and diurnal variation of IOP have been shown as risk factors for glaucomatous progression. The diurnal tension curve, in this we assess IOP in relationship to either as a risk factor for the development or progression of glaucoma, or for the achievement of a target pressure which may direct a therapeutic change. So as we see, normally the peak IOP occurs in the early morning at around 7 a.m. and by mid morning it dips down. Now the modified or the office diurnal tension curve is wherein IOP is measured every 2 to 3 hours only during the office hours, which is like from 8 to 5 or 9 to 5. And this may provide better information regarding the IOP profile than a single IOP measurement. The other test which I did is the water drinking test. We all know it is a provocative test wherein the patient is asked to drink around 1 liter of water over a period of 5 to 10 minutes. And after that, after 15 minutes after drinking water, the IOP is measured at 15 minutes intervals. So we see that the point of increased resistance is generally near the trabecular meshwork. This evaluates the eye's ability to deal with a transient IOP elevation by observing how high the IOP rises and how long it takes to return to baseline. Normally, a rise of 6 to 8 millimeter mercury is considered positive for a diagnosis of glaucoma. This is how it was as a provocative test. The main reason, the aim of water drinking test is to stress the trabecular meshwork by increasing the episcleral venous pressure. Now, in our study, we compared two drugs. One is bimatoprost 0.03% and the second is latanoprost 0.005%. Both of these are prostaglandin analogs, which increase the uveoscleral pathway. But bimatoprost is also known to contribute to the conventional trabecular pathway. The aims of our study, we compared the peak IOP and the rise of IOP from baseline during both these tests achieved during the use of both the prostaglandins, bimatoprost and latanoprost, in 2 eyes of the same patient with symmetrical damage. And then we analyzed the efficacy of both drugs in blunting the IOP spike. We also wanted to establish the importance of the water drinking test in the present day scenario. So we had 31 patients, 62 eyes. Inclusion criteria were basically patients with bilateral symmetric mild to moderate POAG who had similar IOPs in both eyes to start with and who were controlled on monotherapy prior to our intervention. Exclusion criteria were all the above. All of them underwent a basic history, best corrected visual acuity, slit lamp biomicroscopy, gonioscopy, disc examination with a +78 diopter lens, IOP with a Goldman's applanation tonometer, central corneal thickness, and visual field testing. All these subjects were started on bimatoprost in the right eye and latanoprost in the left eye, and they were followed up after 3 weeks, which is when we did the modified diurnal tension curve. So the IOP was measured at 9 a.m., 11 a.m., 1 p.m., 3 p.m., and 5 p.m. And then we did the water drinking test. So basically, most of our patients were in the age group of 51 to 60 years, and most of them were males. The IOP, so when we checked the IOP at different time intervals in the modified diurnal tension curve, there was not, there was no definitive peak at a particular time. It was more at 5 p.m., but it was not very conclusive. On the other hand, the water drinking test showed a definitive peak at around 45 minutes to 60 minutes in both the eyes. And when we check the difference between the peak and the baseline IOP with the modified diurnal tension curve, the difference, so there was a significant difference when we checked the right eye, which was on bimatoprost, and the left eye on latanoprost, and the fluctuation was lesser in the right eye. And the same thing we saw even with the water drinking test, that the fluctuation was lesser in the right eye. Here, as you can see, it is 4.93, and in the left eye, it was 6.45. The IOP peaks. So basically, there were peaks. The IOP peaked during both the tests, but the peaks of both did not correspond. And the peak of the water drinking test was always more than
1 minute left.
So basically, we concluded that the right eye on bimatoprost showed a lower peak IOP, a lower difference between the peak and the baseline IOP in both the tests, and hence bimatoprost has a more IOP lowering efficacy. Water drinking test is not a replacement, but it is a good alternative to the 24-hour diurnal tension curve, and it is useful to assess the status of the eye's outflow facility and to determine the IOP peaks and fluctuations. This could be routinely missed in the routine clinic IOP measurements. It had a few limitations. We checked the IOP only after 9 a.m., but most IOP peaks occur between 5 and 7 a.m. A larger sample size could have been more beneficial, and also documenting perimetric damage for prognostic outcome would have helped. I have a few recommendations. We can compare the efficacy of different IOP lowering drugs with water drinking test as a stress test to question the facility of outflow. And it can use to determine the IOP peaks in apparently controlled patients with documented disc damage in lieu of facility or logistics for a full diurnal record. It can also be used as an additional tool to identify progressors despite good IOP control. Thank you.
You can stop your presentation. Yeah, over to judges.
Yes, good presentation, Karishma.
Thank you, sir.
So, what precautions will you take while doing water drinking test?
So actually, it is not advisable in patients who are prone to fluid overload conditions, CCF patients and lung failure patients. And we advise them not to drink water for not drink too much water, at least before 2 hours before we start the test.
This was a supervised test, or the patient has been done by themselves?
No, sir, supervised in the OPD.
Okay. How much was the time lag between water drinking test and this diurnal test?
Diurnal test was done from the whole day, 5 readings, and after the diurnal test, the water drinking test was done.
So that is my question. After how much time?
After around 15 minutes, I started the water drinking test on the same day.
On the same day?
Yes, after the last reading of the diurnal tension. After the last reading, I did the water drinking test.
So water drinking test is done at one time only in a day.
Sir. Yes, sir.
Okay. Over to Renu, ma'am.
So what is the best time to do a water drinking test actually?
Ma'am, as far as all the studies which have been done previously, they have all been done in this fashion. Like the water drinking test was done after the diurnal tension. There's no specific time mentioned in studies, at least, to do the water drinking test.
And can the sudden intake of water, can that cause damage in a predisposed person?
Yes, ma'am. But this study was on open angle patients. So
yes, even that can give a sudden spike, no? If the outflow is hampered, can that give rise to any damage to the eye?
Yes, ma'am, can. If there's a sudden rise.
It was consent taken for this?
But because they were on therapy for 3 weeks before we did the test, so their pressures did not rise too much. Also because they were on prostaglandin analogs, which are anyway known to increase the outflow facility. The water drinking test has always shown lower peaks in patients on prostaglandin analogs. The peaks are higher, in fact, if they are on beta blockers or any other class of anti-glaucoma medications.
Okay, thank you.
Was it a clinical trial?
Yes, sir.
Karishma?
Yes,
was
sir.
it clinical trial?
It was, yes, I mean, it was a study which we did, not a registered trial.
What do you mean by clinical trial? What is the study?
It was it was not.
Okay, okay. Have you taken consent before doing
Yes,
this
sir.
test?
Yes, sir. Informed consent was taken. The patients were explained about the procedure.
You have mentioned in your study?
Sir?
Have you mentioned in your study consent about the consent?
In my study, I have mentioned, sir. In the PPT, I have not mentioned. They were given a patient-informed consent, and they were made to sign up.
So you should mention in PPT, na, so that we can understand.
Yes, sir. Yes, sir.
Okay. Over to Rupa, ma'am.
Hi, Karishma.
Hello.
So what about the low tension glaucoma? Is it helpful in low tension glaucoma cases, this water drinking test and these drug studies?
Yes, ma'am, because low tension glaucoma, usually we feel they are low tension because we mention only one IOP in the clinic. But this can detect peaks that are not detected in the routine OPD routine OPD.
Okay.
So which may appear to be low tension may actually have peaks which are not detected. So
okay. So it is means useful.
Yes, ma'am.
Low tension glaucoma. Okay, good.
Okay, over to Sumit, Dr. Sumit.
Okay, yes. So with all the due permission from the judges, we have finished the all talks of this session. But Dr. Gaurav was supposed to present in the last session in the Kansky Hall, but there was some technical glitch because of which he could not present. So if with the judges' permit, can he present in this session?
Yeah.
Yes.
Okay. Ma'am, is it fine?
Yes, yes,
Yes.
please go ahead.
Okay. Dr. Gaurav, you can start presenting.
Yes, sir. Sir, am I audible, sir?
Very much. You are very much audible. Yeah.
Thank you, sir.
Yes.
Good evening, everybody. I'll be talking about intraocular ossification and incidental finding during evisceration. Intraocular bone formation is a rare phenomenon. However, osseous metaplasia may occur in phthisis bulbi, usually in cases who are having long-standing history of trauma or any surgical intervention. Hereby, we report a case series of 6 patients with extensive vitreous ossification. All the patients underwent a preoperative B scan and histopathological examination revealing bone formation. This young man presented to the OPD with history of injury to the left eye almost 10 years back and desiring cosmetic correction. The right eye was within normal limits. The left eye was phthisis bulbi. It denied any perception of light and there was slight proptosis. On CT imaging, there was a hyperdense foci in the posterior segment, which was likely to be calcification. The patient was planned for a 4-petal evisceration with a polymethyl methacrylate implant. On the intra finding was a osseous vitreous that was found. This gentleman came to the OPD with complaints of disfigurement of the left eye and also gave history of blunt trauma to the left eye almost 20 years back, desiring cosmetic correction. Was again planned for a 4-petal evisceration with a non-integrated PMMA implant. After separation of the uveal contents, there was a gray to brown hard irregular mass which clinically appeared to be bone. On histopathological examination of the eviscerated contents, there was extensive loss of architecture and normal distortion of the normal ocular histology. The hard mass revealed a mature compact lamellar bone with adipose tissue ruling out any differentials like foreign body or tumors. Similar case of this lady who presented again to the OPD with the history of trauma almost 10 years back, planned for evisceration, showed intraoperative ossified vitreous. This young man presented to the OPD with complaints of pain in the right eye. He had documents of some right eye retinal band buckle surgery and silicone oil implantation, desiring cosmetic correction. The anterior segment examination of the right eye revealed band-shaped keratopathy, corneal opacification, due to which the anterior chamber details were not visible. The left eye was within normal limits. The B scan of the right eye showed a short anterior posterior diameter and hyperreflective echo suggestive of calcification. Was planned for a 4-petal evisceration. Similarly, 2 patients undergoing a posterior segment surgery for retinal detachment and silicone oil implantation with band buckle of history of around 10 years back, presenting with phthisis bulbi, undergoing 4-petal evisceration with custom-made prosthesis for cosmetic correction. The discussion, the incidence of intraocular osseous metaplasia remains to be approximately around 5% of all the enucleated eyes in 2 large studies, trauma being the most common stimulus. The associations can be embryological, organizational, metaplastic. The determined cellular precursors for bone formation are present in the bone marrow. However, the retinal pigment epithelium is a pluripotent cell layer in which which can differentiate into fibroblast or osteoblast depending on the inducible agents, which can lead to a pre-retinal, subretinal ossification. However, the process of bone formation can be a chronic end-stage disease of ocular inflammation, release of interleukins, stimulation of the RPE layer, laying down of bone matrix by osteoprogenitor cells, and primary spongy bone formation finally being replaced by a lamellar bone. This study supports our finding of intraocular ossification being an uncommon calcium deposition process associated with trauma, chronic inflammation, tumor, and long-standing retinal detachment. In summary, intraocular osseous metaplasia is rare. Finkelstein and Bovnik enucleated around 2,400 eyes, out of which only 119 showed calcification. The cause and source of bone formation in each and every individual case can vary. In our case series, the association was trauma and posterior segment intervention, surgical intervention, both having a history of almost more than 10 years, leading to phthisis bulbi and intraocular disorganization. The take-home message: the knowledge of posterior segment calcification is important for keeping in mind the differentials in posterior pole affections. These could be mistaken for an intraocular foreign body or malignancy. A timely silicone oil removal is advocated, and histopathological evaluation is mandatory
1
for all
minute
the
left.
and enucleated specimen to confirm the presence of any immature or differentiated tissues. Thank you.
Dr. Gaurav, please stop sharing us. Over to the judges.
Good presentation, Dr. Gaurav.
Thank you, sir.
Yes, it is a nice and unique study you have presented. So, any more references you have with this study?
Sir, there was one study, with the largest study that I already have cited, Finkelstein and Bovnik. And there was a similar study done by Dr. Honavar and Mehbugati, in which they had histopathologically, out of 151 enucleated eyes, they had seen only 8 eyes in which there was calcification that was present. There was one more study that was done by Monsleys and et al., and trying to find out as to what kind of ocular ossification can lead to due to which insult. So they found out that a compact bone can be seen in cases which were giving history of trauma, and a spongy bone can be found in patients who are giving any kind of history of post-inflammatory disorder or any kind of pathology.
Excellent, excellent. Over to Renu ma'am.
Thank you, sir.
You have done evisceration in these cases.
Yes, ma'am.
Have you come across any other series of eviscerations done where you have this? You've quoted the enucleations.
Yes, ma'am. There was only one case that I came across. There was one study that was done in South Asia, in which they have only cited one female who underwent evisceration and was around 22-year-old female and having history of trauma.
Okay.
Yes, ma'am.
Yeah.
Over to Rupa ma'am. Rupa ma'am.
Good presentation. No question, please.
Thank you. Thank you.
Okay. Dr. Dia, please share your first slide so that we can know your details.
Yes,
because
sir.
we don't have a detail.
Sir, it's Dr. Gaurav Patil presenting a case of.
He can share just first slide only.
Yeah, just show your title.
Yes. So that we can take the screenshot and share it.
Yes, sir.
Okay.
Yes,
Thank you,
sir.
Sumit.
Yes, thank you, sir. Thank you, ma'am. Thank you, Gaurav, and thank you all the participants
Thank you,
for presenting and staying with us till long last session of the hall. Thank you, judges. We can't thank you enough for giving your time and being with us and having such an interactive discussion. I thank you on behalf of MOS and BOA. And I request you that once the mark sheets are ready, you can just take a snapshot and send it on the group that we have created, so that we can compile all the marks and declare the winner of the session, who will be presenting on 30th of May in a finals.
Yes. Thank you so much to Sumit, and thank you so much, Dr. Lahane sir, respected Lahane sir, for giving us this good opportunity to be here at the judges. Thank you so much.
Yes, thank you, sir. Thank you,
Thank you,
everyone.
Sumit. Thank you so much. Just one day prior, I came to know, and it's very, very good. Very good. I like it.
Yes, thank you so much, ma'am. Thank you for making it.
Yes.
Yes,
Thanks
ma'am.
a lot for including
Love
me.
you to all.
Thanks a lot.
Love
Yes,
you to all.
sir. Yes,
Yeah.
yes. Okay. Good day, ma'am. Bye.
Yeah. Thank you.
Thank you. Sumit, can you take one screenshot? Sumit. I think he has stopped. He has Okay, ma'am. He has stopped. I think he has stopped.
ओके दराडे कसे आहात तुम्ही?
Yes, छान आहे एकदम मॅडम. एकदम मस्त चालू आहे बीजे मेडिकल कॉलेज.
हो ना?
Yes,
अरे
yes, yes.
मला
चांगलं
त्यांनी
आहे.
कालच स्मितनी फोन केला. तर मी म्हटलं
Okay,
चला.
ma'am.
ओके ओके
Okay.
बाय भेटूयात नंतर. ओके
Yes,
बाय.
bye. See you. Thank you
Bye.
so much. Bye. See you once
Bye.
again.
Bye.
Thank you. Bye.
मैंने लास्ट में ठीक बोला था मैंने कल ये आई केम टू नो वन दैट मैंने कहा इट्स वेरी गुड बोला ना और क्या बोला एंड बैठ के क्या नहीं आई लाइक इट बोला ना ठीक है ना ऐसा बोला था इट्स वेरी गुड सेशन बोला